for OSIT, Module 4 Practical Application, Module 5 Hands-on Practice, Module 6 Professional and Ethical Consideration, Course Delivery and Target Audience. What is oral motor and sensory integration? Oral motor and sensory integration involves coordination of sensory input from the mouth. The oral motor output of the muscle involved in speech, swallowing, and chewing. Oral sensory processing. The oral pharyngeal and laryngeal structure are lined with mucosa, which have sensory receptors in that allows us to recognize information like taste buds on the tongue offer a vast array of sensory modalities for a bolus to stimulate includes general sensation, that is touch and pressure, thermal sensation, that is temperature, chemical sensitivity, nociception, vibrotactile sensation, oral stereognosis, proprioception, and two-point discrimination. Furthermore, change. Furthermore, periodontinium receptors provide information about the size and hardness of the object between the teeth. Our brain receives further proprioceptive input from the joint of the jaw as we bite and chew on the food with different types of resistance. Also, how we move different articulation to the position them to articulate various sounds. Tactile sensitivity, taste, temperature, and proprioception are the important part of it. Now, problem with oral sensory processing, that is oral hypersensitivity and oral hyposensitivity. Over responsive or have increased sensitivity to oral input, that is resistance to sensory experience like trying new foods or brushing their teeth or gag easily. Oral hyposensitivity, decreased sensitivity to oral sensory input. Example, mouthing objects or chew on their clothes, grinding their teeth in an effort to provide additional proprioceptive input. Introduction to oral praxis. Oral praxis refers to the ability to coordinate and control oral and facial movement in a smooth sequential manner. It is a key aspect of motor planning and involves the coordination of muscle in the mouth, lip, tongue, and face to perform tasks such as eating, speaking, and facial expression. This skill is crucial for various functions like chewing, swallowing, speaking, making facial expression, blowing air for tasks like blowing bubbles, and imitating oral movements. Now, tactile oral praxis sensation, tactile sensation, proprioceptive feedback, oral sensation, neurological responses, emotional and social sensation. Engaging in oral motor activities such as chewing, sucking, or moving the tongue stimulates the sensitive nerve ending in the mouth, tongue, and lips, leading to the various tactile sensation. Proprioceptive feedback. Oral praxis also involve proprioception, which is body sense of the position and movement. Feedback about the position of your tongue and the pressure of your lip helping to coordinate movement effectively. Oral sensation, speaking or eating different sensation can arise such as vibration of sound produced to the different taste and feeding associated with the food textures. Emotional and social sensation activities involving speech can also evoke emotional responses such as joy from successful communication or anxiety from difficulty in speaking. Importance of oral praxis. Speech development. It is essential for coordinating the movement of lip, tongue, and jaw required to produce sound and articulate words. Effective oral praxis contributes clear speech and better communication skills. Feeding and eating, oral motor skills are vital for chewing, swallowing, and managing food in the mouth. Proper oral praxis helps to prevent feeding difficulties and ensure safe swallowing. Social interaction and facial expression, ability to control facial muscle helps in non-verbal communication, including expressing emotion, which is important for social cues. Introduction to feeding reflexes. Infants are born with reflexes that assist in feeding until they can perform movement on their own. Reflexes ensure successful feeding and safety during the early stages of life. Seven primitive reflexes are involved in feeding, with most integrating in the first year of life. Two reflexes, swallowing and gag reflex, persist throughout the life. Keys reflexes that supports feeding, that is rooting reflex, baby turns towards stimulation on the cheek to locate nipple, disappear by 4 to 6 months. Sucking reflex triggered by touch baby starts sucking for feeding integrates by 4 to 6 months. Swallowing reflex allows baby to safely swallow during feeds, continuous throughout the life. Gag reflex protects the choking by triggering the gag when the throat is stimulated and persists throughout the life. Additional reflexes. Palmar grasp reflects baby grasp object placed in the palm, aids in latch, integrates by 4 to 6 months. Moro reflex, startle response can impact feeding positioning, integrates by 4 to 6 months. Babkin reflex, baby opens mouth when both palm and pressed role in feeding, unclear. Now, oral motor control and coordination is important part for feeding and speech skills. Feeding and swallowing skills like sucking, biting and chewing with speech skills, tongue movement, lip closure and jaw control with coordination. Now, when to consider OSIT? Excessive drooling or mouth breathing, unclear speech, difficulty with chewing or swallowing, sensitivity to certain food texture or temperatures, poor oral motor skills such as lip closure or tongue movement, challenges with self feeding or mealtime behaviors. Now, who are the targeted population? Development delays, children with autism spectrum disorder, children with cerebral palsy and Down syndrome, neurological disorders, head and neck cancer, and stroke. To further continue, I'll invite Ms. Sana Zeb Sheikh on the dais to introduce what is oral motor sensory and integration therapy. Thank you.
A very good morning to all of you present here. I'm been privileged by the Speech Gears team and OTCon to come and speak here as a speech language pathologist. I've been practicing with Speech Gears since 2 years, but it's my 13 years of experience which we brought me close to this particular company because of the tools which we use. Now, in order to procure these tools, it's very important that all of us learn how to use this tool. And that's the reason why we have come up with a course, which is Introduction to Oral Motor Sensory Integration Therapy. So, before purchasing any tool or any product, it's important for us to understand how is it going to be helpful. So this formal course will help not only the occupational therapist but also the speech language therapist, because both of us, we are all friends. I'm a speech language pathologist, but I cannot function without an occupational therapist. So, with 13 to 14 years of my practice, this is the recent 2 years which I've got a hands on, with using these tools, and I've seen a lot of changes in the population of sensory processing disorders, of course, neurological conditions where speech and swallowing was also involved. So let's study this morning in the state of Goa a new type of training which the company Speech Gears have come up with. So let me explain to you what is oral motor sensory integration therapy. It's basically a tool based comprehensive training course which involves understanding of how sensory input from the mouth and face affects the motor function and how these systems work together. Now, sensory motor integration is primarily required to improve the oral vegetative functions, reduce the tactile and the gustatory issues. This specialized form of therapy focuses on improving an individual's ability to process and respond to sensory and motor information received through the mouth. So, if there is a speech delay or if there are feeding and swallowing related issues in children as well as adults, we observe weakness and flaccidity of the musculature. Due to the reduced sensation, there's a faded muscle memory and an impaired regulation. So, in such cases, neural residual functions need to be reactivated. And that's the reason why oral sensory motor integration therapy has come into picture, because we are using different types of tools to actually work on these challenges. So let's see what are the benefits of these speech gear tools. It increases awareness of the oral sensations, addressing the sensitivities. By sensitivities, I mean the hyper and the hyposensitivities, the ability to promote sensory exploration with respect to taste, textures, improve muscle strength and coordination, facilitate better oral motor muscular control. So here are the course objectives. We understand the OSIT first. By this, we explore the theoretical foundations of the oromotor and sensory integration and its role in speech, feeding, and swallowing. We learn about the speech gear tools, how we gain knowledge, and how evidence based practiced applications can be done using these tools. We develop practical skills to acquire practical skills for assessing and treating the oromotor and sensory challenges in our cases. Also, to create individualized therapy plans, learn to create individualized therapy plan by selecting appropriate tools and explore research. Examine the research supporting the efficacy of oral motor sensory integration therapy in using the speech gears tools. So, we have tried to divide this course into 6 modules, which will help us understand the use of tools in terms of assessment and treatment. So, the first module, it says the foundation of oral motor and sensory integration therapy. So, first we are going to explain what is OSIT, the definitions, the principles, the theoretical framework, the connection between the sensory input, motor output, and speech and feeding, the anatomy and physiology, a brush up of all this to understand this, the basic structures of which are involved in feeding as well as speech, which involves tongues, lip, jaw, palate and pharynx, sensory motor pathways which are involved, and study about the common types of disorders and challenges where we can use these tools. In speech sound disorders like apraxia, dysarthria, swallowing difficulties like dysphagia, sensory processing disorders wherein hyper and hyposensitivities in the oral musculature are a challenge, and of course the neurological conditions like Down syndrome, cerebral palsy, autism spectrum. Then we look at the module 2, which is the introduction of the speech gear tools. Now, in introduction, we would first see the overview. What are the speech gear tools? We will explain you all the types of tools which are used. For example, the orotube, the jaw bite, the hickey, the talk tip, and the purpose of these tools. Then selecting the right tool is very important in dealing with cases. So matching the tools to the individual needs with respect to the age and the disorder is very important. And also we'll be explaining you about the safety and hygiene of these tools. Then we come to the module 3. The techniques and strategies of oromotor sensory integration therapy, how the sensory stimulation techniques will improve the tactile, proprioceptive, and thermal stimulation, will help desensitize the oral hypersensitivities, the motor exercises which are important for strength and coordination of the muscles of the lips, jaw, and tongue, and improving the range of motion and the precision, and integrating both the sensory and motor skills together. So we are combining the sensory input with the motor task to help in the motor tasks like blowing, sucking, chewing, biting, swallowing, and transitioning from the non-speech activities to the speech activities. Then we can look at the module 4, which is assessment. It's a very, very important part of the therapy and the training, that you need to do a proper assessment using a standardized informal measures. Also, there are achievable goals which need to be notified in order to use these tools. So it's important that we do the thorough detailed assessment using the following tests. Then we create individualized therapy plans. We tailor the activities incorporating the tools and develop personalized plans. So that will also be a part of the training in the module 4. The case studies, like we discussed, it's very important that we do the real world scenarios and problem solving with demonstration therapy sessions for each different type of case and each different type of tools. So in which particular case, what particular type of tool needs to be used is a very, very important module. So yeah. Then we come on the module 5, which is again how to use the tools. Hands-on practice. Using this, we give the guided practice of the tools and the role-playing sessions. There'll be troubleshooting and adaptations which will be explained. We have to address the challenges during therapy, modify activities depending on different population. So here is the small you can see a picture of a special kit here. We also have it in the stall, so you all can just go through. So we'll just explain you what will be the role of these tools. These are specifically designed to address the oral sensory motor challenges by providing target sensory stimulation and exercises. It's important to select these tools and for individual specific needs and providing a safe and effective intervention. Its specific application of these tools are to desensitize in a graded manner the oral structures and to strengthen the oral muscles and improve the oral motor coordination. So this is the special kit. We have 10 wonderful magical tools which help a lot of our cases in developing a good oral sensory integration. Then comes to the module 6, which is collaborating with the caregivers in the family, educating the parents and the caregivers and the carryover activities at home, documentation and progress monitoring to track the client's progress, writing reports in the formal manner and setting new goals, ethical practices of maintaining the client confidentiality, ensuring client comfort and consent. So the key takeaway with this would be, this course provides a comprehensive introduction to OSIT using the tools supported by evidence-based research and practical applications. It equips professionals with the knowledge and skills needed to effectively address oromotor and sensory challenges in their clients. Participants are encouraged to continue their professional development by exploring additional resources and attending conferences held by speech gears. We also have webinars which engage to keep themselves engaged in ongoing research. So let's just have a quick view of the course delivery. The format would be an offline in-person mode or a hybrid mode. The duration would be for 3 days. If it's offline, it will be like a workshop, or a hybrid model which has 2 days online and 1 day offline workshop. The materials provided will be an OSIT course book, access to the tools for practice, the video demonstrations and case studies. So, who is this course for? It's for all of us. It's for speech language pathologists. It's for occupational therapists, the one specifically dealing with pediatric population, the graduate students in the concerned fields. There'll be a certification which will be given to the participants on a score of less than 50%. There will be a certificate of participation or appearance. More than 50 will be certificate of completion of the course, and more than 80% will be certificate of excellence. This can be officially used to practice the OSIT with individuals having oral sensory motor challenges. So let's look at the learning objectives. Upon the successful completion of this program, the participants will be able to describe the principles of OSIT, conduct comprehensive assessment, develop and implement effective intervention strategy, and gain expertise in applying innovation of OSIT techniques. So it will help us master in the proper oral tool usage and techniques to enhance speech production and clarity with feeding skills. So we can also apply evidence-based practices to enhance our clinical decision making. So what would be the next steps? It will be visiting the SpeechGears website to learn more about this course and register to the introductory course to take the next step in advancing your knowledge. These are my references, and I'll be happy to help you with following details. And now the presentation is, now we are ready for the question answer session. Thank you. Sorry? Cost of this course. So cost, we have our CEO, Mr. Bharat, who is the founder of this company, who's going to tell you more about this.
Good morning, everyone. Good morning, all delegates. The cost of the course is 16,000 rupees, which includes one special kit. And this is for the professionals. For the students, we have a different plan where we'll not charge anything except the logistic cost and fee of the experts for the college and institution. Yeah, it's a 21 hours extensive course. We give 2.1 CE for this course certification. Sir, I don't know about the talk tools. We have developed this course, the tools and course gradually. So we started developing the Hiki just to address the mouth opening problem. And then we keep on adding new and new tools. So I am not aware about the talk tools and their program.
I would like to take, yeah. Yeah. So, can I?
Yes, sir.
Yeah, so, sir, I'm an OPT. Yeah. Yes. So, yes, sir. Sir, thank you for the question, sir. I am OPT level 2 certified already. But something like Make in India, if you have heard, OPT is an expensive course which the training therapists can afford. But to train the home givers, the caregivers at home, it's very important that the tools are generalized every day. We cannot use it only once in the therapy session for 45 minutes and see the patient after maybe 2 to 3 days. So it's a training program which helps us even train the caregivers to use it at home so that we can, for example, if it's a case of Down syndrome where there's an anterior tongue thrust and the drooling is frequently present. The child will not be able to eat well, the child will not be able to speak well. The reflexes, primitive reflexes have not gone back. So, with this sensory integration, it's very important for us to give a home program for the parents as well. And this is a cost effective tool from the Indian brand. And that's the reason of my association with this particular thing because I'm a OPT level 2 certified already. It becomes very important for me to use our Indianized tools instead of considering the expensive tools from the US. Thank you. You would like to?
So we this OSIT book level 1, we have that book, and we have 12 research paper, but it is done by the professionals by their own will. So from SLP background, from orthodontist background, from physiotherapist background, because these tools are not only using in pediatric cases, it is also used in
Hello, check.
geriatric
Hello.
cases like stroke patient, cancer patient,
Hello, check.
trauma patient, also after facial surgery. So they have their research
Hello,
paper. Recently, one orthodontist has done his PhD in use of VPN and orotube.
Okay. Uh, is there any the certificate which you are giving? Has it a legal support? Some statutory bodies also recognizing that certificate?
Yeah. So RCI?
Yeah.
Yeah.
So yeah, this is very nice question, sir. And actually, I want to collaborate with different colleges for this. So we are in talk with one college, that is Bharati Vidyapit, Pune, uh, to we are collaborating to make it a proper course, and also we are aligning with the RCI, and I'm also thinking to align with the IOTA and this ISACON for this to make it even more useful for the professionals and useful.
So congratulations to you for starting this startup.
Right.
This is startup, no?
Yeah, it's a startup, sir.
This is startup.
Yeah.
So we can give best wishes to you from Yota side
Thank you.
Yes, sir. Thank you, sir.
so
Thank
that
you very much.
grow.
Yes, sir. And this is not one. These are not the only tools. We are keep on developing new and new tools. Our kitty is the phoneme development kits. So we are developing different tools for phoneme development like ta, cha, sa. So we have 9 phoneme development kits, which is in a prototype stage, and after some year we will get in the market. Thank you, sir. Yes, ma'am, all over India. Yes, ma'am. Also, outside of India, we have conducted one in Bangladesh, and we are going to conduct this course in Chile and Peru. Till date, five. One in Dhaka, one in Leh, one in Nagpur, one in Hyderabad, one in Bangalore. Yes, yes, ma'am. Yep, yes.
Yes. So we have, yeah. Yes. So we have those video demonstration in
Yes,
the
ma'am.
course, but yes, it would have been added. It would be, yeah. So we have different types of patients demonstration using specific particular tools, like if it's head and neck cancer, where there's loss of sensorium. How do we develop using? So it's going to be like case specific, because generalized these tools are cannot be used. It's happening. There are a lot of quacks in the market who try to just use it, who are not even therapists. So I believe occupational therapy, speech therapy, these are professional courses, but the ones who are not done the professional courses, they tend to misuse this particular tool in different manner. So we have also observed that someone who's not a trained professional, he's developed a jaw sling, a slide of the jaw, because of using this in an error pattern. So we have a couple of videos with different types of population, how we use these tools, like for sensory processing disorders or oral hypersensitivity, from where the tool has to be
I followed. I
yeah.
followed. But for the pediatrics and the adults, do you have separate courses or everything?
Everything we
thing
have
is
tried to combine in the same, because
Okay.
one kit, if someone is purchasing worth rupees 6,500, he is getting a lot of benefit of after using these tools on the children. But if he's not trained, then he's actually doing something which is unethical. So this course is basically, before purchasing, if you all can enroll in the course, do the course, and then use it for specific population, whichever population you all are serving, this will give us better results and outcomes instead of just using the tools randomly.
But,
So we
but
have
the sizes will be different, no? For the pediatrics, those
yeah,
tools,
so there are
and for the adults.
yeah, there's a hard and the soft kit.
Okay.
This is how we have tried to bifurcate. But depending on the endurance we want to develop, we use it patient specific. So we don't give like everyone the same kit. We do the assessment, like I mentioned, and after the assessment we come up with those pointers which help us decide which particular tool can be used with this particular population. Like for example, if there's a head and neck cancer where there's a trismus, where the jaw opening is very restricted, we have different types of jaw bite blocks of different widths and diameters. So I've seen a lot of people are using chewy tubes with them, but chewy tubes are not advisable for cancer patients because of the post radiation effect. So depending on the population, we try to use the different types of tools. So whatever my feedback as a speech language pathologist to Mr. Bharat, he's an engineer and he designed tools for children with sensory processing disorders as well as adults. Depending on my understanding of the oral placement therapy and how they have been using their tools, he's tried to actually make certain adaptations and accommodations of those tools so that I can use it with my specific population. And we have seen the results in another 3 months. Like a 21-day learning period for the child is very important for those with those tools. And 3 months we've seen significant difference in the feeding abilities of the child, in the speech clarity, in overall regulation, because oral seeking is very commonly seen in children as well as who are even like if 12 years, 14 years, oral seeking is very, very commonly noticed. So these all behaviors have come reduced. So indirectly there was an improvement in the other skills.
So on the whole, that 6,500 rupees kit contains everything. Okay.
And if you get to compare with the oral placement therapy, with the tools which I have purchased were 1,20,000. So for my Indian population, I'm very sure that I will only be able to give them therapy, but they cannot generalize it at home. So that's the reason for my association with this company for 2 years.
So now the question from engineer. Mr. Bharat, you are utilizing plastic material. Is it plastic, no?
It's a polymer, sir. We can call it a polymers.
So
medical grade polymers. Yeah.
So any testing for toxicity?
Yes, sir. We have a test reports. So we have taken the C certification, ROHS certification, US FDA certification, and we have done testing after every batch of production through international lab, that is the SGS lab, and the level is very, very less. I mean, negligible.
And by seeing the photograph only, what my perception is that the quality is little bit needs to improve.
So sir, since I'm using these tools on my own son who is neurodiverse, and he now developed his speech after using this tool, then I launched this product in the market. So there is always the trade-off between the aesthetic and functionality. So I go for the functionality, not for the aesthetics. Like if I would have used silicone materials, it would be look amazing. But silicone is not meant for chewing because it has a very high shear resistance. And when child chews it, chewing it, then all the forces exerted by the child is taken by their gums, their oral musculatures, not by the material. So that is not the right, and that is the reason why my son used it. He has misaligned his jaw, and now it has become very difficult for me to correct his slurry voice because his jaw is not, a little bit misaligned like this because of hyper use of the silicone made chew tube. Now so we have chosen such material where the force is taken by the material, and it looks very savvy after using it. But we have a well-defined rejuvenation process. When you put these products onto the into the water for 2 hours, it becomes like new. So these consideration has been taken. For example, the TTUD, the general mouth span, the average mouth span of the children is 24 mm against 26 mm which happened in the European and American population. So we have reduced the size to accommodate in Indian population. For adult cases, we have different type of TTUD which is spring loaded. So for adults and pediatric, we have two sets of tools. Even our stimulation device, that is VPen, has higher level of vibration. Its G value is 1G as compared to zero point 0.6 to zero point 0.8 G in case of pediatric cases. So all these consideration has been taken to develop these tools. Thanks.
I have one more question. That since what I understand, it's a one kit for the same patient. As a therapist, if I take it, I have to use it for multiple patients. So, what are the guidelines for the hygienic aspect?
So yeah, you are right, sir. This is for individual kit. We cannot use for multiple kit. So for hygiene and safety, we have a hygiene process. We can clean it through one liquid. We have designed a liquid that is a edible liquid, edible soap. Second cleaning process is by putting these tools into the lukewarm water for half an hour and then clean. And third one is we can also do the ETO. Through ETO process, we can clean in hospital setup. So we have a well-defined cleaning process for this.
Any maximum limit of using, like only 100 patients or whatever, limit of the durability? Or maybe by keeping it for longer period, will it get spoiled or something of that sort? So basic, yeah, durability and the, I meant to say validity also
Right,
of the
right,
tool,
exactly.
both.
So we give warranty of 6 months. So if anything happens to this device, then we replace it. Secondly, we want this tool to be used for 6 months to 1 years, and we want
Okay.
child to be come into the normal setup. We don't want parents to use for whole life. That is not our objective. So we believe that after purchasing one kit, they will be able to uh, fulfill their purposes. So we have a protocol also. There is small dots and big dots in our one of the tool, and if that dot starts degrading, then we say that just throw it out, just discard it and purchase new one.
Okay.
Yeah.
And what about the courses? Who are the faculties?
Faculties includes occupational therapist, speech language pathologist, these two, because this is a mixed course where
You mean to say you have those
yeah, we,
already
we, we have team of experts.
team of
Team of
experts?
experts, yes.
Okay,
And
thank you.
participant would be the OTist and
Yeah,
SLPs,
yeah.
orthodontist, ENTs, and child pediatricians. This is
Okay,
not for the special educators and psychologists and all.
thank you.
Thank you, ma'am. Thank. Okay, okay, right.
Hello. Yeah, so for example, this is a V pen which has got different textures. So, what we do is, in order to work on a child who is having hyposensitivity of the oral musculature, he's definitely a seeker. He needs some kind of an oral input. The vibrations, like I think sir and ma'am, you all have had the experience, it's matching to the neural frequency of firing. So this has been designed technically by Mr. Bharat in such a way that to subside those, hypersensitivities or to increase the to reduce the hypersensitivity and get it back to normal, it's very important for us to drag it from the jawline to the center of the lips. And we used for different textures and taste. The textures we get here, and taste we use honey, lemon, coffee powder inside and on the tongue, inside the palate and on the tongue. So we have I'm just trying to show you a little bit of videos of adult population. Yeah, it's come. Last wale pe kar. How we use it on the adult population, because I just managed to get it to show you all. Yeah. So this is basically a hickey. Okay, it's for the jaw stability. This has been used for a patient who's got a stroke, post-stroke, to improve the jaw stability. So this is a part of the rehabilitation. So she was having a little bit of jaw jerks, a lot of jaw jerks. So this is the way we helped her, and she came us with a complaint of speech difficulty, swallowing difficulty, and drooling. Next play karna. It's a hickey. It's another tool which helps us in improving the jaw stability. It's got some textures. Just change, I will show you. Yeah. This is against the resistance. They are trying to bite on it. So this is to improve the endurance of chewing. This is the technique in which I have advised it for this particular patient. Dusra. Yeah. Next. Here. This is for the tongue stability when they have fibrillations of the tongue, fasciculation. So this helps in the tongue stability. Yeah. Okay. So these tools are with a clinician we have one set, but we prefer every patient giving an individual set. We do not use the same set for all types of patients. Yes, and if in case if the patient is using for the first time for demonstration, it's properly sterilized and used for another patient. We advise, because it has to be done thrice a day and 3 times no therapist can go and reach out to the patients. We train the caregivers or the nurses who are 24 hours or 12 hours to do these things. So the patients who are comfortable, like she has developed a good dexterity, so we have advised her to learn and show us how she's doing it. But for the patients who are bedridden, we have videos of the bedridden patient. Please change the video. So this is to stimulate the periodontium receptors in the gums, what we are doing, because this patient was not able to gauge the... This is a case of ALS, that's amyotrophic lateral sclerosis. He's also having a tracheostomy and he is also on ventilator. But the tongue movements were restricted. He was unable to take his own secretions. So we are just making him ready for the pleasure feeds what we give. He already has a peg in his stomach for the nutrition. Pediatric अभी नेहा को दिए थे मैंने सारे. So activity of the oral cavity improves with these kind of minute vibrations. But for different types of patients, like I said, ma'am and sir, it's very important for us to assess the main reason why these challenges are faced, and then we are supposed to use these tools, not just for the sake of using it. We cannot use it just like that. So that's the reason why we need to train. Yeah.
We had on first day, I don't know whether you attended, we had a continuing OT education. In that we had the topic was I'm just say it was on oncology rehab, but it
Okay.
was only face, neck and face,
Head and neck and face. Yeah.
So all those, I think you should approach all the cancer hospitals, and we have one therapist in Tata Memorial
Yeah,
Hospital.
so I'm a fellow from Tata. I've been trained in onco swallowing and speech therapy for a year.
You should approach her.
Yes.
And because unfortunately she has left, she had to go. Otherwise, she would have been attending, and I think she would have loved it.
We'll try
Yeah.
connecting.
I'll
So-
also try to talk to her, but
Yeah.
you try to connect.
So, ma'am,
with her.
I'm with Sir HN Reliance Foundation Hospital in Mumbai
yeah.
in the oncology department
Yeah,
also.
yeah.
So, we deal with these tools and we use it for patients with maxillectomy, mandibulectomy, tongue surgery,
Yes, yes.
glossectomy. And we've seen a lot of good results because the traditional old school was without even touching the patient. We used to instruct. Now
Yeah.
we are using these tools to see a change. So it's really helping. And I'm sure, I'll try to connect with
Yes,
madam
yes.
so that we can get it a little more evidence-based and researched.
Yeah, and also Hitesh Gupta in Delhi. We'll give you the contact numbers.
Yes, ma'am.
So, because you are talking about Christmas and all, she had shown one tool
Tool,
where
yeah.
she was using it with
Therabyte.
the
It's a
different.
therabyte, yeah.
So, she was, I think, talking same thing. So maybe she will need more and more like
Yes,
this.
ma'am. We will be happy to help, ma'am.
Yeah. Okay.
Thank you.
Thank you.
Thank you. So this is for the child, Charu, you want like?
So I have been working from last 5 years with SPD and ASD children. So this child had this sensory problem, like he was unable to accept any taste and texture. So I started with the gum massage and with the V pen with the pointed tip, and slowly I introduced different texture with hickey, and then I started with different taste and texture introducing to him. Now he is able to eat. So yeah. And same with, I was treating a fragile X syndrome child who had swallowing issue, who had all the feeding issues, sensory issues. So now he's okay, and he's able to like feed himself. He's okay with his ADLs and all. Thank you.
Any more questions?
Very small babies.
Yes. So, ma'am,
Where they have a feeding problem.
yeah. So
And
NICU babies,
yeah,
NICU babies who have difficulty in latching. So there's a new course which has come, which is called as prompt. Which is basically a perioral stimulation using the finger and a finger brush.
That we do.
But which
Yeah.
like in the NICU when
Yes.
the therapists are equipped to do that, in them the tool exploration have not been so far done.
Okay.
I have introduced only the textures of this brush without vibrations because they are too much
Yeah,
for a
yeah.
child who is
Yeah.
NICU or with an RT. So perioral stimulation, yes, we do that. But with the tools, we have yet to explore.
Okay.
Or
So
we are yet
they
to
are not
design.
available.
Thank you so much
So,
for the
yeah.
feedback, ma'am, because I think we can design some
Yes, please.
for them. Yes,
It's very important.
Yes,
Yeah.
ma'am.
Thank you.
Yes, please. Yeah, so basically it can be as early as 1 year we start, because the acceptance of the child is also very important, because this is like 5 times tuck 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 chewing 5 times. So we have to give different tastes like chocolate, honey, to at least introduce the tools, because none of the child will accept the tool. It should be shown like a toy, or it should be played with. So first 2 sessions just goes in playing, all the vibrations over the body, near the face, just asking them to blow something, rounding the lips with textures. And then from the third session they start they start getting a little more adapted with the tools, and then they introduce. So 1 year is the minimum limit which I've started, but NICU is a good idea, but we are yet to design tools specific to that particular population. But yeah, I think that can be taken as a feedback, ma'am. Yeah. Yes, yes. Every Sunday, yeah, we have 2 hour webinars on specific topics of the modules. We don't give the whole course in the webinar, but yeah, for other people, not only in India but abroad, who wish to learn about the sensory motor integration principles and the way we are using the tools on them, and how reflex integration happens and how we work on these sensitivities, we have different topics, specific topics for different kind of population. But recently we had for feeding and ARFID, which is avoidant restrictive food intake disorders in children with sensory processing disorders. So like that, we have different specific topics which are very niche, and which are just related to, sometimes we've just seen like one passage in a textbook but nothing in detail. So we do the researches and we make webinars for other people, especially the therapists, to join in and learn. So that happens on Sundays, all Sundays, for 2 hours. Yes, sir. Yes, so that is available. So it is available on the Speech Gears website as well as Amazon. Yeah. So for some people, we just need the V pen. That's it. So we don't ask them to buy the whole kit. And that's the reason why during assessment we use this tool. That how much will be the acceptance, how much is the need. So for everyone, we cannot prescribe the kit. It is patient specific. Thank you.
You said you start, minimum age is 1 year.
1 year.
So, Miss, you will start doing integration program after 1 year. Until then,
Till then, so
we will wait for that,
we will not.
or as early should be started.
Early intervention is the key, sir. But the thing is, we are introducing the brush without the vibration. That's the fluoride finger brush. For the cases like I discussed, we've done the prompt perioral stimulation course, which uses with the use of the finger and certain textures we start for younger children. And after 1 year, the introduction of the tools which are a little which are having endurance, which is little more. We cannot administer that directly, but we will definitely think of designing something which helps children below 1 year. No.
I think I saw something on your board like talk tools stuff.
So the chewy tube, you mean?
Chewy
The
tube,
oral
blowers,
tube? Yeah.
different kind of blowers
Yeah.
and all.
So there are different type of horn kits which we have designed.
That's why I wanted to know.
That is specific trademark to Speech Gears, which we have introduced for improving the speech clarity and improving the intraoral pressure of the patient.
And you were saying about the prompt, but the prompt is only for speech therapists. It's not for OTs.
Yes,
think so.
I
Yeah.
believe, yeah. So the ones who work with NICU children and in the domain
No,
of
but they
latching
don't
and-
allow the OTs to do that
Okay,
course.
okay. I am the speech therapist, ma'am.
Okay.
Yeah, I'm a speech therapist from Speech Gears India. It's a privilege to be a part of the OTCon. It's very wonderful to get feedbacks like the senior people from here, and we are definitely going to incorporate this to improvise our course. Thank you very much.
Okay.
Thank you, everyone.
On behalf of Avata and organizing committee, it is our honor to recognize the remarkable contributions of our platinum partners, Speech Gears and RCM Healthcare Services. I would like to call upon now Dr. Pankaj Vajpayee, President Avata, Dr. Pratibha Vaidya, Vice President, Avatar, uh, to present a token of appreciation to our partners for their extraordinary support as well as generous support. So first of all, I'll call the speech case, please. Madam, you stand. We hope to continue this partnership long term. Yeah. Now we call upon our next platinum partner, RCM Healthcare Services. Yeah.
Together.
Yeah, together.
This also. Okay.
Yeah.
Let madam.
Let
you-
madam. Please.
RCM. Hello.
Yeah. We thank both our platinum partners, Speech Gears and RCM Healthcare Services. Thank you.
We will start a scientific session number 6 in few minutes. Good morning, one and all present here. I, Dr. Purni P., Scientific Committee Member, OTCON 2025, extend a heartfelt greeting on behalf of the organizing committee to and I welcome everyone to our third day of OTCON 2025, and I welcome all the respected delegates to our sixth session of scientific session oral paper presentation of OTCON 2025, titled on Unlocking Potential, Advancing Holistic Development and Well-being in Pediatric Occupation Therapy. I would now like to welcome our chairpersons for our scientific session 6 oral paper presentation onto the dais. I would like to welcome I would like to invite our chairperson for the session, respected Dr. Jyotika Bijlani ma'am, respected Dean Accord. Ma'am has been instrumental in standardizing occupation therapy education in India. She has led fellowship program, e-learning invitations, and national workshops enhancing professional skills and researches. A former professor and head of LTMMC Mumbai, ma'am has mentored many professionals and played a key role in developing assessment tool for children with learning disability. Ma'am's contribution to research, curriculum development, and clinical excellence are widely recognized. I welcome you, ma'am. I would now like to invite our chairperson for the session, respected Dr. Vaishali Joshi, ma'am, professor and head of Department of Pediatrics, GMC Goa. Ma'am has been at the forefront of medical education, research, and clinical excellence for over 3 decades. She has chaired numerous medical symposium, including key discussions on anemia, benefiting hundreds of doctors. Ma'am is also a co-author of book Current Trends in Tuberculosis, contributing to vital advancements in TB researches. Her dedication to pediatric care, pneumophila treatment, and medical mentorships had made a significant impact in the field. I welcome you, ma'am. I would like to welcome
Our chairperson for the session, Dr. Pratibha Milandi Vaidya Ma'am, Honorable Vice President of All Indian Occupation Therapy Association. Ma'am has been instrumental in promoting and advancing occupation therapy education and practices across India. Ma'am also has a previous role as Honorary Treasurer of All Indian Occupation Therapy Association, showcased her commitment to strengthening the profession's foundation. With years of experience, she has contributed significance to the policy development, professional training, and researches in occupation therapy. Welcome you, ma'am. I would now like to hand over the stage to the respected dignitaries for the sixth scientific session oral paper presentation.
Start inviting people. Yes. Hello. Good morning, all. So we'll start the presentations. So today we have many actually. So we'll start with the first one. This is not there. The second one. An evidence-based review on the effect of premature infants oromotor intervention on feeding in preterm infants. Dr. Neha Mane from Goa. Please come.
बैटरी पर उधर से एक स्लाइड चेंज कर दो, एक स्लाइड चेंज कर दो. बैटरी maybe you change the battery. वो ये वो स्लाइड चेंज उसको अच्छी तरह से डाल दो. एक बार बैटरी चेंज कर दो. बैटरी चेंज.
Good morning, everyone. Good morning, ma'am. So, myself, Neha Mane. The topic of my paper presentation is an evidence-based review on the effectiveness of premature infant oromotor intervention on feeding in preterm infants. So, introduction. In 2020, Introduction. In 2020, 13.4 billion babies were born preterm globally, with India reporting the highest number, that is 3.2 billion, resulting in 0.3 billion deaths from complication. Preterm birth refers to infants born before 37 weeks of gestation, categorized as extremely preterm, that is less than 28 weeks, and very preterm, that is 28 to 32 weeks, and moderate to late preterm, that is 32 to 37 weeks. Premature babies frequently face significant health issues. One of many is feeding difficulties. Feeding problems include oral feeding difficulties, gastroesophageal reflux, dysmotility, and systemic illness, which disrupt normal feeding patterns. These are due to underdeveloped sucking, swallowing, and breathing coordination, leading to the need for gauge feed or tube feeding. So, Various interventions OTs use. These are multisensory stimulation, skin-to-skin contact, oromotor stimulation, adaptive feeding equipment, caregiver education. But there is a lack of published literature on interventions used for improving oromotor function of infants having difficulty in oral feeds in NICU. This created the need of my study as premature infant oromotor intervention is a new intervention to enhance oral feed ability. However, these are very few researches conducted on effectiveness of this program in Indian context. So the aim of my study was to synthesize the existing literature and determine the effectiveness of premature infant oromotor intervention in improving oral feeding outcomes in preterm infants admitted to neonatal intensive care unit in India. So the objective of my study first to systematically review the effectiveness of POME in improving feeding outcome such as oral feeding progression, weight gain and length of hospital stay in preterm infants. Second, to review the overall effectiveness of POME compared to other oromotor stimulation interventions in Indian NICU setting. So materials and methods, study design was systematic review of literature, review framework, conducted a systematic review and meta-analysis following PRISMA guideline covering studies from the inception of POME to October 23. Structured using the PICO framework, that is Patient Population Intervention Comparison Outcome. Data source, a comprehensive literature search was conducted in PubMed, Medline, Embrace, Clinical Key, Academia, Google and Google Scholar. Search term, the keywords were premature infant oromotor intervention, feeding progression, NICU feeding, and oromotor therapy in preterm infants. So what is the premature infant oromotor intervention we are talking about? It aims to mimic the in utero oral experiences that strengthens and develops feeding mechanism. It is a 5-minute oromotor intervention using a little finger in and around the mouth of preterm infants as young as 29 weeks of PMA, that is postmenstrual age. Techniques such as stroking the cheeks are reported to enhance the sucking rate, and providing cheek and chin jaw support may facilitate sucking efficiency during feeding. This technique is used to facilitate the developmental of oral motor and sensory skills required for sucking and swallowing. Such direct programs often involve stroking perioral and intraoral structures in a specific way with a gloved finger for a specified time before feeding. So the inclusion criteria was primary research published in English in peer-reviewed journals from 2018 to 2023. Research focusing solely on the practice of POME program, randomized control trials, and clinical trials assessing the effectiveness on feeding outcome. The exclusion criteria was studies having variation in intervention protocols, studies conducted in countries other than India, research involving full-term infants rather than preterm infants. So study selection process. So we reviewed the assess eligibility based on the Cochrane Handbook for Systematic Review of Intervention and the JBI Critical Appraisal Checklist for RCTs to ensure rigorous selection. So analysis method it was a two-step process. First step was initial staining based on the title and abstract, followed by a full text review for relevant data extraction. So the extracted data involved level of evidence, which was 5 study at level 1, which was RCT, and 1 study at level 2, that was non-randomized control trial, case control trial. The second criteria was study objectives, and third was descriptive data regarding preterm infants. So this was the PRISMA guideline showing the identification of studies via database and registers. So results, so article review, a total of 40 articles were identified, of which 6 met the inclusion criteria and were included in the review, and which was categorized as author or publication, study area, participants, or intervention and control, method, outcome measure, results, conclusion, and evidence, and level of evidence and scoring. So this was the category. So the discussion, so POME improves oral feeding readiness and performance. So POME showed that the average increase, the reduction rate of 4.6 days. POME reduces hospital stay and promotes weight gain. Third, POME enhances breastfeeding rate. In fact, in one of the study, POME infants had higher exclusive breastfeeding rates at 1 and 3 months post-discharge. So POME improves feeding transition. So POME group transit to full spoon feeding 6.5 days earlier than control. 5 was behavioral and neuromotor benefits. POMA helps infants become more alert and ready for feeding by stimulating oral reflex and motor development. 6. All these studies were conducted in India, demonstrating POMA effectiveness in improving feeding outcomes in preterm infants within neonatal intensive care unit. So limitations, there was first language and accessibility constraint, second was limited availability of high quality studies, and third variation in study methodology, sample size, outcome measure and intervention protocol made it challenging to draw direct comparison and synthesize findings, so making it difficult to establish standardized recommendations. So future implication, conducting a multi-center RCTs with a large sample size, developing a standardized POME protocol for consistent use in NICU. Second, exploring the long-term effects of POME on feeding skills, speech and neurodevelopment post-discharge. Comparing POME with other oromotor and sensory-based intervention to determine the most effective approach. Assessing the role of parental involvement in POME for better feeding success at home. So conclusion, POME represents a critical intervention in improving the feeding outcomes of preterm infants. Second, its application could significantly reduce the length of hospital stay and enhance the overall health and development of preterm infants, making it an important strategy in neonatal care in India. So these were my source of findings, and there was no conflict of interest. Institutional ethical committee had permitted for my ethical approval, and I am thankful to the dean of my institution for giving me the permission, and ethical committee for granting me the conduct my study. My heartfelt thanks to my guide for her constant guidance and support, my parents and my loved one for all the encouragement. I will also like to thank AIOTA Oticon 2025 for giving me an opportunity to present my paper at this platform. And these were my references. Thank you.
Thank you, Neha, for that lovely paper you presented. I just have one query. We could do it later. Yeah, I think we are having questions at the end of all the papers, so we will move on to the second paper. Yeah, we can come back later to the questions. So we have the next paper coming in from Dr. Nikita Doma, and she would be presenting on exploring the role of occupational therapy in assessment and intervention in children with attention deficit hyperactivity disorders, a qualitative study. Over to you. Yeah.
Good morning, everyone. My name is Nikita Donna, and my topic is exploring the role of occupational therapy in assessment and intervention in children with attention deficit hyperactivity disorder, a qualitative study. Attention deficit hyperactivity disorder, that is ADHD, is one of the most frequent neurodevelopmental disorder of childhood and adolescence, which typically is first diagnosed in childhood and often persists in adulthood. According to the DSM-5, ADHD is a neurodevelopmental disorder defined by impairing levels in inattention, disorganization, and/or hyperactivity impulsivity. Boys with ADHD usually show externalized symptoms like running and impulsivity. Girls with ADHD, on the other hand, typically show internalized symptoms like inattentiveness and low self-esteem. The global prevalence of ADHD is 7.6%. In India, the prevalence in primary schools is 11.32%. It is higher in males as compared to females, and it is higher in the age group of 9 to 10 years. Occupational therapy aims at addressing the skills related to the impairments, ADL, and participation. The need of my study, limited literature available on the areas of concern targeted by occupational therapists, as well as the assessment tools and intervention strategies that are available, and to bridge the knowledge gap by identifying areas of occupational function, understanding the functional abilities in children with ADHD, and to explore the assessments and interventions used by occupational therapists. The aim of my study is to explore the various assessment tools and intervention strategies used by occupational therapists in addressing the functional abilities in children with ADHD, and the objective of my study is to do so by conducting a semi-structured interview with pediatric occupational therapists. The methodology, the study design was a qualitative descriptive study consisting of semi-structured interviews, which was conducted in India. 15 pediatric occupational therapists were recruited via convenience sampling and snowball sampling. The criteria for selection of participants. In the inclusion criteria, I have pediatric occupational therapist qualified as a bachelor or master degree in occupational therapy with a minimum of 4 years of experience in the field of pediatrics. In the exclusion criteria, I have all other therapists practicing in other fields except pediatrics and occupational therapists practicing outside India. The procedure, after approval from the IEC, interviews via call or in person after consent was taken, transcription of audio was done which led to the coding of data, and finally the generation of themes. Results, these were the themes that were evolved after thematic analysis. These were the various ADHD assessments that the therapist reported. I'll read a few. Some of them were Vanderbilt ADHD scale, the ABC, the sensory profile, VFIM, soft neurological sign test, Berry-Brutica VMI, the BOT. These were the various ADHD assessments, interventions, that the therapist used. Some of them were the developmental approach, the cognitive frame of reference, the SI approach, the auditory interventions like therapeutic listening, ADL training, social skill training, narrative practice, family-centered approach, etc. The first theme highlighted the areas pediatric occupational therapists focus on. Occupational therapists support the holistic development of children with ADHD, focusing on the functional independence through ADLs, play, social interaction, motor skill, handwriting, coordination, and reflex integration. They also assist NICU graduates, premature infants, and children with developmental delays. Beyond the child, therapists address family and environmental needs, including sleep, menstrual hygiene, and sex education for adolescents. A therapist quoted, "So basically, activities of daily living would be our first preference. Play depending upon the age, school difficulties, academics, looking into primitive reflex integration." So I would say these are the main areas that you come across. The second theme highlighted the parental concerns for the ADHD child. The therapist reported that the parental concerns mainly focused on behavior and school-related issues such as hyperactivity, inability to sit at one place, difficulty completing tasks, following commands, impulsivity, and frequent activity switching. The school-related concerns include struggles with sitting in class, turn-taking, running out of seats, and disruptive behaviors. Behavioral issues such as hitting, aggression, lack of concentration, and disobedience were also common. I think mostly the concerns are raised by schools. The parents are always worried that the school might remove the kids. The child is not focusing in school and is struggling with education. So it's mostly the schools that are raising a concern in the family's life, quoted another therapist. The third theme focused on the functional challenges faced by the ADHD child. Children with ADHD struggle with daily activities such as dressing, brushing, eating, and hygiene, often rushing, skipping steps, or completing the task ineffectively and requiring supervision. Challenges include managing buttons, zippers, shoelaces, chewing properly, sensory-based food preferences, and staying seated during meals. Impulsivity, inattention, and hyperactivity hinder turn-taking, cooperative play, friendship, and academic performances. A therapist quoted, "Be it dressing or grooming or brushing, they'll just rush and finish the task. And sometimes they might even complete the task. But the quality or neatness of the task might not be there. Most of the time, they might just also skip the steps." These are a few quotes that some of the therapists also quoted. The fourth theme highlighted the challenges encountered by the occupational therapist, which include rapport building, managing the ADHD child's hyperactivity and impulsivity, educating and involving parents in the therapy session, addressing school-based difficulties, improving the child's attention and focus, and ensuring consistent follow-ups on therapy sessions. A therapist quoted, "So first of all, connecting with the child. He takes his own time to connect. So listening to me and following my commands, he takes his time." Another therapist also quoted, "Parents to comply to me or to make them understand what I want of them during the therapy session, because most of them are not in a state to listen to you. So you to get them to the same page as I am." The fifth theme were the variations in the functional abilities. Some therapists noted the way functional abilities varied based on the age, gender, and context. As children age, hyperactivity tends to decrease, with symptoms shifting to internalized issues like inattention. A therapist quoted, "Absolutely, there's gender difference. As ADHD children grow up, more and more, it is okay for boys to express hyperactivity and to jump around and to be mischievous. But young girls, they are asked to repress or mask their ADHD. The context, including the physical and social environments, play a significant role. The Western focus more on making the child independent, while in Indian culture there is more of parental involvement and family-centered approach. Home environment have a significant influence on how children develop and how their brain develops. So the temperament of the parents have an influence," quoted a therapist. Discussion. The interview highlighted the challenges faced by the children with ADHD and the role of OT in fostering their functional independence. Sensory integration techniques such as sensory diet, deep pressure therapy, vestibular input, and auditory interventions enhance the attention, self-regulation, and participation in daily activities, and they align with the existing research. Enhancing executive functions improve the daily occupational performance, while play-based interventions involving peer, parents, and therapists facilitate the occupational engagement. Several systematic review studies provide strong evidences for intervention studies aligning with the findings of this study. Limitations and future implications. There was small sample size which limits the generalizability, highlighting the need for studies with larger sample and a more culture diverse population. The self-report data may introduce bias, and the qualitative approach restricts statistical analysis. Remote geographical areas were a challenge to cover where there were lack of therapists available, and future studies should incorporate all the areas. Incorporating perspectives from children with ADHD and their families and perspectives from school educators could offer a more comprehensive understanding on this. And further research should explore culturally sensitive guidelines to enhance support in homes and schools. Conclusion. The research highlights the multifaceted approach needed to support the ADHD children in daily activities, play, social interaction, and academics. It underscores the significance of parental concerns and the influence of age, gender, and context on the functional abilities. It sheds light on the therapist's challenges, including rapport building, managing hyperactivity, and ensuring follow-ups. Overall, the study offers valuable insight into occupational therapy assessment and strategies to promote independence in a child with ADHD. Acknowledgement. I would like to extend my heartfelt gratitude to the Dean to giving me this opportunity to conduct my study. I am deeply thankful to my mentor and co-author for unwavering support and motivation throughout my research. My sincere appreciation to the esteemed faculty of occupational therapy for their constant and timely support. Lastly, I would like to thank all the participants of the study. These are my references. Thank you.
The third presentation is by Patra Thrissur. It is on effect of repeated stretch through activities on gross motor skills to improve play participation in children with spastic cerebral palsy, a quasi-experimental study.
Good morning everyone. Today I am here to present my research topic on effect of repeated stretch through activities on gross motor skills to improve play participation in children with spastic cerebral palsy, a quasi-experimental study. Introduction. Children with cerebral palsy often exhibit atypical patterns of movement and posture, affecting their ability to access play spaces and equipment, which substantially affect their pace in playground activities and participation in group games. Repeated stretch elongates and activates spastic muscles, which further facilitates proximal stability and control to initiate, maintain, and transition between play positions. It further develops basic locomotion for play exploration and facilitates turn-taking activities with peers requiring movement. Rational. Play participation in children with cerebral palsy is often influenced by deficits in gross motor skills, including running, jumping, and reaching, due to proximal muscle instability and abnormal synergy. Existing literature has demonstrated that repeated stretch is effective in improving proximal muscle stability and functional synergy. However, adequate research has not been conducted to determine the effect of repeated stretch on gross motor skills and thereby play participation among children with spastic cerebral palsy. So, the aim of this study was to determine the effect of repeated stretch through activities on gross motor skills to improve play participation in children with spastic cerebral palsy, with the objectives to determine the effect of repeated stretch through activities on gross motor skills in children with spastic cerebral palsy, and to determine the effect of changes in gross motor skills on play participation among these children. Methodology. This study utilized a quasi-experimental study design which was conducted in an outpatient department within the duration of February 2020 to August 2021 using the convenient sampling method. The outcome measures were gross motor function measure which assessed the gross motor skills and semi-structure caregiver interview questionnaire to assess the play participation. Statistical analysis was done using Mann-Whitney U-test and Wilcoxon sign rank test. Sampling criteria. The children, those who were included in this study, had a spastic hemiplegic cerebral palsy who were within the age group of 3 to 5 years, having muscle tone of 1 to 2 in modified Osworth scale, with GMFCS level of 1 to 3 who were able to walk with and without orthosis, having Berg balance score of 41 to 56 with minimal fall risk. The children, those who were excluded in this study, were those who had marked cognitive deficit, contracture and deformity, auditory and/or visual impairment, congenital cardiac anomalies, and epilepsy. Intervention protocol. 30 children with spastic cerebral palsy were allocated to experimental group and control group, with each group comprising of 15 children. Both the group received the intervention for 8 weeks. The children in experimental group received repeated stretch for 15 minutes, which targeted the flexors and adductors of shoulder and hip joint, which are the common areas which affects the gross motor skills in these children. So here, upper extremity pattern of flexion, abduction and internal rotation was provided, with the ball with handle rotated in an anti-clockwise direction around a wooden board with circular groove. For the hip joint, a hip circumductor was rotated in standing position using the lower extremity pattern of flexion, abduction and internal rotation. Along with this, usual occupational therapy was provided for 45 minutes, which included occupation-based activities such as feeding, dressing and grooming for 30 minutes, followed by play-based activities such as action songs, obstacle course, bowling, ball kicking and ball hitting in sitting and standing positions, which were provided for 15 minutes. Once in a week, these children also receive play sessions such as musical chair and basketball for 30 minutes. Children in control group also receive usual occupational therapy and play session. However, these children receive usual occupational therapy for 1 hour, which included occupation-based activities for 30 minutes and play-based activities for 30 minutes. Results. Figure 1 shows the mean scores of experimental group and control group before and after intervention. So as we can see here, before the intervention, there was a similar kind of mean score between the two groups, which was approximately 65%. However, the children in experimental group showed a significant improvement in mean scores, which was 84%. Table 1 shows the statistical analysis of gross motor skills between experimental group and control group before and after intervention. So as we can see here, after the intervention, there was a statistically significant improvement in gross motor skills among these children. Table 2 shows the statistical analysis of gross motor skills within experimental group and control group. So as we can see here, the children in experimental group showed a statistically significant improvement in gross motor skills as compared to control group. This shows that the children who received repeated stretch showed a significant improvement in gross motor skills as compared to the children who received usual occupational therapy in control group. Figure 2 shows the mean scores of play participation between experimental group and control group before and after intervention. So as we can see here, before the intervention, both the group had a similar score, which was 5. However, the children in control group showed a significant change in the mean score, which was 10.26. Table 3 shows the statistical analysis of play participation between experimental group and control group before and after intervention. So as we can see here, the children after the intervention showed a statistically significant improvement in play participation. Table 4 shows the statistical analysis of play participation within experimental group and control group. So as we can see here, the children who receive usual occupational therapy in control group showed a statistically significant improvement in play participation as compared to the children who receive repeated stretch in experimental group. Discussion. While assessing the gross motor skills, it was found that there was a significant improvement in experimental group as compared to control group. This shows that the children who received repeated stretch showed improvement in gross motor skills as compared to usual occupational therapy. These results matched with the study conducted by Esteban et al. In Spain, which showed that gross motor interventions improved gross motor skills because structured practice and appropriate instruction promotes gross motor development. However, when play participation was assessed, it was found that there was a substantial improvement in control group as compared to experimental group. This shows that the children who receive usual occupational therapy showed improvement in play participation as compared to repeated stretch. This is acknowledged by the study conducted by Rincon et al. In Bogota, Colombia, which showed that play-based activities improve play participation in these children as it enhances play skills, self-control, and intrinsic motivation required while playing. Limitations of this study included a small sample size, using a semi-structured caregiver interview questionnaire to assess the play participation, and using repeated stretch with shorter periods of play-based activities to improve play participation. So the future recommendation of this study is to perform this study on a larger sample, to use a standardized norm reference assessment to evaluate the play participation, and using repeated stretch with play-based activities to improve all the domains of play. Conclusion: repeated stretch is effective in improving gross motor skills, but it does not improve play participation. However, usual occupational therapy, specifically which provides the play-based activities, is effective in improving the play participation. So, this study provides insights to the occupational therapists that for improving play participation, all the domains of play such as gross motor skills, play skills, cognitive skills, and social emotional skills should also be addressed. These are my references. Thank you.
Thank you, Dr. Patra. May I call Dr. Payal Unhelkar from Mumbai? She is going to present on perspective of social education team members regarding sexuality of children with disabilities in special schools, a qualitative study. Please start.
Thank you, ma'am. Good morning to one and all. The title of my study is Perspectives of Special Education Team Members Regarding Sexuality of Children with Disabilities in Special Schools, a Qualitative Study. Introduction. The World Health Organization defines sexual health as a state of physical, emotional, mental, and social well-being in relation to sexuality. It requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. For sexual health to be maintained and attained, sexual rights of all persons must be respected, protected, and fulfilled. Sexuality starts shaping right from childhood. Social experiences and access to sexual health information are major factors that help children develop their sexuality. The same is true for children with disabilities. In India, where approximately 1 in every 100 children has a disability, children with disabilities face distinct challenges in accessing sexual health education, which are often compounded by social stigma and misconceptions like children with disabilities are asexual. They are deprived of the necessary resources to navigate their sexual development in a healthy and informed way. So, therefore, they are also at a higher risk of sexual abuse. The current scenario in India of sexuality education will be discussed in this slide. So, sexuality education is considered a basic human right by the World Association for Sexual Health and Family Planning Association of India. At present in India, the Adolescent Family Life Education Program proposed by the National AIDS Control Organization and Ministry of Human Resources and Development is being implemented to impart sexual health education. In addition, the Government of India, in collaboration with the United Nations Population Fund, has a national action plan for introduction of adolescents' reproductive and social health, whose implementation in all the CBSE affiliated schools commenced from the year 2005. However, there are no specific programs established to address the unique needs of children with disabilities. The literature review identified the following knowledge gaps in this area. There is considerable lack of literature exploring the perspectives of education team members about sexuality. The roles of the education team members are not clearly defined. There is inadequate research on this topic in India. There is a lack of comprehensive sexual health education interventions designed specifically to meet the needs of children with disabilities. Therefore, this study is required as a prerequisite to create a basis for the development of modules, policies, and interventions for sexuality education. The methodology of this study. The study design was a qualitative descriptive study design with focus group interviews as a tool. The study setting was 5 special schools located in the city of Mumbai. Sampling method, purposive sampling method was used to recruit schools. Inclusion criteria, English and Hindi or Marathi speaking education team members of special schools in Mumbai, and exclusion criteria, education team members who were parents of children with disabilities. Sample size 5 to 7 special schools were set as the number of schools for data collection. Focus group interviews were conducted at the respective schools. An interview guide was used to facilitate the discussions among the participants. Each of the 5 focus group interviews was transcribed verbatim. Thematic analysis method was used to develop codes in each transcript. Line by line coding was done initially, then categories and themes were formed. The results. Participants of the focus group discussed in detail about their perspectives regarding sexuality of children with disabilities. There were 8 participants in each of the 5 focus groups. Duration of each focus group interview was around 45 minutes. The education team members used incidents from their experiences of teaching children in special school to substantiate their opinions and perspectives about the topic. Categories were formed on the basis of the education team members' perspectives regarding children with disabilities and their issues related to sexuality. The education team members' roles in sexual health education of children with disabilities, parents' roles in sexual health education of children with disabilities, the ability of children to grow up into adults having socially acceptable behaviors, whose responsibility it is to educate children with disabilities about their sexuality, and finally, the sexual abuse of children with disabilities. Discussion. So, 4 main themes emerged from the analysis. The first being sexuality related issues are a natural part of the development of children with disabilities. Second theme, sexual health education interventions should be able to meet the unique needs of children with disabilities. Team approach to sexual health education provision to children with disabilities, and the final theme was children with disabilities are more vulnerable to sexual abuse. Now we are going to look at each theme in detail. The first theme being the natural part of development. So most of the participants considered that children with disabilities also undergo the natural process of sexual development similar to their typically developing peers. Hence, it is obvious that they would also engage in behaviors to explore and express their sexuality. They strongly expressed their beliefs regarding the access to sexual health education to children with disabilities, and they also reported that they should know about their private body parts, types of touch, and appropriate behaviors to express their sexuality. The second theme, interventions for children with disabilities' unique needs. The educators reported that teaching strategies like dramas, role plays, charts, and the use of statues or models to teach the children about sexuality related issues is important. Receiving some kind of training often help the education team members to tackle the issues related to their students' sexuality. Third theme being team approach. All the participants found that the team approach is the best to carry out sexual health education interventions. This team should consist of not only the team members in the school but also parents, all education team members, which also includes professionals like occupational therapists, physiotherapists, and other members of society like the family members and relatives of the children. The education team members reported that they encountered parents who refused to accept that their children can also develop sexually despite the presence of a disability. So they reported that they often consider their children as children only even when they grow up. So to overcome these challenges, they expressed the need to provide support and education to parents regarding their children's sexuality. And the final theme, that is, children with disabilities are more vulnerable to sexual abuse. The participants expressed their concerns about the incidence of sexual abuse being more in children with disabilities. The reason being is that their impairments, along with the lack of sexual health education, were identified as the reason. So, majority of the findings of this study are similar to the studies that have been carried out in the other countries. The fact that talking about sex is considered a taboo in India was not reflected in the participants' opinions, as they emphasized about the importance of sexual health education for children with disabilities. Further research is recommended to develop comprehensive sexuality-related interventions and policies for children with disabilities. Implications for occupational therapy. The findings of the study highlight the need of training for special education team members to deliver sexual health related interventions. A team approach is also the preferred method to use to carry out these interventions. As we occupational therapists have a holistic approach to plan interventions, a unique role for occupational therapy in the team can be identified. Additionally, the curricula for professional training of occupational therapists can be modified to meet the need for training in the area of sexual health education. Also, occupational therapists can advocate for the need of sexuality related education in special schools where they are working. These are my references. Thank you.
Thank you, Dr. Pal. And now we have another paper on challenges faced during puberty in children with autism spectrum disorders. And I call upon Dr. Kimberly from Goa to present this paper.
Good morning, everyone. My name is Kimberly Banneto. I'm an occupational therapist from Goa. Today's topic is challenges faced during puberty in children with autism spectrum disorder, a qualitative study. The introduction. Autism spectrum disorder is a neurological and developmental disorder that affects how people interact with others, communicate, learn, and behave. Puberty is the time in life when a boy or a girl becomes sexually mature. While puberty is a stressful and difficult time for everyone, children with autism require more support as they navigate this new phase of life. The characteristic autistic resistance to change results in increased difficulty with alterations and additions to personal care routines, particularly during menstruation. Changing social rules, which become progressively more subtle and complex, may leave adolescents with autism socially isolated or experiencing mental health problems. The need for this study is that very little research is available on challenges faced during puberty in autistic children, and none in the Indian context. The purpose of the study is to explore the specific challenges that ASD children encounter during puberty and identify effective strategies to address their unique needs. The objective of the study is to explore the specific challenges faced by children with autism during puberty by the interview method using a semi-structured questionnaire to identify the problems faced by the parents and the children and the best ways to help them. This is the methodology. The research design was qualitative narrative study design. Sample selection was done using non-probability, convenient, and snowball sampling method. The study duration was from January to June of 2024. Sample size was 15 children with autism spectrum disorder. There were 10 males and 5 female subjects. Age group was 7 to 15 years. The study setting was in the state. Ethical approval was taken on the 29th of April 2024. The inclusion criteria was children with autism and no other comorbidities. children between the ages 7 to 15 years, informed consent from the parents, and children residing in the state. Exclusion criteria were children without ASD or with comorbidities, children with age less than 7 years or more than 15 years, no consent from the parents, and residents outside the state. Data collection was done using in-depth, semi-structured interviews were conducted with parents of children with ASD in person or telephonically as per the parents' convenience. Data analysis was done. 15 parents were interviewed. Data was summarized and collected and summarized. Data was interpreted in the form of themes. Discussions were formed. Conclusions were derived. Table number 1 results. Table number 1 shows the demographics of the subjects and parents. Total number of participants were 15. There were 10 males and 5 females. There was children's age was 7 to 15 years with a mean age of 8.6. Parents' gender was there were 2 fathers and 13 mothers. Table number 2 shows the effects of puberty in autism spectrum disorder in the children with autism spectrum disorder. The effects were behavioral change, that is increase in anger, social interaction, that is they were lonely or they had no friends. Physical changes include enlargement of genitals, formation of breasts, menses, facial hair, pubic hair, and change in voice. You can see that the number of males and the number of females that reported these changes. The themes formed were behavioral challenges, that is increase in anger and aggression, worsening of social interaction, decreased peer interaction. The third theme is knowledge gap, that is parents' understanding of autism and puberty. Future concerns were the parents' worries and child's themes. The first theme, that is behavioral challenges, in majority of the children, it is seen that the males showed more behavioral changes, that is anger and aggression. The children would have a tantrum, hit the family members, and or hurt themselves. One of the mothers said that he gets angrier and he can't control his emotions. He started hitting and biting us. This started in the past 6 months. The second theme is worsening of social interaction. When questioned about their child's friends, almost all parents shared that their child did not have any friend or a single best friend. If the child has a sibling, then that sibling is the child's best friend. Another primary caregiver said that she doesn't have any friend. I would say her brother is her only friend. Third theme is knowledge gaps. When the mothers were asked to describe what happens in puberty in their sons, they were not able to answer. In puberty, it is periods, breasts and all. I don't know about boys what happens. This was said by one of the parents. The parents stated that currently the child does not understand what puberty is and what changes take place in the body during puberty. However, 2 children had some idea of what changes are occurring in the bodies. The primary caregiver stated that he knows that girls get breasts and boys don't, and since he is also studying biology in school. Another parent said, I had explained to her every time I got my period. I showed her what a pad is and how to use it. I told her that her breasts will become big like mine. The fourth theme is future concerns. A lot of the parents voiced their concerns about their child's future. Some of them were marriage, career, and education. The others were fitting into society, communication, and future without the parent support. Discussion. Research by an author highlights that both children with autism and their neurotypical peers experience behavioral difficulties, social adjustment issues, and menstrual hygiene. The author suggests that adolescents should receive autism-related social skills training and education programs. The families need additional support on ways to communicate social and sexual skills to their child. In individuals with autism, unusual sexual behavior may stem from a lack of social awareness and understanding the boundaries. Additionally, autistic adolescents often struggle to regulate these emotions, intensifying the behavior. Similarities in these behaviors were also seen in other research. Boys typically engage in masturbation in the presence of others, incorrect masturbation techniques, hypermasturbation, and touching of genitals in public. Aggressive, repetitive, and behavioral obsessive behaviors intensify during the menstrual cycle in ASD girls. An autistic teenager may not be able to understand the consequence of their behaviors. Some of the behaviors observed in this study that were problematic are undressing in public to use the washroom, touching of self, and touching of others. It is observed that majority of the parents or the primary caregivers were not aware of the changes to be expected during puberty and how it can be challenging for their child. In another study, it was found that mothers had to take the full responsibility of the girls during, during their menstruation. Limitations of the study were a small sample size, confined geographic area. Given the sensitivity of the topic, only limited information was gathered. Interview of only one parent was conducted, and the level of ASD and IQ level was not factored into the criteria. Conclusion. Based on the interviews with parents, significant challenges faced by adolescents with ASD were revealed. That is behavioral issues, that is anger, worsening in social interaction, difficulty in understanding about the changes during puberty. These findings underscore the crucial need for improved parental education, use of correct terminology for body parts, and tailored interventions. The occupational therapist needs to assist the child by modeling self-care activities and demonstrating proper hygiene during puberty. Acknowledgement. I am greatly thankful to the Dean of our college, the Ethical Committee. I warmly acknowledge the continuous encouragement and support offered by my guide. I thank my participants for their kind cooperation. I would like to thank my parents, my family, and my friends. Lastly, I wish to dedicate my research to my cousin Grace, because of whom I was motivated to pursue this research topic. These are my references. Thank you.
Thank you, Kimberly. The next topic is presented by Nima Gosavi, an evidence-based literature review on the effectiveness of task-oriented training on hand dexterity and strength in children with hemiplegic cerebral palsy.
Good morning, everyone. Myself Nima Gosavi, and I'll be presenting an evidence-based review on effectiveness of task-oriented training on hand dexterity and strength in children with hemiplegic cerebral palsy. Background: cerebral palsy is a group of permanent movement disorders affecting posture, muscle coordination, and control. Among its various types, hemiplegic cerebral palsy is a condition where one side of the body is affected, leading to significant impairments in hand dexterity and strength. These deficits greatly impact a child's ability to perform daily activities such as grasping objects, writing, dressing, limiting their independence. In recent years, task-oriented training, or TOT, has emerged as a potential intervention in occupational therapy that focuses on repetitive, meaningful task practice. By engaging in meaningful tasks, patients experience improvements in their motor performance, which translates to better functional mobility and independence in daily activities. This approach not only reduces overall disability, but also positively impacts the quality of life by improving functional abilities. This training method is effective in both hospital and home-based settings, making it accessible and convenient for patients. While some studies report improvements in hand dexterity and strength, others show notable gaps due to differences in study design, intervention protocols, and outcome measures. This review will help develop rehabilitation strategies for effective task-oriented implementation, enhancing independence and quality of life in children with hemiplegic cerebral palsy. Need of the study: there is a notable gap in research specifically addressing the impact of task-oriented training on hand dexterity and strength in hemiplegic cerebral palsy. There are very limited number of researches conducted on effectiveness of this program in Indian contexts. Aim of the study: to synthesize the existing literature and determine the effectiveness of task-oriented training on hand dexterity and strength in children with hemiplegic cerebral palsy, and to provide an evidence-based insight to guide clinical practice and rehabilitation strategies. Objective of the study: to review articles related to the effectiveness of task-oriented training on hand dexterity and strength in children with hemiplegic cerebral palsy using the PRISMA, that is Preferred Reporting Items for Systematic Reviews and Meta-Analysis Guidelines, to produce an evidence-based synthesis of existing research. Methodology: Study design was systematic review. Databases articles searched include Medline via PubMed, ResearchGate, and Google Scholar. Registered searched include International Journal of Occupational Therapy and American Journal of Occupational Therapy. Keywords and search items: task-oriented training, hand dexterity and strength, hemiplegic cerebral palsy. So, sample selection, the inclusion criteria consisted of the studies which focused on task-oriented training on hand dexterity and strength in hemiplegic cerebral palsy, which were within the time frame from 2000 to 2023 and which were published journal articles only. Exclusion criteria consisted the articles which did not focus on task-oriented training on hand dexterity and strength in hemiplegic cerebral palsy, which were outside the time frame and which were non-published articles. So, data collection and analysis, identification of studies via databases and registers. So, during the identification process, records identified from the databases and registers and published journals were 82. Records removed before screening, duplicate records, records marked as ineligible by automation were 0. During the screening process, records screened were 82 and records excluded were 70. And during the screening process, full text articles assessed for eligibility were 12 and full text articles excluded were 9. So the included articles were 3. Results. These were the articles. The systematic review consisted of one systematic review study, one randomized control trial, and one preliminary study. The key findings within each study was analyzed and the 3 themes were formulated. First was significant improvements in dexterity, second was variable impact on grip strength, and third was influence of intervention duration and dosage on outcomes. First one, significant improvements in dexterity. Task-oriented arm training led to improvements in manual dexterity as reflected in increased box and block test scores, enabling better performance in functional activities. There was significant increase in box and block test scores. The task-oriented training group reinforcing the effectiveness of task-oriented training in enhancing hand dexterity. The improvement in BBT scores across studies highlights the impact of repetitive, goal-directed tasks in refining fine motor skills in children with cerebral palsy. Second was variable impact on grip strength. Grip strength improvements in the task-oriented training group were not statistically significant despite an increase in strength values. The overall improvement in functional tasks suggests that dexterity gains may not always correspond with strength gains. These findings suggest that while task-oriented training enhances dexterity, additional interventions may be necessary to achieve meaningful gains in grip strength. The third one was influence of intervention during the dosage on outcomes. Increased intervention dosage could lead to greater improvements in dexterity, as indicated by the box and block test scores. Repetitive task-oriented training contributed to functional gains, implying that session frequency and duration play a crucial role in maximizing outcomes. The variability in grip strength results across studies suggest that optimizing the dosage and intensity of task-oriented training could enhance both strength and dexterity outcomes. Discussion. The findings consistently indicated that task-oriented training or TOT led to significant improvements in hand dexterity, which reflected significant increased box and block test scores. These improvements were attributed to the repetitive functional tasks in TOT. However, improvements in grip strengths were less consistent, suggesting that while TOT is effective in enhancing dexterity, additional interventions may be necessary to target hand strength. Clinical implications. A deeper understanding of the impact of different task-specific activities and their unique contributions to hand dexterity and strength can help refine task-oriented training protocols, which may lead to more targeted, efficient, and adaptable intervention strategies that are easier to implement in clinical and home settings. Future studies should focus on long-term follow-up to assess whether improvements in hand dexterity and strength are maintained over time. Limitations of the study. There was selection bias due to some closed access articles. This review did not include studies printed in languages other than English and did not include non-published literature. The review primarily examined hand dexterity and strength without addressing functional independence or broader impact of task-oriented training on daily life. Conclusion. This systematic review highlights the effectiveness of task-oriented training in improving hand dexterity in children with hemiplegic cerebral palsy, promoting better motor control and independence. However, the impact of task-oriented training on grip strength remains inconsistent. While it enhances functional hand use, additional interventions can be incorporated for targeted strength gains. I would like to express my sincere gratitude to my research guide for providing invaluable guidance and advice throughout this research, and I would also like to thank the Dean of my college for giving me opportunity to conduct this study. These were my references. Thank you.
Thank you, Dr. Nima. Now I call upon Dr. Pavitra S. from Bangalore. She is going to present on effectiveness of occupational therapy intervention on circadian-based sleep pattern and daily routine in children with autism spectrum disorders, COSI experimental study.
Hi everyone, good morning. I'll be discussing about effectiveness of occupational therapy intervention on circadian-based sleep pattern and daily routine in ASD children. Introduction. Sleep is a natural state essential for both cognitive and physical development. Children aged 6 to 12 years need 9 to 12 hours of sleep. Circadian rhythm is 24-hour internal clock which regulates sleep and wakefulness. Children with ASD often struggles with sleep problem due to melatonin production and disrupted routines. Study shows 50 to 80% of ASD children have sleep problem, out of only 2% receive diagnosis and treatment. Occupational therapy play a vital role in regulating circadian rhythm and improving routines. So this study focuses how OT positively impact on improving sleep quality and daily routine in ASD children. My objective of the study was to determine occupational therapy intervention improving sleep quality and daily routine in ASD children. Hypothesis, we have two: alternative null, wherein alternative hypothesis tells it is effective in occupational therapy to optimize circadian based sleep pattern, wherein null hypothesis it is not effective in optimizing circadian based sleep pattern. This is a quasi-interventional study, used pre-test and post-test on 50 ASD children aged 6 to 12 years from developmental centers. Duration of the study was 6 weeks, 5 sessions per week, 30 minutes each session. We have used two scales: sleep disturbance scale for children to assess sleep and child routine inventory for routine adherence. Selection criteria, we have included both male and female aged 6 to 12 years with impact from parents via questionnaires. We have excluded comorbid conditions of ASD children, past history of seizure episode, and feedback from other rehabilitative professionals. OT intervention is a structured, practical, and personalized techniques to improve sleep and routine. So wherein we have 5 sessions. In session 1, it is introduction to routine and visual schedules. We have introduced role play and schedules to learn daily routines. And in second session, it was building routine independence, wherein we have practiced dressing, eating, and daily bedtime routines. Third session was sleep hygiene and play preparation, wherein we have encouraged consistent sleep. Session 4 was problem solving and challenges with play theme. We have used sensory play for the transition from play to sleep. Session 5 was review, play, and reinforcement, wherein we have educated parents in maintaining consistent sleep. Each session were customized for the child's circadian rhythm and active parental participation for the better outcome. Results show significant improvement between pre and post test. STSC scale is improved with t-value 32.82, p-value less than 0.01. CRI scale, which is child routine inventory, increased with t-value 12.8, p less than 0.01. Graph 1 shows decrease from total score of 62.39% and increase in the hour of sleep with 16.47%. In graph 2 shows it is a significant improvement with a mean difference 41 and 95% confidence in interval of 34.47.4. So these two tables and graph denotes structured OT improves sleep and routine in ASD children. So the discussion, OT intervention effectively improves sleep and daily routine of ASD children. Structured routine can reduce anxiety and enhance daily living, improving sleep pattern, enhance therapy progress and social skills. Early intervention is the key term for the long-term progress of ASD children in sleep and daily routine improvement. So while we have a positive impact on the study, there we have limitations as well. Excluding comorbid conditions may affect generalizability. Biological measures for circadian rhythm tracking were not considered, and cultural environmental factors were not considered. Daytime sleep quality assessment were also not included. So wherein this gives a further highlight for the further research on cultural and adaptive techniques for that. In conclusion, we have OT intervention significantly improve sleep and routine in ASD children. Aligning activities with circadian cycle can enhance daily function. Further researchers for personalized interventions. Parental education is the key term for the long-term progress. So this, I hope this study gives a importance of OT in sleep, addressing sleep-related problems of ASD children for the better outcome of parents and children. And these are my reference. Thank you.
Thank you, Dr. Pavitra. And I now call upon Dr. Redkar Simran to present a paper on socioeconomic status and visual perceptions in children, a systematic review and meta-analysis. Over to you, Dr. Simran.
Good morning, everyone. My study topic is socioeconomic status and visual perception in children. Shall I continue? A systematic review and meta-analysis. To begin with, socioeconomic status, it encompasses of various variables such as parental education, occupation, income that play a significant role in shaping a child's cognitive and perceptual development. Research has highly signified that lower socioeconomic status might influence various aspects of a child's functioning, including perception. Visual perception being a critical component of a child's ability to interpret and respond to their environment is particularly susceptible to socioeconomic status, as it involves a lot of cognitive processes that can be either hindered or fostered by environmental exposure and resources. It is quoted by several studies that children belonging to a higher socioeconomic status tend to have a better visual perception outcome due to a better access to enriched environments and educational opportunities than the low socioeconomic background children. This brings me to the rationale of my study, suggesting that socioeconomic status is a very influential factor for visual perception. However, this impact is not clearly understood, and this might hinder the evidence-based approaches, especially for occupational therapists. Therefore, a systematic review and meta-analysis on socioeconomic status and its influence on visual perception is needed to understand how these factors affect the development and the remediation of these skills. Furthermore, in a broader scope, this review will also guide occupational therapy practitioners in addressing the health disparities related to socioeconomic status. By understanding socioeconomic status as a modifiable risk factor, a therapist can also advocate for policies and practices that can enhance better outcomes in developmental therapies and at school settings. So the aim of our systematic review and meta-analysis was to synthesize findings from existing literature on the impact of socioeconomic status on visual perception performance in children, for which we used the study design of a systematic review and meta-analysis and followed the guidelines of PRISMA. We first registered our review on Prospero. We used the following databases that were Scopus, PubMed, ProQuest, Cinehel, EBSCOhost, and OTSeeker. For our inclusion criteria, we targeted on studies that have an impact of socioeconomic status on visual perception between the ages of 4 to 12 years, published between Jan 2004 till October 2024, available in full text in English, level 1B, 2B, and 3B. Levels, systematic reviews or other meta-analysis, case studies, and case series were excluded from our criteria. This was a search strategy generated using the following MASH terms for visual perception, socioeconomic status, and children. For the methodology of the meta-analysis, we used the software data, and for data extraction, we used sample size, mean, and standard deviation. We used the random effect models, and for the effect size calculation, we generated standard mean difference and 95% confidence interval. We also conducted a heterogeneity assessment using the Cochrane's Q test and depicted the results in the form of forest plot. So the results of my systematic review, at first the records that were generated were 842, of which 4 were handpicked. We used the software Rayan to erase the duplicates and conduct the title, abstract, and full text screening. On full text screening, we assessed 12 articles that were eligible for the full text review, of which we had to exclude 5 of them and finally include 7 for our qualitative synthesis. These are the main findings. So the main findings of our review suggest that there are several components such as visual sequential memory that have an impact both on visual perception and socioeconomic status. Children belonging to high socioeconomic background, especially high educated parents, have a better outcome. The children belonging to lower socioeconomic, their visual perception score was lower than the children belonging to a higher socioeconomic background. Also, the lower socioeconomic type impacted their academic performance as well as visual perception. And children belonging to lower socioeconomic status, nor did they just reveal a lower score, but also a delayed development in the visual perception. Another 2 studies, they suggested that socioeconomic status would be a strong predictor for visual perception performance, as well as it is a strong demarcator of when we consider to form any normative values. So on a whole, major studies were cross-sectional. The age ranges they considered were 5 to 12. The major socioeconomic variables they studied were household income, education, occupation, ethnicity, urban and rural, age, gender, race, and socioeconomic status on a whole. Berry BMI was the most commonly used test to assess visual perception. For the critical appraisal of the study, we use the Axis tool. It has a set of 20 questions, and the responses are generated in yes, no, and I don't know. The major drawback of all these studies were there was no sample size justified. The non-responder bias was present. Selection bias was also there. Certain studies also lacked basic data, basic demographic data, as well as informed consent. On a whole, the major deficit that we found was in the methodology part. For the meta-analysis purpose, we took the 7 studies that we generated in the systematic review. However, we had to exclude 2 because 1 did not specify the sample size in the socioeconomic group, and second, they conducted only the correlation analysis. So here's the forest plot depicting the results of the meta-analysis. On the left, we have all the 5 studies, of which I have highlighted one outlier study, that is Waldi et al. 2018. Due to this study, the p-value was not significant, which we found to be 0.25. We then tried to see whether this outlier study has a major impact on the results. So then we conducted a leave-out analysis where we excluded this study and again conducted a meta-analysis, and then the results were significant. So the major drawback was the study that was the outlier. The p-value was then significant, it was 0.01. In discussion, this review suggests that socioeconomic status is highly influenced by visual perception. Children belonging to a higher background and a higher background in terms of income and education exhibited better scores. So this tells us that early access or better access to resources, quality, education, and family socioeconomic status can definitely impact visual perception. Also, our study has a strong influence on parental employment and education. So this also suggests that parental engagement and home environment is influenced by socioeconomic status. We found only one study that was longitudinal, but then again, even in the longitudinal study, the results were similar. So this also suggests that low socioeconomic status may have a lasting impact on cognitive and perceptual development. In our meta-analysis, we found similar findings. However, this was only confirmed when we did the leave-out analysis, and they were only on 4 studies. So we need a little more studies to confirm our findings. The key highlights of our review is that all the studies generated a similar finding indicating a global concerns. Clinicians and policymakers should focus on these factors when we plan intervention programs. The limitations of our study are only studies published in English were considered, most were cross-sectional and used different visual perception tools. Clinical implication, early identification and targeted interventions for lower socioeconomic children would definitely benefit. A multidisciplinary approach would, however, be fostering visual perception development. Educating parents, especially on visual perception enhancing activities, can help us implement better policies and provide early access to these resources. In conclusion, the systematic review and meta-analysis underscores the robust impact of socioeconomic status on visual perception development. These findings highlight the need for early intervention, especially children belonging to lower socioeconomic families, and suggest the major factors that we have identified through our study. There is significant variation in the findings of our meta-analysis, so further subgroup analysis may explain why these differences came about. Ultimately, this review supports the development of inclusive targeted programs and policies that might help mitigate these socioeconomic disparities for children and for better outcomes of visual perception. These are my references. Thank you. I take this opportunity to thank the organizers of OTCon 2025 and my guide for his constant support. Thank you.
Thank you, Dr. Simran. Now I call upon Meenakshi Batra from New Delhi to present on determine correlation between repetitive behavior, social emotional development, and playfulness in neurodivergent children.
Good morning, everyone. All the chairpersons, delegates, professionals, and students. Myself, Dr. Meenakshi Batra. Can I have the slide, please? Yes. Myself, Dr. Meenakshi Batra. And the topic of my study is determine correlation between repetitive behavior, socio-emotional development, and playfulness in neurodivergent children. The clinical indicators of children with neurodiversity may include repetitive or stereotypical behaviors, restricted interest, and poor interpersonal skills. The behavioral challenges are of significant concern for play skill development, and the characteristic behavior apparent during free play has been associated with socio-emotional skills. Difficulty in playful engagement and social interaction poses a great challenge. So the study was conducted to see the interrelationship between the playfulness with socio-emotional aspects of behavior. That was the research question, to determine the correlation between repetitive behavior, socio-emotional development, and playfulness in neurodivergent children. It was the second phase of the study, primary study, which was an intervention-based study. It was purely the correlational study design, and the data source was secondary analysis of existing data. So the internal secondary data research was being carried out for the primary research, and it was a data-driven approach. The background research from which the data pool was being taken, effectiveness of socio-emotional strategies for augmenting play engagement in children with neurodevelopmental delay. The 32 subjects were allocated to two groups with different intervention based on the conventional strategy versus the socio-emotional strategies, and the intervention protocol was given to both the groups, and re-evaluation was done after 2 months. The informed consent and the ethical clearance was obtained, and the subjects were evaluated for these variables. Repetitive behavior, which was divided into 5 types: stereotypic behavior, self-injurious behavior, compulsive behavior, ritualistic behavior, and restricted interest. Social-emotional skills, which was again based into 5 domains: self-management skill, self-awareness skill, decision-making, relationship skill, and social awareness skill. Test of playfulness for the extent, intensity, and scalefulness. This was again the intervention, which was the primary phase of my study. The brief about the scale, it is RBS is an informant reported scale having 43 items and 6 subscales rated from 0 to 3, and all the 5 domains were calculated. Test of playfulness, 21 item questionnaire rating from 0 to 3. Repetitive behavior scale, again 5 domains ranging from 0 to 3. And the domains of the socio-emotional development skill checklist, which was again divided into 5 domains score ranging from 0 to 4. The data was analyzed for normality, and since the distribution was found skewed, non-parametric Spearman correlation coefficient was calculated with IQ range at 95% confidence interval with P less than or equal to 0.05 using SPS20 software. The correlation coefficient was calculated for all these three domains: differentially, RBS with socio-emotional developmental skills and test of playfulness, and test of playfulness with socio-emotional developmental skills. This was the tabulated presentation of the degree of correlation as shown by the degree of rho, and the differential finding was formed. There was no monotonous correlation between any of these two variables, like negative correlation between the stereotypical behavior for some domains like self-management and self-awareness, and for the skillfulness under the test of playfulness and the stereotypical behavior was also found to be negatively correlated. While for the compulsive behavior, it was positively correlated with the domain of compulsive behavior under repetitive behavior scale versus the social awareness scale. Whereas for compulsive behavior and the test of playfulness for all these three domains, that is extent, intensity and skillfulness, it was also found to be moderately positively correlated. Similarly, for ritualistic and sameness behavior, there was a mild degree of correlation, but on a positive side, between the ritualistic behavior versus the self-management, and intensity, skillfulness domains of the test of playfulness versus the ritualistic behavior. And for restricted interest, just for the social awareness scale, there was found to be just one positive correlation, although to a mild degree. And the correlation between the test of playfulness versus the socio-emotional development only for the variables self-awareness and social awareness with skillfulness, it was found to be mildly correlated positively. So it was a scatter plot, although it was not a monotonous relationship, but just a visual representation. So this is the summary of the presentation. The result, the degree of correlation between socio-emotional skill and several domains of repetitive behavior skill has been inversely related, although of a variable degree. There was no clear-cut monotonous linear association being found. Stereotypical behavior versus self-management and self-awareness skills, as demonstrated by the value of rho, which is a Spearman correlation coefficient, was found to be minus 0.4 and rho minus 0.4 for both these two domains. Self-injurious behavior versus relationship rho was again negative correlation minus 0.31 and weak negative correlation. Compulsive behavior social awareness rho, the value of Spearman correlation coefficient 0.42, moderate positive correlation. Stereotypical behavior and skillfulness, the degree of correlation was moderate but inverse. Restricted interest and extent of play, it was minus 0.22, showing a weak inverse relationship. Other domains like ritualistic and compulsive behavior, degree of association was moderate with extent, intensity and skillfulness as shown by the Spearman correlation coefficient, which is 0.22, 0.36, 0.51 and 0.54, 0.61 and 0.65 for these two domains of RBS. Discussion, the test of playfulness and socio-emotional development skills show a weak correlation for most of the components. The moderately weak positive correlation between self-awareness and social awareness with skillfulness. As we know that play incorporates the element of cooperation, sharing and interpersonal interaction, which influences the socio-emotional aspect of play behavior, which was evident in our study by the correlation coefficient between the two, that is socio-emotional developmental skill and test of playfulness, although with a differential and variable degree, lacking a clear monotonous association. That was the finding of a few researchers also. The mixed pattern of association between the repetitive behavior scale versus socio-emotional skills and test of playfulness indicates that repetitive and stereotypical behavior alone cannot attribute to the lack of playfulness and socio-emotional developmental skill. However, to better understand the precise degree of association, the wider and overall spectrum of clinical and functional profile must be included, which plays a critical role to govern the correlation between test of playfulness, socio-emotional development skill, and repetitive behavior scale. So conclusion, this study supports the argument that although the stereotypical behavior bears inverse relationship with test of playfulness and socio-emotional development, but the presence of other factors like cognitive abilities based on the high or low level functional skills are always a detrimental factor to find the exact correlation or association between the two. So the study concluded that owing to a diversified spectrum of presentation of repeated and stereotypical behavior and its underlying causation, within the functional context, the broad indices of the mental health within one's functional and clinical behaviors must be incorporated to come to a conclusion within the neurodiverse situation, which was one of the limitation of my study also. These are my acknowledgement. I have my deepest gratitude to my client population, the caregivers, for their continuous support and accomplishment of my study. And the list of references. Thank you, everyone.
Thank you, Meenakshi.
Thank you, ma'am.
So this session is open for the questions, but please note, maximum 2 questions. I'm emphasizing on questions, no discussions, no suggestions. If you want to give suggestions or discussions, you can meet them personally and explain to them. Thank you. So the first speaker. Any questions? Please raise your hand and introduce yourself. Okay. You are Neha. An evidence-based review on the effect of premature infant oromotor intervention on feeding in preterm infants.
Any questions from the audience? If no, then can I ask? Yeah. Was there any article which had comparison of different treatment approaches with PYOMI? Because the articles which you said all had only PYOMI and showing their effectiveness when you did the systematic review.
Ma'am, some of the articles were there using POME as adjunct with other therapies such as non-nutritive sucking intervention and kangaroo mother care, which has shown effectiveness. But I had not taken that articles in my review, as my articles were only solely practicing on POME programs, as I wanted to see the effectiveness in that intervention.
Any article with negative effect?
Ma'am, throughout my review, I have seen the studies had shown no adverse side effects as such, but it has shown that preterm infants having ventilatory support or having respiratory difficulties should be given more time, and external supervision is required more during giving the POME program during the intervention time. So we have to be more cautious for ventilatory preterm infants. Yeah, thank you so much, ma'am, for the question.
Yes, please.
Thank you for the wonderful paper. From my experience, I want to tell you, dysphagia management is one of the area where OT has a lot to do. And, premotor intervention is a very good thing. But, my suggestion or my question is, why don't you look into the holistic nature of the occupational therapy intervention for the premature infants? Because we always talk about one particular thing, which is actually a speech therapy does it. Why don't you look into the holistic nature, which is actually the real work of OT? So why you're not looking into that part of the management?
So it is a future implication where we will be practicing the POME program with which has an effect on neurodevelopment and on behavioral effects such as speech improvements and other oromotor abilities, which is like a future implication where we can conduct a RCT, which is a large multi-centered practice wherein we can incorporate other interventions and practice together with POME program. But as in it is a new intervention, we are only focusing on POME program solely.
Okay, so one more thing, the feeding or eating is the basic ideal which you need for survival. From the time you are born, till you die. That is the basic thing you need for survival. So it's a very much important thing. So that part of the this thing also, the intervention also can be mentioned over here, because like I have my experience. I treated a patient who was on the ICU on the third day of the birth. I treated, and they came to me after like around 20 years. They said what the child achieved in that 20 years was the only thing is that feeding, or the child is able to eat independently. The other areas the child was not able to do. It was that severe a case. So the early intervention is quite a good thing about patients with dysphagia. Okay.
Thank you so
Thank you.
much,
All
sir,
the
for the
best.
question.
Thank you, Joseph. We'll call upon the next.
Thank you, ma'am. Thank you, everyone.
Yeah, so we have Dr. Nikita, who presented a paper on exploring the role of occupational therapy in assessment and intervention in children with ADHD. So any questions for Dr.?
Can we have some lights? Can we have some lights in the in the audience or in the auditorium? Some.
No. Yeah, thank you, Doctor.
Excuse me, ma'am, I have a question for her.
Yeah.
Yes, I just want to know, you were doing an exploratory study, right? So just what were the salient themes that involved?
So the first theme involved how the primary areas the occupational therapist focused on. Okay, second was the parental concerns for their ADHD children. The
These were the two things.
No, ma'am. The interview involved 5 themes. First were that the areas the pediatric occupational therapist focused on. Second were the challenges encountered by the occupational therapist. Third was the parental concerns for the ADHD children. The fourth reviewed. The fourth were the variations, and yeah.
Because I had a question on your presentation of the results, the conclusion, because it was not aligning with the exploratory study that you do. So that was
Okay.
the thing,
So
probably.
yeah, ma'am,
Maybe
it was
we can
the
discuss over a cup of
yes,
coffee. We don't
sure.
have to-
Yes, ma'am.
Okay, thank you.
Yeah. Thank you, ma'am.
Yeah, one more question to you is your sample size is very small and there are so many occupational therapists working in the field of pediatrics. So why couldn't you generate data from the other occupational therapists? And that too, your cases were ADHD.
Yes, ma'am. So my sample size was 15. My data had already reached a saturation point. So therefore, I took few more extra and then I concluded my study.
So for this study, it was less.
Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
Thank you.
The next speaker was Patra Trisur and her, right, no? Yeah. Her topic was effect of repetitive stretch through activities of gross motor skills in improving play participation in children with CP, spastic CP, a quasi-experimental study. Any questions from the audience?
Hi, good morning. I'm Samil from Mumbai. So my question is that your inclusion criteria, you mentioned the age of the children. Was it the chronological age or the developmental stage of the children? Because if that was the developmental stage, then the play pattern and the play function and the play stage would definitely vary. So that is what my question is.
So it was considered, the chronological age of the child was considered. But according to the GMFCS level, the children who were able to walk with or without orthosis were included in the study. So based on that, the play participation was assessed.
You are correlating the play only with the physical motor aspect of the child?
Yeah.
Okay, thank you.
Thank you.
So actually, one thing I want to add, the experimental group received the repeated stretch and usual occupational therapy. The therapy which was provided to both the groups actually address all the domains of play. Like repeated stretch only address the physical, focusing on the gross motor skills, but the activities that were provided in usual occupational therapy addressed the play skills, social skills, and cognitive skills required while playing. But it was actually related to the physical play. Yeah, yeah. Thank you, sir.
Anyone? Can I ask you?
Yes, ma'am.
You have, first of all, I have few suggestions to all. Everyone has presented it very well, but there were lack of pictures, particularly those who are, for example, in your presentations, not a single picture. And I think we organize the Kote programs. For that reason, you must have seen in the morning of the first day of the conference, beautiful pictures, beautiful videos. Yes, I understand the videos and all, but in 10 minutes, you can parallelly show the videos and your pictures and your your whatever text, you can do it. That makes lots of, difference to understand. Now, for example, I could not understand the repeated stretch. How did you do it? How, in what, some circumductory, something you said. If you would have shown me the picture, it would have been better understood. So can you just tell me that how did you, and why repeated stretch, like in what way you did it? Can you just explain?
Thank you first for your suggestion, ma'am. Ma'am, actually, today early morning, I shared my PPT with a picture, but it was not visible today in this presentation, as I think this presentation was submitted on the first day, so that's why the picture was not there. So
Okay.
sorry for the inconvenience. Ma'am, actually, repeated stretch was provided for the upper extremity and lower extremity, particularly targeting the shoulder and hip joint. For the shoulder joint, a ball which was connected to a handle. I think if the PPT can be shown, I
Okay.
can show the picture.
Okay, no problem, no problem.
So that handle was connected to a ball. A wooden board was there with different circular grooves. So the child had to hold the handle of that ball and rotate it in an anti-clockwise direction. So here flexion, abduction and external rotation was used. Usually children with hemiplegic cerebral palsy show synergistic patterns of movement. In order to break those synergistic patterns and develop functional synergy required for play participation, this activities was provided. Next, for the lower extremity, hip circumductor was provided in standing position, so that also we have to rotate it in an anti-clockwise direction. So here also we used actually the PNF technique, specifically the flexion, abduction and internal rotation, to break the synergistic pattern in lower extremity, because these children have more of extension and plantar flexion will be there. So if the child is if we will be able to break the pattern, the child will be able to walk, which is required for playing. So play being an important occupation for the child, we need to work
Yes.
on these areas.
But do you think the play comes under occupation of the child?
Yeah, ma'am, it is
So
an
because you
important.
had divided the occupation based activities and the play based activities.
ma'am.
So that is just a suggestion. The play is also a part of occupation of a child.
Yeah, ma'am.
Yeah. Thank you.
Thank you so much, ma'am.
Yes, so next we have Dr. Payal. Yeah. So Dr. Payal presented a paper on perspectives of special education team members regarding sexuality of children with disabilities in special schools. So any questions for Dr. Payal?
Hello, myself Dr. Kamalare from New Delhi. I have one question that how would you justify your study as per of the profession of occupational therapy, and what type of qualitative study you used in your design?
Okay.
Thank you, sir, for the question. So it is more of a team approach that we use in special schools and when we work with children with disabilities. So my primary aim was to take the perspectives of all the team members, not just limited to special educators. But as I went about with the study, I found most of the participants were special schools. So after my data analysis, I changed the title to special education team members. Earlier it was initially it was more directed towards all the education team members. So as a team member, we occupational therapists can educate the other team members to how to go about this intervention, like sexuality related education and interventions. We can plan them accordingly. So and qualitative study, it was more about like focus group interviews were used to generate their perspectives. So this was my qualitative study. Yeah. Okay.
Rupal, first, kudos to your study.
Thank you, ma'am.
And just want to have one question. What is that one challenge that you would say when you were doing the study?
Challenge, surprisingly, I would not say that it was very challenging. Like initially, when of course it is a taboo topic, and I expected that people would hesitate or people would not speak about it, but they were very outspoken. Like even during the focus group discussions, all the participants, they did not hesitate, and in fact they emphasized and they empathized with the idea that yes, it is the hour of the need and we need to speak about these things, because it often goes unnoticed, and there are no, like, even though we are occupation centered and we all we do not include this occupation in our interventions. So yeah, that is what. Okay. So surprisingly, there were not many challenges for that.
Thank you.
Thank
As I
you.
said, modules are already in place. I've made 2 modules for that. If you need, I can share it with you. Modules for intervention for sexuality.
Okay.
It will be published soon, so
Oh,
probably you
that's
can
great.
access it. Yeah, thank you.
Thank you, ma'am. Yeah. Yes.
Yeah, you have done the perspective of a special educator when they are seeing the child, and that perspective has been put up into themes, and then it has been concluded that problems with sexual education is needed because the children are having problems. But you have told about the problems of sexual problems, but you have not mentioned why they are occurring in ASD, which is the main thing which we are going to tackle. So the educators know why a ASD person, even a girl going into puberty, why she has those problems. Otherwise, all normal children also has the problem.
Right. Okay. Yeah, I got the, like, it's a feedback. Yeah.
Excuse me, ma'am. I have one question. It's good study. I myself.
This should be the last one, please.
Yes, ma'am. So myself, Dr. Vineet. Yes, I'm here. So did you include psychosexual stages in your study? Because I'm an occupational therapist. We have much more barriers and fixations while we're dealing with psychosexual stages like oral, anal, phallic, latency, genital. Is that anything in your study?
No, sir, I did not include those stages as such, because it was more of what the special educators think about that. So we did not look at children as such, like what children are going through or what stages they are at, or are they fixated on any one of the stages. But it was more about what they encounter during their practice as
Special education couldn't encounter?
like
if it is fixations comes like oral, anal, face and all, as we occupational therapists have encountered more in our practice,
Right.
psychosocial stages,
Yes.
well-being, etc.
Now that I think of it, of course, like there are behaviors that they reported, like people, like children being fixated with putting things in their mouth, or playing with their private parts. So yeah, that all of that was included, but I did not place it, or I did not see the use of any of those terminologies in my
More
study.
genital part, it will be like ASD, more prevalence as per study shows.
Yes, and I just wanted to clarify that my study was on all the children with disabilities, not just limited to children with autism spectrum disorder. So yeah, so various experiences they have shared, but yeah, not in this light of psychosexual stages of development.
Okay.
Thank you.
Yeah. So if there are no further, I think
Excuse
let's
me.
move on to the next speaker.
I'm Dr. Deepa Udyar from Mumbai. I fully agree with Dr. Pratibha Vaidya. This was more like a survey study, right? Because it's already known fact that there are sexual problems in children, and government has also regulated Sati Savitri cell in special schools. When you were dealing with special educators, you have been come to know about it. So, any protocol you have devised for these special educators, how to tackle these problems, being an occupational therapist?
No, ma'am, not protocol. Mine was more like, just as you said, maybe it was more of a survey. It looks like a survey, but in order to develop the protocols, in order to develop the modules, we need to have need to know what are the experiences and perspectives of the team members who are working in this area. Are they even really working in that?
Yeah, there are of course many people working. I am also attached to many special schools in Mumbai and Karnataka and Lonavala. And though we have developed a protocol and we are already working on it. So I think it would be more nice if you could throw light on it, ma'am. Yes?
Was basically on getting the perspectives rather than developing a protocol.
Yeah. So I think there's further scope of study
Yes,
in
definitely,
this.
ma'am. Yeah, yeah.
Thank you.
Thank you, ma'am.
Thank you.
Thank you.
I have to call. The next speaker was Dr. Kimberley, and her paper was on challenges faced during puberty in children with ASD, a qualitative study.
Yes, please.
In one of your slides mentioned that there were certain behavioral challenges like development of anger after puberty. So my question for this particular statement is that the development of anger was as a normal part of the hormonal changes or the psychosocial changes the child is going through, or it was because of the unnatural reactions from the environment which were shown towards these children.
So a lot of the parents mentioned that the child used to have anger from the very beginning, but this has worsened. One of the narratives from the parents was that they have increased in the anger or aggression in the past 6 months. So according to my conclusion was the child used to they had behavioral issues, but after the start of puberty, it has worsened or it has increased. They have got they have got angrier. So that's why it was the behavioral changes or the challenges was that they had increase in anger and aggression. But it has worsened after the start of puberty.
Yeah, hello.
Yes.
I'm Dr. Swati from Odisha. You took the sample from 7 to 15 years of age. So that is mostly after 12 years of age, that is adolescence, towards. But you have put it like in children with autism from 7 to 15 years. Okay, are there any self-report questionnaire or something for the children? Because it is up to 7 to 15, so they can self-report about their issues or something.
Yes, self-reporting for ASD children is very rare, but the age group, I will answer the question as why I've taken that particular age group, is recent studies have shown that puberty is occurring in the earlier age groups, like compared to previous studies. And in the past 2 decades, studies have been done wherein wherein puberty has been occurring earlier up to even 12 to 18 months. So physiologically, puberty used to start at the age of 8 to 13 in females and 9 to 14 in males. If you get that lower, it becomes around 7, and that's why the age group is 7 to 15. In a study done in the US, it was noted that breast development and pubic hair has started showing in white females at least 1 year, on average 1 year prior, and in African Americans at least 2 years prior to the normal age of puberty.
You have mentioned that you have taken interview of one parent,
yes.
right? So all the codes of you have mentioned all the codes. It's of one parent only.
No, there were 15 parents that went. There were 15, the entire subject sample size was 15. So the primary caregiver was the parent that I interviewed.
Okay, so there were no self-report or something of the children, like how
No.
they felt about.
Due
So
to the
we could have-
communication issues that the autistic children
But they
face,
are,
it would be difficult for them to perceive my question and answer it accordingly.
Okay, fine. Thank you.
Did you use any software for your results? Software for analyzing the.
No, ma'am.
No.
It was the interviews were conducted using a semi-structured questionnaire. It was either in person or telephonically according to the parents' convenience, and that was put into themes using thematic analysis.
Yeah, even at analysis part, I'm asking.
It was used in Word Excel sheets.
Okay.
Next one, please. Yes, thank you.
Thank you, ma'am.
Oh, acha, only one question, please. Only one.
Yes, you have mentioned in your slide uncontrolled masturbation. Unhealthier masturbation. What do you mean that? And do you have any review of literature says that unhealthier masturbation?
I don't think I mentioned the word unhealthy.
Or uncontrolled?
It was abnormal, as in usually in neurotypical.
What's your review of literature?
There have been multiple studies showing
Do
that.
you mention here?
Yes, my primary study was by Remington, M. Remington. In that it was mentioned, and also in the further studies that were mentioned.
They mentioned the same term, unhealthier.
Yeah, there was no unhealthy, there was abnormal.
Abnormal.
In the sense, it means that they don't do it in private as a neurotypical
So there is no
individual
normal and
will do it.
abnormal masturbation, actually.
It's abnormal sexual behaviors.
Okay.
That has been mentioned in other reviews.
If it is review, well, that's fine.
Yes.
And
Thank
it is,
you.
Yeah, we have seen also the patients doing those abnormal behaviors. Yeah.
Thank you, ma'am.
Thank you.
Thank you.
The next one is Dr. Nima Gosavi. An evidence-based literature review on effectiveness of task-oriented training on hand dexterity and strength in children with hemiplegic cerebral palsy.
Yes.
Any questions, please? I would appreciate the people from far also should take interest and ask questions.
Myself, Dr. Kamalare from New Delhi. Yes. Just can you clarify how did you use ResearchGate for your analysis or as a database?
Sir?
You specify ResearchGate is a search engine for your reviewing the articles. ResearchGate database.
So I've searched for articles in the ResearchGate.
But it's a social site for the researcher. How can you use, I don't know, is there any way to search articles on that site?
So,
by using ResearchGate, what did you do?
So I've searched for articles like whether there are research is conducted on task-oriented training, on task-oriented training specifically, and then I've seen for the authors also whether they have done studies on task-oriented training.
Okay, thank you.
Can you please let me know what are the comorbid conditions you have mentioned? No, you have excluded the comorbid conditions. So what did you use to exclude those conditions?
I didn't get, ma'am.
You, in the exclusion criteria, you
Yes,
have
ma'am.
mentioned you have excluded all the comorbid conditions.
No, ma'am.
Yeah.
In the exclusion criteria, I've mentioned that I have not included the studies which did not include focus on task-oriented training on hand dexterity and strength.
Thank you.
Yes, ma'am. Thank you, ma'am.
Yeah, so we have Dr. Pavitra now from Bangalore who presented a paper on effectiveness of occupational therapy intervention on circadian based sleep pattern and daily routine in children with ASD. So any questions for Dr. Pavitra?
Yeah, one question from me. You are talking only about the sleep patterns and the effect of your sleep therapy given to him after few sessions. What about the confounding factors? Was he given medications?
No,
None
ma'am.
of them?
No.
And then other confounding factors, you have written it as limitation, like environmental, means
Cultural and
social
yeah.
environment present
Yes,
in the house, then how the child is being accepted in the society, that you have mentioned at limitation. So I don't know. But no, none of the patients were given medications?
they were giving medications not for the sleep, like for the, like, suppose if they are so much repetitive and impulsivity, no, for reduction, for reducing that only the medication has been given, but not for the sleep.
And secondly, have you considered the time,
For, ma'am?
the amount of time he sleeps and the time you are asking the...
Yeah, yes, ma'am, yes, ma'am. Because through the scale, no, sleep disturbance scale, so we have assessed through that. Yeah.
Thank you.
Ma'am, there.
Yes, please. I'm so happy. Somebody from far.
As Madam said, have you maintained sleep diary?
Sleep diary.
Yes.
For daily things.
Yeah.
Yeah, parents, like after each session, parents will be reporting the consistency of the sleep and how they are like,
Yeah, sleep hygiene
having a
maintenance.
disturbed
Yeah.
sleep. Yeah.
Have you mentioned it here?
Yeah, through the study, it is like, it
No.
is in this.
We are not listening. Sleep diary need to be mentioned as per what Pratima ma'am said.
Yeah. Okay. Yes.
Thank you.
I'll look.
The last one.
Hi, I'm Dr. Sumit from Mumbai.
Yes, sir.
Sleep, when you say, my question is very basic on a physiological level. Sleep is a parasympathetic nervous system activation, right? And in autism, most of the time child is, because of the repetitive behavior, because of the some kind of a feedback is missing, and number of sensory integration issues they are going through. So their sympathetic nervous system is always activated. What are the activities you generate to activate the parasympathetic nervous system, which helps the child to develop sleep as a organic manner?
You're asking about some, like, how they are going for a sleep from the stimulus of the thing?
Activities.
Yeah. So we have used sensory play, and when we are making a session, no, it is like the schedule has been given to according to the circadian rhythm that they have to do it in a proper time, and for them to go back to the sleep, we have used a sensory play, as they have already a sensory problem. Most of the ASD kids will have a sensory problem, so which they like, that activity we have given to them, like it is a personalized thing, like how each kid will be liking some of the other activities, no, so we have taken that and we have given that activity before they go to sleep to make them calm. After then they'll be sleeping.
Thank you. Thank you.
Yes.
Dr. Simran? Yeah, so we had Dr. Simran presenting a paper on socioeconomic status and visual perception in children, which was a systematic review and meta-analysis. So do we have any questions for Dr. Simran? Yes, ma'am.
Dr. Simran, I wanted to know why did you want to do both a systematic review and a meta-analysis?
Thank you for the question, ma'am. Ma'am, actually, when I did a systematic review, I understood that there is a commonality in the results that I'm able to find. But that was since systematic review is a qualitative synthesis. However, critically, I try to analyze it. I wanted to see whether quantitatively also I am able to establish the similar relationship or no. So that's why I conducted a meta-analysis to confirm the impact.
Okay. In fact, you can put these two things as two different studies too.
Yes,
That will add strength to your CV as well.
Thank you
As a
for the
suggestion.
suggestion,
Yeah.
ma'am.
No more questions? Thank you. Thank you,
ma'am.
Dr. Simran. And we had the last paper from Dr. Meenakshi Batra on determining correlation between repetitive behaviors, socio-emotional development, and playfulness in neurodivergent children.
Dr. Meenakshi, I wanted to know what is the implication of knowing all these correlations?
Okay. As I said that it was the secondary analysis of the pre-existing data, which was done as a part of interventional study. So, because I came across literature stating that differential components of the repetitive behavior, like ritualistic and sameness behavior and compulsive behavior, they had been found to be positively associated with the extent of involvement as on test of playfulness. Whereas we know that extent of playfulness is something which demonstrates the active engagement of the child, which is reflective of a normal play, whereas it was not. Secondly, I also, after literature review, I also found that there was some components of the test of playfulness which is associated with the relationship and self-awareness skill. So to get into in-depth analysis of that on all these subdomains, I did this secondary analysis. That was the main objective.
Because I couldn't find any novelty in this. That's why I was just trying
This was
to.
not it was not novel in a way of intervention, but of course, to find a subdomain, as I said, that there was very multiple limitations that I came across after conducting the entire correlation, and that was something I think elemental, which can be taken up in my next study.
Okay, sure.
Thank you. Thank you, Meenakshi. So we'll end this program.
Thank you, ma'am. Thank you.
Yeah. Before this, I would, on behalf of my full team, we are thankful to the team, the scientific committee team, who have given us the opportunity to be present here and listening to these presenters and asking the questions from the audience and all. Thank you very much. And you, all the presenters were too amazing. Thank you, all the presenters. Thank you, audience. Thank you.
Thank you, ma'am. I would like to extend our gratitude to our respected dignitaries for chairing this session. Now we are moving to the felicitation. I would like to invite Dr. Pankaj Bajpai Sir, Honorable President, All Indian Occupational Therapy Association, to felicitate our respected Dr. Jyotika Bijlani, ma'am, Dean Accord, with a memento and a certificate. Thank you, sir. I would like to invite Dr. Samantha Shan, ma'am, Honorable President of WFOT, to felicitate our Dr. Vaishali Joshi, ma'am, Professor and Head of Department of Pediatrics, GMC Goa, with a memento and a certificate. Thank you, ma'am. I would like to invite Dr. Vijay Badra sir, Executive Member of ACCOT, to felicitate our Dr. Pat- Pratibha Vaidya ma'am, Vice President, ACCOT, with a memento and certificate. Vice President of IOTA. Thank you, sir. Thank you, dignitaries.
Dear delegates and dignitaries, I hope you all are having a fruitful time at the OTCon 2025, which has been made possible thanks to all of our sponsors. Now, I would like to take a moment to express our gratitude and appreciation to all of our sponsors. Our platinum sponsors, Speech Gears, Therapeutics for Ultra Kids, and RCM Healthcare Services, Foreign Recruitment Specialists. Our event partners, India Medico Instruments, Isaac Group LLC Healthcare Staffing and Recruitment, Godrej Interior, Matrix Rhythm Therapy, Akara Foundation, Treasure Island Therapy, Digital Interactive Rehabilitation Systems, KAN Innovations, Embright Infotech, Prasad Psycho, Electromedical Control and HMS Medical Systems, Resicare Medicines Private Limited, and Health and Fitness. A big thanks to all of our sponsors, and I request all the delegates to kindly visit the stalls. Also, a small announcement about a missing watch. A rose gold bronze watch with a black dial has been found yesterday night at the Gala Night venue. If it belongs to anyone, please come backstage and take it. Thank you.
It is my honor to introduce Dr. Kamal Narayan Arya sir, a distinguished lecturer of Pandit Deendayal Upadhyay National Institute of Persons with Disability, New Delhi. Sir specialized in stroke rehabilitation, focusing on innovation therapeutic interventions with numerous publications in prestigious journals. Sir's work as an influenced neurorehabilitation practices on global scale. As an active member of Academic Council of Occupational Therapy, ACCOT, he continues to shape the future of occupation therapy through his dedication to research, education, and clinical excellence. I would like to hand over the stage to Sir for his faculty talk titled on Predatory Journal, a detrimental threat to the integrity of research in health sciences. Welcome, sir.
Thank you, ma'am. First of all, I'd like to thank organizing secretary and the team of this OTCon 2025 for inviting me and giving this platform. I would like to especially thank Dr. Ganpati, scientific chairperson, who has given me opportunity to speak on this dice and given me the time out of the busy schedule of the entire conference. And I'm also thankful to Dr. Lakshman for motivating to take this session. So I'll try my best to put whatever I know. Okay. Hello. Hello. I'm audible? Hello. Hello. I'm audible? Hello. ठीक है Hello, hello.
Hello, check. Hello, 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 check. Hello.
Hello, am I audible? Okay, okay, I'll start. So, the topic is predatory journals, a detrimental threat to integrity of research in health sciences. Okay, I'll start with this slide, and you must be thinking that's a journal presentation, why we are talking about water. So, just have a look on these 4 bottles of water, and anybody can tell from which bottle we would like to have water from. So, why not from first, second, and fourth? Water is water. Okay, that is one thing. Good observation. Another thing, suppose other are also filled with water, why shouldn't we take water from? No, water is water. How do you know that? Fake brand. Okay. So this is Belseri. See, I'm not promoting any company, so there is no conflict of interest with this Larry. Okay. So other is Bilseri and other is Bresley. Okay. So but all look like same, and definitely if you go critically, we will not go for the other first, second and fourth, we will go for the third. And there's something, some ISI or FSSAI or the standard of the company or reputation of the company on which we rely on when we may take water from the third one. Okay. So similarly, when we talk about the scientific journals, the water of knowledge, we should be also very careful from where we are taking and from where we are giving our knowledge to be published. So it is more of giving the knowledge to be published and more of taking the knowledge which is already published. Both way we should have to have a standard journal. So what is a scientific journal? It is a periodical publication where we disseminate new research findings by publishing new original articles through a rigorous peer review process, a very important, a rigorous peer review process. Cannot be published as it is, whatever we give, it has to undergone by a same professional experts who review your work and then it get published. And that ensures the quality and the accuracy. Each and every word of the published article has to have a quality, have to have an accuracy, everything cannot be published. Okay. And like that we have standard journals like American Journal Physical Medicine and Rehabilitation, American Journal of Occupational Therapy, Indian Journal of Occupational Therapy, and Occupational Therapy International, some of the examples in our field. So all they are giving us accurate and quality information. So broadly these journals can be divided into 2 categories. One is paid access and where the reader has to pay for the full text article. Like on net, if we go for the search, we'll only get the abstract, not the entire article. For the entire article, we have to pay to a journal. So these are known as the reader has to pay and they are paid access. They are not open access. The other category is open access, where the reader doesn't have to pay. He has free access to read the entire article, but somebody has to pay, either the publisher or the author. So there are further 2 categories without APC. APC stands for article processing charges. And the first subcategory, author doesn't have to pay, like our Indian Journal of Occupational Therapy. It is an open access journal, but neither the author nor the reader has to pay. It is freely available, whether our association is bearing the cost or the publisher is bearing the cost. The other subcategory of the open access is the with APC, that is the journal charges money from the author to publish the article. And that forms the biggest basis of this fraud or the open access journal or the predatory journal. And from there the business starts, where the company charges, the publisher charges money from the author to publish an article. So what is predatory? So anything that is intended to injure or exploit others for personal gain or profit. That is a dictionary meaning of the predatory. So I hope some of the seniors must be knowing, the faculty must be knowing who is Jeffrey Bell. He is an actually American library scientist, a very senior library scientist who worked on this, and he was the first who coined this term, predatory journal of predatory publication. Okay. Actually, he was a whistleblower in terms of the predatory journal, and this term is not very old. It is just 15-year old. In 2010, this term was coined. Actually, I was doing PhD at that time. These journals was just, I know, got to know there's something like predatory journal. But after 15 years now, there are so many such articles on predatory journals. Okay. So, by definition, these journals are publications that claim to be scholarly journals, but are fraudulent, they are deceptive, or they are pseudo journals. Mind you, they are fraudulent, they are just running for the business and for the money. So, there are some common features or which they share, most of them. They usually lack rigorous peer review. There are no standard of review process. They would publish anything what you give, whether you are following all the standard criteria of research or not, they would publish it. Okay. So, there is no rigorous peer review. They would be aggressive solicitation. They will keep asking you, please come to us, publish with us. Please come to us. Like those who are authors sitting here, they must be getting lot of spam mails coming to their inbox that the journals may be requesting you, please submit an article, please submit an article. So, never ever submit articles to such journals. Basically, most of them are predatory and false journals. They don't follow any publication standards. They will be either negligible or no standard of publications. Okay. So, I will come to that how these journals they don't follow means whether their sample size calculation is there, whether inclusion criteria is right or not, exclusion criteria or not, whether all the research methodological things are be structurally followed or not, they will never see it. Some other common feature, false or misleading information. Since they are not following any standard, definitely the information coming from these articles or the journals are misleading and false. And most of them are going to charge high publication fee. Indian journals, they may charge you a little less, but definitely they charge fees. Without fees, they are not going to run, and that's I already told, they exploit the access of these articles from money. That is, open access model is being exploited by these journals. Okay, so that's what the credible journal looks like, and that is what the predatory journal looks like. So, if you find a journal, okay, anyway, where the peer review process is there are some revisions like yesterday Dr. Lakshman was telling us that there is a review process, peer review process, and one has to undergo different revisions, and possibly after that there may be rejections. Okay. So, there is a lot of hurdles are there. So, in a credible standard journal, you have hurdles to cross to get your article published, and you may get rejection at the end also. While in the predatory journals, you are getting a warm welcome, red carpet welcome, and you are being greeted for your work and very easy to get published. So, whenever you get that type of picture in your publication, please doubt your journal. And if you get this type of picture in your journal publication, it means you are on the right track. So, one very unfortunate fact about India is that majority of these journals are being published in Asia, and within the Asia, 30% are from India. So, we are always higher in every field. So, similarly in predatory journals, majority 1/3 of the entire world, we are publishing it in India. And in talks of number, 15 years back, they were just 10 in numbers, and today they are more than 15,000. The data says they are more than 15,000, they must be much more than this. Okay. And Indian authors are no behind with the publication also, because since we are publishing too much of predatory journals, so you will find that most of the authors in these publications are also from India. Okay. So, publishers are also from India and authors are also from India. So, this is one of the data given by this particular article reference given down. So, it shows on the map of India that you can appreciate the lot of red dots, that is the publishers are sitting here in the India, and they have a link for the bank and for their payment and everything in the different countries worldwide, but they are seated in India and they are running these predatory journals here. Okay. So, a sting has been operated by this scientist John Boynan, who sent a bogus paper which is basically written by a 6th standard student, and it is a chemistry or math of a very basic level of 6th to 8th class. And he sent up this bogus paper to 300 predatory journals. And it was surprising to the author that he found acceptance by more than 60% of these predatory journals. More than 60% journals, they say yes to publish this article, which is a 6th standard chemistry article. And again, a very surprising thing is, out of that 60%, majority was seated in India. The majority was seated in India. Okay. So usually they recruit fake editors, not like our iJot. We have good editors in iJot or in other journals. So these journals, priority journals, they recruit fake editors. Their name may not be existing anywhere in the world. They are just for the namesake, and they run their business from the fake editors. They may be a big editorial board also, but all the names are also bogus and the fake. Maybe they may be using the names of the other person, like a very prominent person, say Dr. Lakshmanan, but the name of the Dr. Lakshmanan will be only using for this. Okay, he must not be aware of that my name is being used by such XYZ journal, and he'll be showing the editor-in-chief of that journal. Okay, so don't mind, sir. Okay, so most of the times again, it is a one person, one PC show. One person sitting somewhere in the India by one PC, he is running the entire show. The website would show there's a 20 editorial board member, one is editor and everything, but still the entire show is being run by a one person. And he will be giving you one address to pay, do the payments, or UPI address or some bank account details also, and you'll be paying and you'll getting the acceptance overnight, and your paper get published. So just as news to be shared, the Federal Trade Commission of USA, I've skipped the name of the publisher for the ethical reason, and that is seated in India, in Hyderabad. He has been charged with $15 million fine or penalty for fake publication. It is not in one journal. That particular publisher is running more than 100 of journals in medical and the biological field, and all are predatory. All are predatory. So who are the vulnerable author? See, why we become vulnerable? Because there is always a perish or publish or perish. Means a pressure to publish at any cost due to our MOT or PhD guidelines, or for the promotions, or for the awards, or for the anything, or even for the reputation. So the authors who are vulnerable are the postgraduate students, PhD scholars, maybe faculty who are not aware of these predatory journals, elderly faculty or elderly professionals who are not very tech savvy or internet savvy, and there may be a person or the professional who seek reputation and awards instantly. So they are the vulnerable authors. They want publication at any cost. They send the papers, and they would like to know the name of any such journal which publish overnight. Some of his colleague will tell, okay, you publish it, and he will send the paper, and the next morning he get the acceptance, which is not a right process. So they are the vulnerable. So one has to educate himself that what are the predatory journals and should not get prey to them. Okay, so how to identify these predatory journals? I have already given a few common features of predatory journals, and considering those factors also and some of additional factors I would like to enumerate. So you can also search on the website on the Bell's list. This website was very active till 2017, and it provides a long list of predatory journals. The same person, Bell, but due to unknown reason, this website is not updated nowadays, and his work in the field of predatory journal has been stopped now. There may be some legal issues or some ethical issues. So apart from that, look for these 15 red flags. So first thing is they mail you. No standard journal would mail you for publication. Unless you may be a very senior person, they would ask for an invited commentary or invited some editorial. Okay. So if some journal mails you, never ever send your paper to them. No deadline. They will mail you and there is no deadline. You can send paper at any time. There won't be any special issues or certain like this without any deadline. Very importantly, they will publish out of the purview. There may be a journal of agriculture and they are publishing the article on occupational therapy. So beyond the scope of their purview, and they're publishing it, it means it is a predatory journal. They definitely will charge a good amount of money, that is APC, article processing charges. The making of the website, if you look at the making of the website of American Journal of Occupational Therapy or archives of PMR, and you compare with any predatory journal, it won't be the same. So the designing and the color of the is not standard. The content of the website is not standard. Even they are deliberately they use lot of grammatical mistakes. They will deliberately use it so that for any legal hassle, they will can easily become out of that problem. Okay. So cloned and hijacked websites. There are journals who are with the same name but have two web addresses. So you won't be aware that which one is right and which one is wrong, which one is original, which one is fake. So they are cloned journals also. They also come in the category of the predatory journals. Then Gmail account. Usually the website like iJot, we have a editor at ijot.org. You don't have an editor at gmail.com. We have an editor iJot because we have our own domain on our website, and from that we have email addresses. Most of these fake journals, they use their Gmail account or Yahoo Mail account. Okay. No proper contact details. At every journal website, there is always a contact detail, and you can contact the editor-in-chief or the editor, and you can mail them or you can contact. But these journals, they will not have a proper contact details. They will give you a box where you can write your query, and you can post it, and they will contact you. You cannot contact them. Okay. Then they would be using lot of standard this indexing system like Scoopus, Web of Science, or UGC. I'll be talking later. So they will be using a fake stamp that their journals are being indexed or in these particular websites. Digital object identifier is missing or misleading. DOI is basically anything which gets published online. They have a for searching, they have a DOI, digital object identifier, and with that you can reach to that particular article. So there is a DOI website also. You can search whether the articles being published by these journals are there in the DOI or not. If the DOI is not there, it means misleading. So majority are not working. Their articles DOI doesn't work or misleading. Google indexing. See, there's nothing like a Google indexing. Anything which is published online can be searched on Google. So there's no Google indexing, and they will be writing very big thing that their articles are indexed in Google. So there's nothing like a Google indexing. Okay. High acceptance rate. See, higher the standard of journal, lower is the acceptance rate. But these predatory journals have 100% acceptance rate. As I said, 60% of journals accepted a bogus paper. So you can see if you send a semi-bogus type of paper also, they will be accepted in the most of the predatory journals because they want money, nothing else. Okay. Negligible time for acceptance. You send it today, you get acceptance by tomorrow. It means they have not gone through the review process and they have just accepted for the sake of acceptance and for the money. Poor or no citation. See, whenever we read an article, at the end we find lot of references, and every article cites the articles or the studies previously done. So it's a chain, research is a chain. But these articles which is being published by predatory journals are not being cited usually, because who is going to read it? Who is going to cite it? So you just read any article and see whether that particular journal is being cited by the other articles or other journals. So they are having a poor or no citations. So these are three standard indexing database. In these, if your journal is indexed, if it is national, it should be in the UGC Careless or UGC India. If they are international, they should be in Scopus or Web of Science. If either of these three database is not considering your journal, please doubt your journal may not be a good journal. Other things can be also, as I said, digital object identifier. You can check that their DOI Google search, you just put a Google DOI, you get a DOI website. So there you can check whether the article is indexed or not. Then ISSN number, there is International Standard Serial Number. Directory of open access journal, there is a directory is also there. All those, see, open access doesn't mean that all are fake. They are very good standard journals, open access also, they charge money and they publish articles. So DOAJ, Directory of Open Access, provide the list of all the open access journals which are not predatory. Potentially they are not predatory. Maybe they are not today, but maybe tomorrow. So DOAJ website, please check for the DOAJ website if you are paying money to anyone. Then there is an open researcher and contributor identifier, that is ORCID, ORCID. So every author nowadays, researcher has this ID. So all those articles which is published by a standard journal, now they are linking that article with the researcher ID. So if the article is not linking with the researcher ID, it means the journal is not working in a standard manner. So they are nowadays, they are taking some precaution. Plus Committee of Publication Ethics, their website is there, that all this publication ethics has to be followed. They also provide the list of the journals which follow the ethics, but that is not openly available. You can check DOAG and DOI openly, free of cost, they are available. One more thing, impact factor. Nowadays we run over whether the journal has an impact factor or not. So journal claim that impact factor is 7, journal claim that impact factor is 10 or 5 or whatever it is. But standard wise or by reputation, worldwide, globally, only one agency can give the impact factor, that is Clarivate Analytics. No other agency has right to give the or provide impact factor. So if your journal claims that it has an impact factor of say 5 or 7, please check the website of Clarivate Analytics whether it actually provides that. Sometimes they will write not from the Clarivate Analytics, some other agencies. So that agency is basically a bogus or fake agency. No other agency has right to provide the impact factor in research committee. Then there is one more, now this thing coming, Elsevier provides site score. So Clarivate Analytics provide impact factors and Elsevier provides the site score. So site score is also a matrix. It is basically based on the number of publications a journal produced in the last 4 years and number of citations that journal has got. Okay. Like if somebody cites the previous published article, so that journal gets a reputation, a cite. It is a more reputed one. And nobody citing, like as I said, keep predatory journal, nobody cites, so their impact is always zero. Okay. Else all fake journal metrics are fake. Please mind it, all metrics are fake, there's nothing like it. And it's better to publish in a zero impact journal, but should be indexed in Web of Science, Scopus or UGC, instead of running for the impact factor. So they are very good journals with a zero impact factor, but they are indexed. So if they are indexed in a reputed database, you may go for it. Don't jump over for the impact factor. So this Clarivate Analytics web website looks like this, and there's a master journal list. Then in this search box, you can provide the name of the journal. All those international journals, if they are indexed in this, it means it is standard, it is not predatory. Okay. Those who are national, it won't be found here. It is mjl.clarivate.com. Then Scopus, scopus.com/sources.uri. Open this site. You can link with your Google Mail account, or it is without a link also, provide the detail. The title box comes and enter the title of your journal, and the journal site will come here. So if a journal is indexed, see one more thing is, if a journal says that I am indexed in Scopus, don't rely on them. Like if I say I know Donald Trump, nobody would laugh. So whom would ask? You will ask the White House whether they know me or not. Okay. So you go to the website of Scopus and then check whether the journal is indexed in their site or not. Okay. Instead of if the journal claims that I am indexed in Scopus, he may be claiming wrongly. So Scopus looks like this. You put a box here. The journal will come like this. Like number 1 is coming like that with the site score, journal name, and you click further. What are the area of publication? That all will come. In fact, most of the time, home website will also come. So if the website is fake, you can check for the right website from the Scopus also. Then UGC care list, till today it is being provided by the UGC, that is the Consortium for Academic and Research Ethics. It provides the list of all the journals, national journals which are indexed in the list 1, and all the international which are indexed in Web of Science or Scopus in the list 2. So if some journal is indexed in Scopus and Web of Science, by default they comes under the UGC care list. If some journal is not indexed in those 2 websites, but national journal and they want to index, so it will come the UGC care list 1 till today. But recently the UGC is in the process of revising this care, and they are coming up with the 36 guide, characteristic for the journals, and on the basis of that they are going to revise this thing. Maybe we have to decide whether journal is fake or not. So till today it is there, but by 25, maybe after 2 days, they will close this website and not care list, but they are going to revise it based on the information and the responses from the public. They have asked the response from the public. But till today it is active. That is UGC care list. For that you have to make your login. This is basically managed by Pune University. Clone journal, as I already told you, they are hijacked a clone journal means with the same name. Like we have an iota.org and somebody, another group of iota.org, and then with the same iota, but the website address will be a little different. It may be iota.in. So somebody is running the same association with the iota.in and somebody running the iota.org. So they are clone journals, very difficult to make out which one is original. Original says don't go for the publication of that one. And you go to the fake one says don't go to the publication of this one. So it's quite difficult which one is right, but definitely these databases are there. They keep on revising this database, whether it's Scopus or Web of Science, and then they'll make the predatory journals out, and you can check from their linking whether the journal is right or wrong. So like that, UGC Care is also providing till today the list of all the clone journals. You click this website, you will find the list of the entire clone journals which are running by the 2 different websites, 2 different group organizations. So one is original, one is fake. So they provide the highlighted in the fake ones. So don't go for that fake websites through that one. So I'll take some of the examples. So please don't mind of the audience if somebody has published in this journal. Okay. So I apologize for this, but I just search on it, you'll find OT articles in this type of journals. So say it is the International Journal of Multidisciplinary Research Review. The name seems it's a very international type of journal. But actually there are just 2 I have marked. One is the email address. If you can appreciate it as the gmail.com. No international journal will run by a gmail.com. It has to have its own server or domain. Another thing is SGIF impact factor 7.352. So that shows there is nothing, no SGIF cannot give impact factor. Because as I said, only Clarivate Analytics, just the green tick, can give the impact factor. So any journal whose impact factor is given by the SGI type of agency, it is not a good journal, it is a predatory journal. Supposed to be predatory journal, there are further motives, but by these two features, I can say it is a fake journal. Okay. And if have a fake impact factor, it cannot be indexed in Web of Science or Scopus. Web of Science Scopus is not going to take a journal with the SGIF impact factor, they are not going to take it. It will be out of the Web of Science. Another thing about this journal, very important, I think the fonts are very small, I will read for it. Very smartly they have written, they are going to take the publication from the entrepreneurship, psychology, management, human resource, administration. This is very long. Public administration, sociology, economics, financial banking, organizational behavior, organizational psychology, corporate, environmental science, library science, applied. I am reading it long because it's a list is very long. So can you appreciate a journal is publishing so many areas of researches? So can you think the number of editors and editorial board to run one occupational therapy journal? We are putting so much of work by this team and still we are not able to do our job properly. So how can they do this such a long areas? And they are, occupational therapy is not mentioned, but they are publishing paper on occupational therapy also. So if any journal which is publishing this extreme areas, very long list of areas of publication preview, it is a bogus journal, it is a fake journal. Very, it's not, I'm saying with a good literature and by support of the data and from other professionals and experts in the field, they have very categorically said any journal like this is a fake and a bogus journal. So don't go for it. So I checked this on UGC care list and the moment I checked the International Journal of Multidisciplinary Research, the research found is 0. So neither this journal is in the Web of Science nor in the UGC. And it is a 100% fake or bogus just running for the money. Another journal, International Journal of Research and Analytics Review. These are just examples I have taken. Just what may around this oval one, red one. The result comes in 2 to 3 days. Very boldly they are writing the result comes in 2 to 3 days. Means you submit today, by the time you reach home, your people get the acceptance of publication. So it is not possible. This is not possible. No journal can publish overnight. The review takes, as Dr. Lakshman said, 10 to 14 weeks usually. And if there are good number of articles, it may take 3 to 6 months time sometime. So if somebody publishes over 2-3 days means it is not going to be a review. Review is absent there. Other thing is I have blue marked, very nicely they are written. Their publishing subject areas are master in MBBS. So master in MBBS, they have not done it they have done it very smartly and deliberately. Okay. So master in MBBS, BAMS and the line they have somewhere written the master of occupational therapy. BOT, occupational therapy. So if you send OT paper, it will be published by these journals. Okay. So what is a master? Say paper being published from the area, not from a course. So this type of things are fake and pseudo, and they deliberately write. Suppose something happens tomorrow, some legal hassle happen, they'll be very free. So they have mentioned like this. So that's what you have to see the designing of the website, how they have designed the website. So they have given a DOI number for a particular article, mental health status among parents of intellectually disabled children, and the DOI number is 10. Usually DOI start from 10 point something something something. Always remember this. So 10.6084 something like this. And in the second box, I have opened it in a DOI website, and the DOI website it says it is not found. So it means the claim of that DOI is fake. And if you click their DOI, you will reach somewhere. So don't click their DOI, don't rely on them. You open the website of DOI and look whether their article is actually coming in the DOI or not. So I've checked in the Web of Science, that is MGL Clarivate, international. I put the International Journal of this, whatever the previous one, sorry, Journal of Research and Analytic Reviews, and what I got is International Review of Research in Open Distributed Learning. So it means this journal is not there in the Web of Science also. Okay. So neither in the, if you check the UGC also, see UGC will be the national as well as international, but list one gives the national one. So you can check there also, you can check here also. So something is Web of Science, it is automatically in the Web UGC. You don't have to go separately for that. Very interesting another journal, is the name itself suggests Library Progress International. So it shows that it's a journal of library. Anybody can say it's a journal of library, but you search in this journal, you find the article of occupational therapy also. You'll find the article on occupational therapy also. Okay. Now, one thing, impact factor is 5.96, it's Cosmos. So there's no agency like Cosmos, fake predatory journal. Okay. as I said, they have stamped it, I am indexed in Scopus. I know Donald Trump. But if you go to the Scopus, ask whether you know Library International, they will tell the other story. So they have stamped that I am indexed in Scopus. Okay. Usually they don't have to stamp. In a standard journal, they list that what are the indexing databases. Just provide the name of it. Don't have to give a stamp like this. Okay. So I went to the Scopus, and what I found in the Scopus, years currently covered by Scopus is 2023. So they have stopped indexing the Library Progress International because of their activities. So they have made him out. And 23, after 23 is not indexed. And they are not claiming that I am indexed till 23 or I was indexed till 23. They are saying I am indexed in Scopus by putting the stamp. But actually when you go to the Scopus, you will ask, another very important thing is their site score is 0. Site score 0 means nobody has referred their article. So nobody has referred they are publishing it for the sake of themselves, but nobody is referring it. If somebody is referring it, the site score will come. How many citations they have got, it will come on the Scopus list. So till 23 they were indexed, and till 23 they have not got single citation. So it is a fake predatory journal, and that's why the Scopus made it out. High technology letters. I have taken this because it is listed on the UGC website, and it is a clone journal. There are 2 websites are being run on the same name. So this is the one, and the website is there. So one more thing, you put a Google search high technology letter, the first search thing comes out of it is this website. So it is basically the name of the, basically what we put in the search box, whatever we are searching the item is just something on the Google, the letter comes, high technology letter, this will come. It is basically Google search process. In the process it will come to this, not the original one. So I've checked, I didn't get this website, so I went to a SkyMago. So you can use this SkyMago, it provides all the websites, the actual website of most of the journals. So I went to the SkyMago and I found something different. Other checks are Web of Science, Scopus, UGC, DOAGI, as I already told you, Directory of Open Access Journal, SkyMago and DOI. SkyMago will only provide the links of the journals or the website addresses. So from there, what I found, that this high technology letters, the original one is a Chinese journal. So in a Google, this will come later on, because it is in Chinese language. So you will not go on the Chinese one, you will go on the English one and you submit your paper. Okay. And it is very unfortunate that we have occupational therapy in that fake journal one, high technology letters. So actually the original is the Chinese one, and they use the name of this high technology from the Chinese and they publish in the English. Nobody is going to go for the Chinese one. So they are cloned. Another journal, Journal of Chemical Health Risk. Now the name itself suggests they are going to publish the paper on the chemical risk, chemical health risks. Okay. And they have given the areas of publication: toxicology, mineral, organic agents, environmental analysis, occupational medicine, cancer research, analytic chemistry, and risk analysis. But it is unfortunate that I have found 17 occupational therapy articles related to cerebral palsy, autism in the chemical health risk. So it is very astonishing that why a chemical health risk will publish a paper on cerebral palsy and autism. Okay. And this is one website, jchr.org, please appreciate. And this is another website, sanat.iau and i.r. This is also chemical health risk, see the logo, and this is also chemical health risk. Okay. But all the OT papers were in this. Definitely it shows that this one is predatory, because if somebody is publishing the health risk is a predatory. And actually this is the original. This is published by one of the university in the Iran. And they have taken the website with a different name, jchr.org. And their actual website is sanat.iu.ir. IR stands for like India, IR for the Iran. So this journal is being run by Iran. And there is no OT article. And they are actually publishing on the chemical health risk. Okay. So the previous one is a fraud. So you check on the UGC clone list, they are very categorically mentioned 47 number. That is Journal of Chemical Health Risk on this side and Journal of Chemical Health Risk on that side. This is a list of the clone journal. So that yellow highlighted is the list of the clone journal. So UGC is categorically giving the names which are cloned. But sometimes UGC, that's why UGC is refining the care. It is not possible in the lakhs of journal. It is very difficult for the UGC also to provide each and every information very correct. It is our responsibility also to check whether the journal is accurate or not. Journal of Chemical Health Risk, I went on the Scopus also. So they are currently covered by the Scopus till 2024. Okay. Now you will get confused that if it is covered by Scopus, it is Scopus linked. But actually we are looking for the original linking, the original journal which was published by Iran, not by the Indian one. It is published by Islamic Azad University. So you can look at the Islamic Azad University website and you will find the original link. There is one important very tool you can note down. Because of time constraint, I could not go for the hands-on. Otherwise, there is a compass to publish, and they important for the international articles or international journals. Sorry. So this particular website is given by the ULEG University. It is in France. Maybe I am pronouncing wrong. It is ULEG University, which provides a compass. They ask 20 questions about the journals. You put the information. They also help you to how to put the information if you know it. And at the end, they will provide the compass in the green side or the red side. If it comes on the green side, you should go for it. If it comes on the red side, don't go for it. So they ask you to fill the form in terms of 20 questions, sub-questions, and they give a clue also what to fill, name of the title, whether it is published, whether it is indexed in certain websites or not. Some questions are coming up like this. So there's International Journal of Health and Sciences and Research. There also I found the paper of occupational therapy, and that's why I've taken this journal. And I use this compass to check it. Unfortunately, what I found, that the compass needle comes on the red side. And what it says, your answer indicates that the journal is very likely to be predatory. It is best to avoid it altogether. So like that, for international journals, not for the Indian one, for the international journal, you can use this compass, and if it goes on the green side or to the light greener side also, you go for the publication. Otherwise, don't go for it. So what is the outcome of these predatory publications? So through articles and through different discussion, what I got to know that if you go for the publication in predatory journal, like we go for the Bilseri type of water, so there may be risk of contamination or any hepatitis or infection, whatever we can get it from that water. Similarly, if you go for the predatory publication, all these things are going to come out. You are going to have a poor science, poor knowledge, I'm going to use every time poor patient care, poor professionals, poor profession, poor policies and poor society. Okay. So that is basically the purpose of this slide is it what we want to get out of the publication? No, not at all. I think nobody wants this. So then why we are publishing into it? Or why we are reading it? So we have to avoid it, and considering these outcomes, we have to be very serious and very crucial in terms of the publication. So nowadays there are a lot of penalties also. Categorically UGC has given very strict guidelines. If somebody's publication is in the predatory journals, their degree may be snatched, or their promotions for the faculties may also be taken care of, and they may be demoted to the previous post also. Okay. So overall, they will not going to get any credit for this in the research society, in the academic society or academic market. You may be demoted, or your degree may be retracted, and your awards or honors may also be retracted. So what is the solution for this? Okay. So the solution is at the every level, from not only the author is responsible, at the reader level, at the organization level, at the college level. So the author should be aware. Most importantly, awareness is very important to identify these journals. So we have to be very aware. Use digital skills to check whether journal is predatory or not. Reduce the temptation to publish more. Most of the authors have temptation to publish for 40 articles, 30 articles per year. It is not possible at all. Even if you publish a 1 to 2 article every year, it is a big thing. Okay. So don't have a temptation to publish more. Reader, don't read from these journals. Okay. Reference citing such journals. When you are doing a research, don't cite from predatory journals. Even whatever we are giving the citation is very important. Even if you are citing American Journal of 40, Indian Journal of 40 or Lancet or Nature, or whether you are citing such journals which I have just given the examples, in your references, make sure you are giving the references and the citation of the standard journal. Okay. Unscribe from your library. If you are working in some organization college, unscribe from your library. Don't subscribe it. Academicians, I think most of the academicians are sitting here. I humbly request that guides should please insist your PGs not to publish in such journals. A humble request, please insist your PGs and PhD scholars not to publish in such journals. Institute level and college level, there should be a stringent guidelines, and then some of the institutes have already made it to check for the PGs and PhDs publication. That's why most of the good universities are saying that your publication should be indexed in Scopus. Okay. Every PhD universities are saying it, your publication should be published in Scopus, at least Scopus or UGC Care List or Web of Science. Okay. Then professional bodies and agencies are working on it, UGC is working on it, ICMI is working on it, NCAP has come up in our profession, maybe in coming years it is going to have some guidelines from the NCAP also, and ITO is also, I think from IJOT is working on it and like giving me opportunity to talk on these issues. It means ITO is working on it, and ITO is very particular through its publication by IJOT, which is a link, which is indexed in UGC. So all the standards are being followed by the IOTA publications also.
So in conclusion, identify and boycott this journal. Most importantly, identify. If you identify it, then only you can boycott it. You cannot identify it, you cannot boycott it. Okay. And then only you can break the flourishing market, which has come from 10 to 15,000 in 15 years. Maybe in coming few years, they may be in lakhs. And then the publication has no value. Okay. And then only can force them in the dormant stage. And you can raise the standard of our research in our profession, that is in occupational therapy. So this not formally but informally I would say, is better not to publish than to publish in a predatory journal for the sake of profession and our society. Thank you. Any question, please? Yeah, please.
Thank you very much. It is a really eye-opener actually. There are a lot of scammers in this field here. My question is like, is Indian authority doing anything about it at all? Indian authority, Indian government, I mean.
See, at every level things are going on because during last few months and checking on the articles, there are more than 2 dozen of Indian authors who are publishing paper anti-predatory journals. They are given articles on predatory journals not to go for it. So authors are working on that level. Government is working on through UGC. Government is working through UGC. Okay, and authors are working at their professional level, like I'm working or somebody else is working at the professional level. And the government is working through their agencies.
Yeah, it sounds like it's a criminal
in terms of legal
offenses,
one.
basically.
Yeah, our laws are very weak. It's very weak law. So that's why they're using the wrong grammatical mistake, masters in MBBS, something like this they're using, so that law cannot catch. So that way US law is very strict. So that group which is running in Hyderabad, which has been fined for $50 million, it is running very nicely in India. And it has more than 100 journals on biological sciences. So Indian laws are a little weak on this thing, predatory journals.
Okay, thank you.
Okay. So maybe in coming years, the laws may be very strict now. Yes, the question.
Sir, I'm Dr. Sumit Shinde from Mumbai. Wonderful presentation.
Thank you.
You are presenting it in a ethical, professionals, everything is ethics over here. But all these journals are unethically presented to the clientele level. Most of the time in pediatrics I'm working, and clients comes to us and say ki, this particular practices, see there are so many publications, so many these things, and why we should not follow it and why we should not this thing. I know that after 10 years the regulatory body will come and this thing, but they are taking away rights from the ethical professionals. The quack practices are actually taking the advantage of this, and the fake is more marketed than the ethics. How we can work on this, sir? I mean, why not this lecture is taken in the society? Why not this lecture is taken in at the clientele level?
I understand your concern, but the only thing is, if I take this lecture in the society, even if I take here, because why I'm taking it? Because if you search on it, the publication given by is from our profession only.
True.
The public is or lay persons are going to publish into it. It's the professional who are publishing in it. So we have to work on the grassroots level. Who is publishing it? If our professionals are not going to publish in it, nobody is going to read it.
But fake professional is actually nicely marketing himself by doing it and then taking.
So they're not
taking
marketing,
away
they're doing
5
for
years
their
of-
particular cause. Usually they're not for the marketing, for the clinical practice or for the, because articles are not being read usually by the layman. They only go Google it and find something,
Yes.
and half knowledge, they come with that to you.
Absolutely,
They come to
absolutely,
us also.
absolutely.
Okay. But usually the professionals, they publish it for their particular reason. Either for the promotion or for the PhD or for the PG thesis or for the reputation or something like that. Not for the client. So definitely we have to, there are various means, what you're suggesting also right way, to work on the every level, but the first level is from the root level.
Absolutely.
And that is from the authors.
Sure. Wonderful initiation. Thank you, sir. And I want IOTA, please take it to the clientele level. Every private practitioner should have this lecture so that they can promote this particular lecture in their clientele level, so that the clients can understand what is fake and what is supposed to be read and what they are not supposed to read. Thank you.
Okay, thank you.
Thank you, Dr. Kamal Narayan Arya. It was a wonderful presentation because, and I feel this is very, very relevant for this conference as we are discussing about translating research into policy and practice. And especially I like the slide where you have put like 2 tracks, and one track with a lot of obstacles, another track with the smooth pathway. That is really very interesting to see. Now, one aspect you covered, like there are predatory journals and we need to be careful. On the other hand, why researchers are approaching these predatory journals? Now, like the previous, yeah, when he raised this question, you have touched few lines on that. I think you need, maybe you should have taken 2-3 minutes to elaborate why the researchers are, some researchers are approaching these predatory journals. Because as you rightly said, it has to be stopped at that level. So maybe if you add 2-3 points from your experience, that would be really useful because many students are sitting here. It will be a good take-home message for them.
So I think definitely it's if something is very easily available, something is very easy. As I said, it is they publish it in overnight or 2 days, 3 days. So we approach to it. And as I said, one of the slides, the vulnerable authors, we have a published or perish. That pressure of publication is always a one thing which moves you towards these journals because they give a red carpet. So when is the pressure of publication, I have to submit my thesis, I have to give 2 publications at any cost. So I'll go through this red path. I don't have this time. So these are the usual factor. PG, I have to, suppose some of the university says you have at least 1 publication, I have to go for it. My guide say you have to publish it, I have 1 publication. I am an assistant professor, I can only become associate if I have 2 publications, so I will go for it. So usually these are the some objective or reasons where we would like to, and publication is usually a long process. I would work for 1 to 2 years and I'll work for another 6 months for the publication. Maybe I'll get 2-3 rejections, another 1 year I'll get a publication. So everybody would like to have a shortcut. By nature, humans are lazy. So we would like to go for the shortcuts. Okay. So definitely I couldn't because of time constraint, but I could have added this.
Okay. Respected
Dr. Kamal,
dignitaries.
Yeah,
I'm Dr. Shailaja Jaivan from Mumbai. It was really an excellent presentation.
Thank you.
This is for mainly for appreciation I got up. And I suggest that since we have started that webinar series, we all are members, so we know it from the beginning. So if you can take it as a one of the this session of webinar on this, we all the teachers will encourage our PG student to attend this particular webinar. Please consider
Sure.
this.
I'll extend my help, whatever I can.
And
Sure.
Dr. Vijay, I request you to consider this on the priority basis.
Sure, ma'am.
Okay. I will give him the message. Even sir will give him the message. Thank you.
Thank you, sir. Thank you, Thank you, delegates. It is our honor to extend our sincere gratitude to Dr. Kamal Narayanan, sir, for his thought-provoking session on topic Predatory Journal, a detrimental threat to the integrity of researchers in health sciences. Sir has highlighted a crucial challenge that researchers faces today. The knowledge shared today will undoubtedly keep us safeguarded the integrity of researchers that happens in health sciences. Now I'd like to invite Dr. Samantha Shan, ma'am, Honorable President of WFOT, to felicitate our presenter, Dr. Kamal Narayanan, sir, with a memento and a certificate. Welcome, ma'am. Thank you, ma'am. Thank you, sir. Good afternoon, one and all present here. Now we are moving to the 7th scientific session, that is our oral paper presentation, which will be the last session of oral paper presentation of OTCon 2025 under the title Sensory Processing and Occupation Therapy, Addressing Challenges in Cognition, Behavior and Development Across the Lifespan. Now I would like to invite our chairperson for the session, Honorable President of IOTA, Dr. Pankaj Bajpai sir, onto the dais. Sir has been instrumental in shaping policies enhancing education and promoting occupation therapy at national and international level. Sir's contribution as an editor in charge of Indian Journal of Occupation Therapy further reflected his commitment to academic excellences and knowledge dissemination. Sir has been honored with several awards, including the IOTA Professional Excellence in 2014, reflects his relentless effort in promoting the profession. Welcome, sir. I would now like to invite the next chairperson of the session, respected Dr. Shailaja Sandeep Jayawant Ma'am, Assistant Professor Lokmaya Tilak, Municipal General Hospital and Medical College, Sion, Mumbai. Ma'am is an esteemed occupation therapist with over 26 years of experience. Ma'am has published more than 30 researchers' articles in national and international journals and has been awarded fellowship for All Indian Occupation Therapist Association. Welcome, ma'am. Now I would like to hand over the session on to the chairperson for the seventh scientific session on oral paper presentation.
So hereby we open scientific session number 7, sensory processing and occupational therapy, addressing challenges in cognition, behavior and development across the lifespan. The first presenter is relationship between sensory modulation and cognition, a cross-sectional study by Shalini Quadros from Manipal.
So all the presenters will be given 10 minutes time. Those guidelines you must be knowing. And after presentation, after all presentation, we will go for discussion. Okay. So can we start? So please, you can start.
Good afternoon. Before I start my presentation, I would like to inform that this particular study that I'm going to present is a part of an ongoing larger study which aims at identifying the relationship between sensory modulation and occupational participation in individuals with schizophrenia. So today's presentation, the title of the study is Relationship Between Sensory Modulation and Cognition, a cross-sectional study by co-authors Dr. Ravindra Munoli and Dr. PSVN Sharma, Department of Psychiatry, Kasturba Medical College, Manipal. Sensory modulation is the ability of an individual to regulate the sensory stimuli received from the environment and produce appropriate responses. It is the body's ability to moderate the sensory stimulus that is received and accordingly cope with one's emotions related to the stimulus and with the surroundings contribute to various activities. Cognition is the ability of an individual to think and respond to situations using proper judgment, problem solving, decision making abilities. Impaired cognition ranges from poor attention, concentration, memory, decision making, planning, etc. Both sensory modulation and cognition play an important role in the individual's occupational participation and are hence of interest from an occupational therapy perspective. The objective of the current study was to explore the possible relationship between sensory modulation and cognition in healthy population. This was a pilot exploratory cross-sectional study. Permissions were obtained from the authors and the publishers of the assessment tools used, that is Hindi Mental Status Examination and Adult Adolescent Sensory Profile, for its use in my study and also for the translation. Ethical clearance was obtained, followed by CTRI registration. The study was conducted in 2 phases. First phase, in which the HMSE and ASP was translated into Kannada, and the second phase where the relationship between sensory modulation and cognition in healthy population was explored. The outcome measures used were Hindi mental status examination. This is a tool used to assess any cognitive issues in individuals. It is sensitive enough to detect cognitive issues even in clients who are illiterate and from rural areas. It consists of 22 items including components such as orientation, attention, memory, comprehension, expressive speech, motor functions and praxis. It is a modified version of mini mental status examination in which the test items are related to reading, writing were modified to apply for illiterate individuals. It is extensively used as a screening tool and is also used in clients with schizophrenia. Individuals scoring less than 17 are found to have cognitive issues. Adult adolescent sensory profile is a tool used, is a self-report measure consisting of 60 items. It is based on the Dunn's model of sensory processing and it measures the 4 types of sensory processing styles in adults. It is a self-report measure and has favorable psychometric properties. A score can be charted for each quadrants, that is sensory sensitivity, sensation avoiding, low registration and sensation seeking. The tool can detect sensory patterns that exist in individuals based on the quadrants. If the individual has much more than or much less than scores in the normative range, people are found to have dysfunctions in their occupational activities, occupational functioning. The International Test Commission, that is ITC 2014 guidelines for translation and adaptation of tools was used in translation of the tools here. The procedure for the first phase, the English version of AASP was translated into Kannada by 2 bilingual translators and 2 bilingual occupational therapists. A Kannada translated version, a single Kannada translated version was made based on the inputs received from the 4 translated versions. And this Kannada translated version was back translated again by 2 bilinguals and 2 bilingual occupational therapists, and then a single back translated English version of ASP was made based on the inputs received from the 4 versions of the Kannada back translated version. Then there was a consensus, the original ASP English was compared with the back translated version of ASP English version and modifications were made in the Kannada version accordingly. Cognitive comprehensibility was tested by administering it on a sample of population and then followed by final draft which was made based on the consensus received from bilingual experts and based on which the final Kannada version of ASP was made, and then face and content validity using Likert scale, and then finally submission to IEC for approval. The similar procedure was followed for the translation of Hindi mental status examination, wherein it was translated and back translated again to Hindi, and then the original and the back translated version was compared and changes were made in the Kannada version accordingly. The main purpose of this translation, the need for translation was many of the residents, patients who come to our hospital speak Kannada, and that was the reason why we did not want to miss out with the patients who speak only Kannada. For the second phase, the study population was healthy population. Participants from the community, Udupi district. Sampling was convenient purposive sampling. Sample size was 100 each, total 300, where 100 in each group in age ranges from 11 to 17, 18 to 64, and 65 years and above was decided statistically. Inclusion criteria, healthy adults with ages ranging from 11 years and above, both males and females were included. Exclusion, adults with any self-reported long-term comorbid conditions such as chronic respiratory conditions, cancers, diabetes, neurodegenerative conditions, any mental health conditions, or adults on any adults on any medications acting on the central nervous system were excluded. The procedure for the second phase, after the IEC approval and CTRI registration, the participants who met the inclusion criteria, the study details were explained, informed consent was obtained from them, and then the administration of HMSE or Kannada version of HMSC was administered, followed by administration of ASP, or the Kannada version of ASP was done, followed by statistical analysis of the data obtained. The statistical analysis was done using Jamovi software 2022. Kappa statistics were used to determine the agreement between the English and back translated versions of Kannada scale. The Spearman's correlation coefficient was determined to explore the relationship between categories of sensory modulation and cognition. Results: Cronbach's alpha score was satisfactory agreement for HMSE, and the scores was excellent agreement between original English version of ASP and the translated version. The results, the demographic details are as followed, mentioned here. The total participants were 300, with 100 each in these categories. 59.3% of the participants were female, and around 42.3% of the study participants were currently students. The Spearman correlation coefficient found that there was actually not much relationship between any of the categories like low registration, sensory sensitivity, sensory avoiding, and cognition, except for a slight weaker association between sensation seeking and cognition, which was contradictory to the existing studies by Zheng 2014, Zheng et al. 2014, or Holmes et al. 2016, where they have found that there is a relationship between sensation seeking and sensory modulation and cognition. I attribute it to maybe because the tool was the HMSC is a screening tool, and the agreement between the translated tool was not excellent. Could be the reason why I have found these results. But I'm also planning for sub-analysis of the obtained results here. So the aim of the current study was to explore the possible relationship between sensory modulation and cognition in healthy population. And as I mentioned, there was a weaker association between sensation seeking and cognition only, and not for other components of sensory modulation. So in conclusion, despite a comparatively lesser sample size, the existing relationship between cognition and categories of sensory modulation, including sensory seeking, paves way for future research in this area. This study was funded by Department of Science and Technology, Ministry of Science, and I acknowledge my department and HOD for supporting me in this study, and these were my references. Thank you.
Thank you, Dr. Shalini. Here I call upon the second presenter, effectiveness of sensory modulation intervention for persons with anxiety disorder, Dr. Fabian Maria Matthew from Chennai.
Good morning to all present. I am going to present my research topic on the effectiveness of sensory modulation intervention for persons with anxiety disorder. Introduction. Anxiety disorders are characterized by excessive worry and apprehension that is often difficult to control, hence causing restlessness, palpitation, difficulty in breathing, concentrating, feeling sad or low mood, leading to occupational functioning impairment. Although some anxiety may motivate people to engage in life activities, anxiety becomes problematic when the response is excessive or if it persists once the threat is gone. Excess anxiety is believed to be caused by a combination of psychological stressors and physiological vulnerability, and is associated with hypersensitivity to threat, overwhelming physiological arousal, and avoidance of feared situations, and reduced functioning. Sensory modulation is the central nervous system's neurological capacity to control environmental sensory stimuli, allow for a behavioral reaction to these stimuli. The neurological component involves the regulation and organization of sensory input within the CNS, resulting in a behavioral response that meets the environmental demands. In contrast to the neurological process, which is involuntary, sensory modulation intervention involves the conscious management of physiological arousal using sensory input from various objects, activities, and environment. Where possible, the use of sensory strategies is self-directed, although in situations of acute distress, others who are aware of an individual's sensory preferences may ensure the right sensory input is provided. The need for the study was, according to WHO, anxiety disorders impact an estimated 4% of people worldwide and are most commonly occurring mental illness. One consequence of anxiety disorder relevant to occupational therapy is the reduced participation. Participation has been defined as an involvement in everyday activities, both social and individual, and research indicates that reduced participation results in lower quality of life for people living with anxiety disorder. According to research, it has been found that sensory modulation intervention helps in reducing distress levels and modulating the arousal levels, thereby improving the occupational participation of adults with mental illnesses. It was recommended that future research should focus on evaluating the effectiveness of sensory modulation intervention in various types of mental illnesses using more randomized control trials. Thus, the purpose of the current study is to investigate the impact of a 6-week sensory modulation intervention for individuals with anxiety disorders for a better occupational functioning in their daily life. The aims and objectives of my study, the aim was to find the effectiveness of sensory modulation intervention for improving occupational functioning in persons with anxiety disorder. And I had two objectives. The first objective was to compare the pre-test and post-test scores of COPM and WHO DAS 2.0 between the control group and experimental group. And the second objective was to compare the pre-test and post-test scores of COPM and WHO DAS 2.0 within the control group and experimental group. Methodology. The study design was a quasi-experimental study. Number of groups were 2, control group and experimental group, and the sample size was derived from the following formula. The inclusion criteria included people within the age group of 20 to 40 years, both genders, people with a primary presentation of anxiety based on a psychiatrist's diagnosis of clinically significant anxiety, symptoms present for a minimum of 3 months, no change of medication for 6 months prior to the commencement of the study. Exclusion criteria involved receiving cognitive therapies, substance use issues, and significant cognitive impairment. This is my study procedure. First, I got the ethical clearance done. Then consent form and demographic details were obtained. Persons with anxiety disorder were recruited for the study using the Beck's anxiety inventory, and they were recruited into the experimental and control group equally, that is 15 number per group. Then before the intervention was given, pre-test was taken using my outcome measures, which was COPM and WHO DAS 2.0. And in the experimental group, sensory modulation intervention was given, and in the control group, conventional occupational therapy intervention was given. In the post-test, COPM and WHO DAS 2.0 was conducted for both the groups, and statistical analysis and interpretation was done. Sorry. Tools used. So for screening tool, I have used Beck's anxiety inventory. I have 2 outcome measures. My first outcome measure was the World Health Organization Disability Assessment Schedule, WHO DAS 2.0. It is a 36-item measure which captures the impact of health conditions on participation in 6 life domains, which were understanding and communicating, getting around, self-care, getting along with people, life activities, and participation in the society. My second outcome measure was Canadian Occupational Performance Measure. It is an outcome measure of a person's performance and satisfaction, which selected everyday activities based on a semi-structured interview. The intervention for a conventional occupational therapy intervention, both the groups got one-on-one sessions for 6 weeks, and the duration was 45 minutes to 1 hour. The conventional OT techniques used for diaphragmatic breathing, restorative yoga, mindfulness techniques, activity scheduling, and graded exposure. Sensory modulation intervention. Session 1 educates on sensory inputs impact on the autonomic nervous system. Session 2 explores different sensory tools. Session 3 were used for goal setting and planning for integrating sensory strategies into the daily life. Session 4 to 6 focuses on applying these tools to improve participation in meaningful activities. Result, participants analyzed in experimental group were 15 and control group was 15. The mean age of the participants was 37.27 years and the ratio of male to female was 8:7. SPSS 27 was conducted to analyze the data. The statistical analysis shows that there is significant difference between the control group and experimental group regarding COPM components performance with a p-value of 0.017 and satisfaction of p-value 0.003, and in WHO DAS 2.0 the p-value was 0.015. The statistical analysis also shows that the mean scores of COPM for post-test in experimental group is more than in control group, meaning there was improvement in the experimental group after providing the intervention. Similarly, WHO DAS 2.0 outcome measures in post-test has reduced significantly in experimental group than compared to the control group, meaning the rate of disability due to anxiety has been reduced for participants after providing the intervention. The first table represents the demographic distribution of the variables, and the results aligns with previous studies conducted by Candler and Wallace et al., who performed sensory modulation intervention for similar ages and severity levels. These findings highlight the broad applicability of sensory modulation for anxiety disorders. Table 2 representing pre-test and post-test scores of COPM and WHO DAS 2.0 in control group. The control group showed significant improvements in COPM performance 5.580 to 6.547, and for satisfaction it improved from 5.933 to 6.993, and the WHO DAS scores reduced from 102.67 to 95.53, and it is consistent with the previous studies which found conventional occupational therapy effective but less impactful than sensory modulation. These results highlight the baseline efficacy of occupational therapy for anxiety disorders. Table 3 represents pre-test and post-test scores of COPM and WHO DAS 2.0 in experimental group. The experimental group demonstrated significant improvements in COPM performance, improving from 4.847 to 7.740, and satisfaction from 5.907 to 8.307, and the second outcome measure reduced from 108.47 to 85.53, and it was from previous studies it was found that sensory modulation is highly effective in reducing anxiety and improving occupational performance. Table 4 comparison of pre-test scores of COPM and WHO DAS 2.0 between control group and experimental group. The result shows that there is no significant difference in the pre-test scores, and it aligns with previous studies which emphasize baseline comparability in sensory modulation intervention, ensuring baseline equivalence in critical for valid intervention. Table 5 shows that there was improvement in the scores of COPM performance and satisfaction and WHO DAS scores, and it confirms with previous study that sensory modulation superior efficacy is reducing anxiety and improving occupational outcomes in persons with anxiety disorder. Limitations: the sample size was small and convenient sampling was used, and recruiting participants was difficult due to lack of interest and other physical limitations. Implication: it implies that the sensory modulation intervention is effective and it is safe, and its findings imply that occupational therapists can incorporate sensory modulation intervention along with occupational therapy intervention. Conclusion: the current study indicates that sensory modulation intervention is beneficial for persons with anxiety disorder as it improves the occupational functioning. Recommendations: future studies focus on evaluating the effectiveness of sensory modulation intervention for various occupations such as ADL, IADL, sleep and rest, education, leisure participation, and other conditions. These are my references. Thank you.
Thank you, Dr. Fabian. The next presenter is Association between Adult Sensory Processing and Behavior Characteristics in Alcohol Use Disorder, a quantitative study by Dr. Kiran Talkande from Goa.
Good afternoon, everyone. So today my title is Association between the Sensory Processing and Behavior Characteristics in Alcohol Use Disorder, which was a quantitative study design. So alcoholism involves frequent intoxication, preoccupation with drinking, compulsion and withdrawal symptoms. Also, it is recognized disorder with a broad spectrum of symptoms and behavior. Occupational therapy focuses on assessing the sensory processing and the behavior characteristics and improve the occupational performance. So the need of the study was that there is limited data availability. Also, there is limited occupational therapy evidence-based assessment, and only few evidences in Indian context are available. The aim of my study was to determine the association between adult sensory processing and behavior characteristics in alcohol use disorder. The main objective of my study was to determine the association between adult sensory processing and behavior characteristic in alcohol use disorder. To achieve this main objective, my first objective was to identify sensory processing patterns using the adult or adolescent sensory profile, also known as the SP2. Secondary objective was to identify the behavior characteristics using the adult behavior checklist, which is also called ABCL. Coming to the methodology, my study was a cross-sectional quantitative study conducted in a tertiary psychiatric hospital. 350 participants were recruited using convenience sampling with a study duration from August to December 2024. And the outcome measures used were adult or adolescent sensory profile and adult behavior checklist. So both of these instrumentations are not available freely. The adolescence or the adult sensory profile is a questionnaire with 118 questions and needs certification. Adult behavior checklist is also a questionnaire with 89 questions highlighting 9 types of different behaviors. The eligibility criteria included adults diagnosed with alcohol use disorder using the ICD-10 criteria, adult male and women aged between 18 years up to 59 years, adult coming to the outpatient department and admitted in the inpatient department at tertiary psychiatry hospital, participant accompanied by a caretaker, participant to be able to comprehend and respond to the questions asked, participant characterized as having sensory processing pattern much more than others. The exclusion criteria involve client who had brain damage due to acquired brain injury, congenital causes or birth trauma, client with any other psychiatric diagnosis or drug abuse, and client not willing to give consent. The procedure followed was IEC, that is the institutional ethical clearance was taken from the institute. Data was collected and compiled in Excel sheet. Data was analyzed using chi-square test using the JAMOVI 0.9.6 license source. Data was presented using graph and charts with a p-value of less than 0.05. Result, demographic information of participants included the mean age as 38.3 and standard deviation as 11. For males, it was 43.76 with a standard deviation of 12.68. Out of 350 participants, 344 were male and 6 were females. 289 were employed, whereas 71 were unemployed. 301 were married, 14 were unmarried, 29 were divorced, and 6 were married but away from their spouse. So there was a strong association between sensory processing and behavior characteristics, highlighting the p-value as less than 0.001, stating the strong association between both of it. Also, association of sensory patterns and behavior characteristics were observed. So there are 4 sensory patterns which were highlighted. Low registration. So low registration had a strong association with the anxious or depressed behavior and withdrawn behavior, highlighting the p-value. Coming to the second one is sensory seeking behavior. It has strong association with the anger and withdrawn behavior, which I have highlighted. Coming to the sensory sensitivity, it had a strong association with anger and withdrawn behavior, whereas weaker association with anxious or depressed behavior. Sensory avoiding pattern had strong association with anxious or depressed behavior and withdrawn behavior. So sensory processing problems were identified for all the 350 participants. Majority of participants experienced sensory avoiding pattern. Then low registration were experienced by 262 participants. Sensory sensitivity was experienced by 75 participants and 43 of them experienced sensory seeking patterns. Coming to the behavior characteristics, which was identified for all the participants, 90% of participants exhibited anger behavior, 8% of them expressed anxious or depressed behavior, and 2% of them expressed withdrawn behavior. So coming to the discussion of the study, strong association between sensory processing and behavior characteristics was found. Association between the sensory pattern and anger behavior was found. So the similar findings were stated in the study conducted by Stolz et al. In 2013 and Jell-Younger et al. In 2022. All participants experienced sensory processing problems. Low registration and sensory avoiding were predominant sensory pattern. Similar findings were stated in the study conducted by John Kelly in 2021 and Bhatia Yeager et al. In 2014. All participants experienced behavior problems. Anger was the predominating behavior, and the similar findings were also highlighted in the study conducted by A. Ray et al. In 2023 and Balasubramaniam et al. In 2024. So this Balasubramaniam et al. 2004 study is conducted in the Indian context in the Maharashtra. The study concludes that it highlights a strong association between sensory processing and behavior characteristics in individuals with alcohol use disorder. Findings indicate that all participants experience sensory processing challenge, with low registration and sensory avoidance being the predominant pattern. And additionally, behavioral issues were also seen, particularly the anger-related behavior was prevalent. So the limitations of the study was that the study was a cross-sectional study design which precludes casual inferences. Additionally, the reliance on convenience sampling may limit the generalizability of the finding. Future implication includes the development of occupational therapy intervention considering sensory processing approach with other traditional approaches. Future research with longitudinal design could provide deeper insight. Also, audit result to be considered as an inclusion criteria. I would like to thank the Almighty for His constant presence and blessing. I'm extremely indebted to the Dean and HOD of my college and study setting. I warmly acknowledge the continuous encouragement, valuable supervision, timely suggestion and inspired guidance offered by my guide. I express my heartfelt thanks to my parents and my participants for their kind cooperation and participation. The following are my references. Thank you for your patience listening.
Thank you, Dr. Kiran, for finishing it well in time. Thank you. I call upon the next presenter, effectiveness of supporting and enhancing NICU sensory experiences program to enhancing neurodevelopmental outcome in neonates in NICU in Goa. Dr. Priyanka Kinalkar from Goa.
Good afternoon, everyone. My name is Priyanka Kinalkar. Title of my study is Effectiveness of Supporting and Enhancing NICU Sensory Experiences Program to Enhancing Neurodevelopmental Outcomes in Neonates in NICU. Premature birth is a leading cause of mortality in children under 5 globally, resulting in approximately 1 million annual deaths. In India, preterm birth accounts for over 10% of total birth, with around 13.4 million cases reported annually. The intrauterine environment provides a meticulously orchestrated sequence of sensory experiences precisely timed to support fetal development. NICU environment significantly impacts the growth, development, and long-term neurodevelopmental outcomes of premature infants. Early parent-infant interaction in the NICU positively impacts infant development, enhancing emotional, cognitive, socio-emotional growth and leading to a better neurodevelopmental outcomes and long-term developmental trajectories. The Supporting and Enhancing NICU Sensory Experiences, that is SENSE program, developed by PINEDA, delivers personalized, evidence-based sensory experiences to premature infants daily, empowering parents to foster healthy sensory maturation. Despite its potential benefit, the effectiveness of the SENSE program in Indian context remains unexplored. Need of the study: there are lesser number of intervention protocols used in the NICU. SENSE program is one of the protocols used in the NICU. Its effectiveness in Western context is understudied and its impact on the Indian population remains unknown. This knowledge gap necessitates the investigation into SENSE program efficacy in improving the neurobehavioral and physiological outcomes in preterm infants. Aim of the study is to assess the effectiveness of the SENSE program intervention on physiological stability and neurobehavioral outcomes of NICU infants. Objective of the study: this effect of the SENSE program intervention was studied using the Brazelton Neonatal Behavioral Assessment Scale. Methodology: study design: it was a quasi-experimental study. Sampling method was a convenient purposive sampling. Study setting is NICU in the tertiary healthcare center. In sample size, 30 preterm infants, 15 in the control and 15 in the experimental group were allotted. Instrumentation used is Brazelton Neonatal Behavioral Assessment Scale to assess the premature neonates' neurobehavioral outcomes. Methodology: inclusion criteria: NICU admitted infants, premature neonates from both the sexes, gestational age ranging between 30 to 36 weeks, birth weight of 1000 gram to 2500 gram within the first 48 hours, ABGA score of more than 7 at 1 and 5 minutes, and those who were appropriate for their gestation, medically stable, and duration of hospital stays more than 72 hours. Exclusion criteria for the study were the severely ill infants in the NICU, on ventilator support requiring surgery, on sedative medications, intraventricular hemorrhage or hydrocephalus, and on oxygen requirements. Procedure: study received institutional review board approval and informed consent from parents. 30 patients were randomly assigned to control and the experimental group based on the predetermined eligibility criteria. Baseline assessment was conducted using the Brazelton Neonatal Behavioral Assessment Scale for both the groups. Parents in the experimental group received education on the SENSE program. So parents also received education through the PPT and in the form of the papers where they were explained about the program in different languages like Hindi, English, Konkani and Marathi. Intervention received was in the control group received standard care for 1 week daily once. An experimental group received SENSE program twice daily for 1 week by the parent and the investigator. Post-intervention data was collected using the same scale for both the groups, and data analysis was performed using SPSS 2022 to compare the outcomes between the two groups. SENSE intervention. Here in the SENSE program, they have given for each PMA what interventions in the tactile, auditory, olfactory, visual and kinesthetic vestibular in each domain, what interventions are to be given. So for 23 to 27 weeks, 1 hour of kangaroo care or gentle human touch. In auditory, quiet conversation, no additive auditory exposure. In olfactory, scent clothes, visual lights of less than 10 lux. And kinesthetic and vestibular, 2 minutes free movement, 1 time day. So this way for 28 to 29 weeks and 30 to 31 weeks. Similarly for 32 to 33 weeks, 34 to 35 weeks and 36 weeks plus. Results: the two group demonstrated homogeneity, demographic homogeneity with no statistical significant difference observed in terms of gender, delivery mode or the post-menstrual age. The table 1 shows the number distribution of the studied preterm neonates according to their demographic characteristics. Result 2, comparison of the mean weight gain among both the control and the study group. The comparative analysis of the weight gain post-intervention revealed marginally higher mean gain in the experimental group compared to the control group, although this difference did not reach the statistical significance. Result 3, the effect of standard care on the control group. Standard care in the control group was associated with improvements in motor performance, range of state and autonomic regulation with P less than 0.05. Effect of SENSE program on the experimental group. Experimental condition had a positive impact on most aspects of the preterm neurobehavior, notably significant gains observed in habituation, orientation and regulation of state. All P values were less than 0.05 relative to the control group. Discussion. Preterm neonates who received SENSE program intervention demonstrated enhanced physiological stability, weight gain and neurobehavioral outcomes. Results were consistent with the previous research. Experimental group demonstrated superior performance in habituation behavior characterized by decreased response to disturbing stimuli and superior orientation skills including visual and auditory responses to animate and inanimate stimuli, and these findings were also consistent with the previous research. The findings also stated that the SENSE intervention group possess healthy state regulation abilities including affectionate behavior, emotional regulation and self-soothing capabilities with identical patterns to those reported by the Mathai. Studies utilizing other concurrent outcome measures have consistently shown that preterm neonates who receive sensory stimulation intervention encompassing tactile, auditory, visual and vestibular stimulation exhibit improved physiological stability, weight gain and neurobehavioral outcomes compared to those receiving routine hospital care alone, and this also was supported by the research conducted earlier. Limitation in the future research. The NICU population is inherently heterogeneity, characterized by diverse medical complexities, and the socio-economic background can impact the developmental outcomes. Pilot study findings, although valuable, were context-specific, which may limit the generalizability to other contexts. The small sample size also limits the generalizability. And due to resource constraints, the optimal environmental conditions recommended by the SENSE program were not fully replicated, potentially impacting the intervention's efficacy. Future implication. Future research will prioritize large-scale or more diverse samples to enhance external validity, investigation of the program's effectiveness in varied settings, long-term follow-up studies, and evaluating the feasibility, acceptability, and cost-effectiveness within the Indian population. Conclusion: the study demonstrated significant improvements in physiological stability, neurobehavioral outcomes in both experimental and the control group. The experimental group receiving the SENSE program showed notable enhancement in habituation, orientation, and regulation of state. These findings suggest the SENSE program efficacy in promoting neurobehavioral development in NICU preterm infants. I would like to express my sincere gratitude to my research guide for providing invaluable guidance and advice throughout this research. I would also like to thank Dean, HOD, Pediatrics, NICU staff, neonates and their parents. These were my references, and thank you.
Thank you, Priyanka. You also finished your presentation in time. Thank you so much. The next presenter is to study a use of goal attainment scale to measure a functional outcome from sensory-based motor intervention in classroom setting by Dr. Rucha Thorat from Pune.
Good afternoon, everybody. This is a study which attempts to understand the application of goal attainment scale to measure the functional outcomes in a homeschool setup in coordination with the parents and the teacher. Sensory processing, it's not happening. Just excuse me, this is not working. Yeah. Sensory processing is a lifelong process, hence should be viewed as a continuum. And there is a need of hour today for us occupational therapists to join hands with the parents and the teachers to help them for effective classroom management and help them in the societal roles and take it to the future. Based on this knowledge of awareness, the study we introduced the use of goal attainment scale for measuring the functional changes following the sensory-based intervention program conducted in a classroom setting to empower and educate the parents about the planning of functional gain in a classroom setup and help them in carrying it over. From the review of literature, it is evident that the documentation of and the application of GAS goals, especially when the standardized tests are not available. Here we are used goal attainment scale developed by Kirsuk and Robert, and the references are given for the same. Our demographic data represent 5 children diagnosed with ASD, all between 7 to 10 years of age, were taken for the study, and they were off sensory integration and OT intervention programs. More than 1 year are included for this study, and who were committed to be with us for 3 months of time in the intervention process were included. This is a study which is a qualitative multiple case series, and this is a diagrammatic representation for our methodological process. We begin our data collection process by open-ended semi-structured parent interview, which was based on the ICF model, along with the skill observations which was made by OT based on the parental responses and the classroom environment. Caregiver sensory profile 2 was administered to the parents. Structure observation of sensory integration motor, SOCM, was also conducted for the parents. This systematic data collection helps us for the functional goal planning using the goal attainment scale and proceed towards tailor-made intervention strategies. Functional goals, which were important for the classroom management, were planned. They include the occupational performance areas measured in the playground performances, tabletop activities, and eating tiffin during the lunch break. They were selected as their were main occupations to be performed in the school setup. The duration of the intervention was 5 days in a week for 45 minutes for 3 months. Therapists visited twice in a week, and rest of the program intervention was conducted by the parents and the teachers. Pre and post semi-structured parent interview was conducted, and the goal attainment scale were measured at the end of the 3 months as well. Here we are going to report to you case A, how we went about the data collection. based on the parent semi-structure interview, his activity, level of activity was noted, level of participation was noted. What are the factors, environmental factors such as crowded class and noisy environments were contributing to his function were noted. His personal factors, how they were contributing to his behavior was noted. Based on this, the hypothesis and assumptions were made and a clinical judgment was planned. What could be his possible body structures and function? Parents' interview findings goes as follows. Parent interview findings suggested his activity level as he eats foods with supervision with physical assistant with intermittent running around in the classroom. He can button the shirt with the assistant. He writes with the wrist flexion, with the cross grips and the light strokes. So these are our classroom observation which lead to this participation as he eats with the lunch group. He eats lunch in a group with intermittent moving around, prefers to eat only dry food, follows instruction inconsistently with physical support. This helped us to arrive at his body structure and function and gave us the idea that he might have high arousal, insufficiency in postural proprioception. He might be having tactile hyperresponsivity, vestibular processing issues that could lead to his low attention span and difficulty in executive functioning. His contextual structures also noted in the semi-structured interview. This was further supported by caregiver sensory profile responses and gave us a definitive reference in the tactile proprioceptive and vestibular system. SOSI-M was also documented in the binary responses in a yes-no format, and the way he performed the items were noted and showed us that he had difficulties in proprioception, vestibular processing, motor planning, and the postural control. So based on his baseline activity level, as listed in the left-hand side table, his related system impairment we could prioritize and narrow down, and hence we could plan the intervention strategies related to his system impairment which are appropriate for his goal attainment. So these are the list of activities which are performed over the span of 3 months, as these are the sneak peeks of the intervention structure that we conducted in a homeschool setting. Result for the child A, which we documented using the goal attainment scale, following the playground activity, tabletop activity, and how he performs during the lunch break. His baseline, his goal for the playground activity was to follow the obstacle course by crossing over the benches and take turns without frustration and with minimal verbal commands. So he could reach to the level 2, as shown in the slide with purple color, that he could perform from expected level of outcome to the 2 with only visual support, and he could perform in a group setting for 15 minutes. So he certainly went much more than expected level of attainment. Similarly, while tabletop activities and lunch break activity, he could reach to the expected level of attainment. So in a nutshell, we could put our clinical observation with the help of parent structural interview and the standardized tests such as sensory profile and SOSI-M. We listed down the activity level of a child, participation level of a child, which would arrive at the conclusion of his possible body structure and functional impairments and functioning. That was further strengthened by the score on sensory profile and the SOSI-M, which helped us to analyze his system impairment and give specific activity program to the parent and help teacher to understand the underlying sensory processing program, underlying sensory processing issues that could be contributing to his behavior. So this helps us to result and arrive into the theme 1, that why they do what they do. Earlier, during the parent semi-structure interview, pre-intervention, highlighted the parent responses as a concerns of their behavior. My child is showing a lot of behavior. He screams, he rocks, he hits on the face. He's impulsive, he has a short attention span. But with the help of analysis, based on the structured data collection, it helps us to narrow down his system impairments and understand the root cause of why this behavior is happening and give them a possible intervention which lead to the effective classroom management. Use of goal attainment scale help parents plan the functional goals and defining the expected outcomes, set realistic goal, appreciate the changes in the functional outcome, and thus help towards reaching the neurodiversity affirming approach, such as their responses from the OTIS were to eliminate the behavior, but rather than they were changed that my child would sit on the table and maintain the erect posture and at least write 5 alphabets as listed in the parents' responses was the theme which was derived at the end of 3 months. The effective classroom management was reached. These are the results. After 2 out of 5 children showed increased sitting tolerance and better responses with reduced screaming. 4 out of 5 children showed playground activities with minimal support, demonstrating the improved engagement in the activities. 1 showed progress only in one-on-one setting. He could not perform in the group setup due to his comorbid and personal factors. In conclusion, it is very important that we came to the concluding sentence that joining hands with the teachers and the parents in the goal setting helped, and use of gas goal helps them in transitioning outlook towards the function rather than focusing only on the behavioral lens. Also, this was an effort by putting our OT clinical practice into the research. So translating what we see in the clinical picture and how we can generate the evidence-based approach through by putting the clinical practice, translating research into the clinical practice. So this common premise structure interview helps to establish the language across the multidisciplinary team, which was easier for the parents to understand how to form the functional goals and how to note the smaller changes in the functional goals. Thus, it highlights the role of occupational therapy beyond clinical setup to the community-based setting, thus providing the structure for the parents to look upon. It was a very small sample size. That was a limitation of the study. It needed to conduct. It had to limited resources available and equipment available, and this study was not blinded. I would like to thank the parents and the school organizers who helped me to form this study with their given consent. Thank you very much.
Thank you, Dr. Rucha, for your presentation. I request all the student delegates in the auditorium to maintain the decorum. The participants are presenting their scientific papers, so please maintain the decorum. No chaos. We can hear from here. From here also we can hear that you are making chaos over there. Thank you. I call upon the next presenter, the impact of sensory processing on executive functioning in children aged 3 to 18 years, a systematic review by Dr. Deepak Vignesh Raj S. from Chennai.
Yes, good afternoon everyone. I will be presenting a systematic review on the impact of sensory processing on executive functioning in children aged 3 to 18 years. So the executive functioning is a neurological ability that directs and manages cognitive, emotional and behavioral functions to solve problems and regulate behavior towards a goal. And these processes includes attention, incubatory control, working memory, planning, emotion and actions. The development of executive functioning begins in infancy and reaches its peaks in early adulthood. The deficits in executive functioning are often observed in children with neurodevelopmental disorder, and it significantly impacts the school performance, self-care, play, leisure activities and social interactions, all of which are integral to a child's well-being. So moving on to the sensory processing. Sensory processing is a function of the central nervous system that involves receiving and interpreting information from body's sensory system, which helps to respond appropriately and adaptively to environmental demands. So research strongly suggests that there is a higher prevalence of sensory processing disorder among various disabilities ranging from 40 to 88%. Also, there is a higher prevalence in children with general pediatric populations. There is a growing body of evidence on the significant relationship between sensory processing and executive functioning across populations, including adults with ASD, older adults and children with sensory modulation impairments. Therefore, there is a need for conducting a systematic review to understand the impact of sensory processing on executive functioning, which helps in the translation of translating research into clinical practice by shedding light on the development of more focused and effective early interventions. Therefore, the aim of the study is to systematically review the existing evidence on the impact of sensory processing on executive functioning in both typically and atypically developing children aged 3 to 18 years, for which we have prospectively registered the protocol of the systematic review in Prospero, and we have used PRISMA guidelines for reporting the systematic review, and we have used Scopus, PubMed, Embase and EBSCO host for electronic searches. And these are all the keywords which have been used during the database searches for the terms executive functioning and sensory processing. And we have selected the articles based on the predefined selection criteria. So the inclusion criteria where the studies must involve typically developing or atypical children aged 3 to 18 years, and the studies must focus on the relationship between sensory processing and executive functioning, and the study should be published between 2010 and 2024, and the full text of the study should be available, and the study is published in the English, and the level 4 and level 5 evidence has been excluded from the in the selection criteria. We have used McMaster critical review form for quantitative studies to evaluate the methodological quality of the included studies, and it comprises 16 items that evaluate various aspects of the studies methodology, and each item of the scale is assigned a score of 1 if it meets the specific criteria and 0 if does not. And moving on to the result, we have identified 26,453 articles after removing the duplicates, and we have excluded 26,441 records after the title and abstract review, and finally we have included 10 studies after the full text review. And these are all the results of the McMaster critical review form, and each studies secured a score between 11 and 14, indicating a very good quality of evidence. So moving on to the findings of the included studies. In 2015, Adams et al. Conducted a study with preterm children aged 3 to 10 years and found a strong correlation between the total scores of short sensory profile and the total scores of brief and its subscales, inhibition, shift, emotional control, working memory and planning. In 2019, Solar et al. Conducted a study with tics disorder aged 5 to 12 years and found a strong correlation between total short sensory profile 2 scores and the total brief 2 scores. In 2020, Pastor et al. Reported that children with sensory processing challenges predicted difficulties in performance of the inhibitory control task, but not with the planning task in children with autism spectrum disorder aged 5 to 8 years. In 2021, Fernandez reported that in children with autism spectrum disorder aged 4 to 16 years, the working memory significantly correlated with tactile and vestibular processing. In 2021, Brown et al. Conducted a study with typically developing children aged 6 to 10 years and found that there was a strong correlation between all the quadrants and the sensory sections of child sensory profile and the 4 indices of brief 2 scale. And 2023, Lee et al. Reported that in children with ADHD, the incubation and working memory correlated with the vestibular processing, and the attention shift factor of brief is correlated with the hypersensitivity scores of the child. In 2023, there is Bishop et al. Found a strong correlation between interoceptive awareness and executive functioning. In 2024, Diamond reported that in school-going children, the auditory and vestibular processing correlated significantly with incubate, initiate and self-monitoring. In 2024, they have found that in both children with ASD and ADHD, all the quadrants of child sensory profile correlated with the total scores of brief. In 2024, Engel reported that children diagnosed with both ADHD and atypical sensory processing demonstrate lower executive functions across all brief scales compared to those with only ADHD. So all the findings of the 10 included studies highlights a significant impact of sensory processing on executive functioning in children aged 3 to 18 years, including those with neurodevelopmental disorder such as ASD, ADHD and tics disorder, as well as children born preterm and typically developing children. The challenges in a stable and appropriate level of arousal mediates the impact of sensory processing and executive functioning in children with sensory modulation disorders. So additionally, there are few neuroimaging evidences which supports the connection between the areas of sensory integration and the areas involved in executive functioning. So this review will enhance the understanding of how sensory processing impacts executive functioning in both typical and atypical children, thereby improving the assessment protocol for executive function deficits. Additionally, this review will aid in the development of tailored interventions to manage executive functioning deficits in children aged 3 to 18 years. So there are two major limitations of this systematic review. One is the assessment tools. Majority of the studies used subjective assessment for both domains, which may introduce bias. And also the reliability and validity of the subjective assessments used in this included studies were lacking. So next is the sampling method. So all the studies have relied on convenient sampling, so which restricts the generalizability of the findings. So future studies should employ the more representative sampling strategies to capture the diverse populations. So the conclusion of this systematic review is that sensory processing plays a crucial role in executive functioning in both typical and atypical children aged 3 to 18 years. So the future studies should focus on the longitudinal studies to investigate the impact of sensory processing on executive functioning and the impact of sensory based interventions on executive functioning development. So these are all my references, and thank you.
Thank you, Dr. Deepak. Now I call upon next presenter, Dr. Purushothaman. Presentation on effectiveness of occupational therapy intervention on visuomotor integration in children with developmental disabilities, a systematic review.
A warm welcome to everyone, and I'm Dr. Purushothaman, and my presentation is Enhancing Visual Motor Integration in Children, a Systematic Review. So visual motor integration is the interaction and the coordination of visual receptive function, visual cognitive function, as well as the motor functions. So visual motor integration is also a crucial component in child's development, and it is associated with many functional skills including a daily activity skills like buttoning, zipping, shoelacing, etc. Also with their academical activities like handwriting, arithmetic learning, and their recreational activities like plays, solving puzzles, mazes, etc. So, in deficits in this VMI skills are multifaceted and negatively impacting their child's ability to participate in their occupational performance as well as reducing their self-concept. So, the children with autism spectrum disorder, learning disability, cerebral palsy and brachial plexus injury, and also the children who has difficulty with motor coordination and praxis difficulties are more prone for increased risk for having a VMI deficits. So such deficits in their abilities will affect their ability to participate in their academical aspects, recreational aspects, as well as self-care aspects. So the interventions provided for VMI difficulties is, so far we can broadly categorize into traditional VMI interventions as well as technological interventions. So the traditional interventions encompass of activities including copying of figures, matching shapes, block constructions, puzzles, paper and pencil exercises, and exercises like gross motor activities, also motor skill training, etc. And technology based interventions including game based training, virtual reality based and simulated trainings, etc. However, all these literatures has a lack of comprehensive synthesis and critical analysis of the interventions designed to enhance the visual motor integration skills in children. So this current systematic review aims to evaluate the existing interventions, identifying their methodological strengths, weakness, etc. And this study is outperformed based on the research question: what is the effectiveness of various visual motor integration interventions on the VMI skills in children? So the study design is a systematic review, and this review adhered to PRISMA reporting guidelines, and it is registered in Prospero also. And databases included for search is PubMed, Scopus, ProQuest, and EBSCO-SINHEL. The inclusion criteria of this study is: the studies targeted interventions on VMI and the age range between 4 to 14 years, and the study should be published between Jan 2014 to December 2024, and the studies where RCTs, NRCTs and case control studies were included in the study. And the study, if the study is systematic review or meta-analysis or case report, case series and expert opinions were excluded from the study. So this is my search terms used for database searches, and it was broadly categorized based on population related terms, intervention related terms and VMI related terms. For critically appraising, we used McMaster critical review form for the qualitative studies. This is used to assess the methodological quality of the included studies. And for each item which meets the criteria, we are given as a score 1, and for if it does not meet the criteria, we are given the score 0. Totally, after the database search, we received a total number of 4,343 articles. From there, after removing duplicates, we received 4,321. And after the records excluded after title and abstract review, we received a total of 15 articles, which is assessed for full text eligibility. And finally, we included total number of 9 for the qualitative synthesis. And out of 9, 4 studies were computerized interventions and 2 studies were physical training, and 3 studies were visual perceptual training and fine motor training. So this study also includes the diverse range of clinical populations, including 2 studies on developmental delays, 2 studies on intellectual disability, and 2 studies on school going children who has VMI difficulties, and 1 each down on Down syndrome, cerebral palsy and pediatric tumor survivors. So this is the McMaster critical appraisal form, and in this form the total score ranges from 12 to 14, which indicates the moderate to higher level of methodological quality of across all the studies. And the results of this study indicates the study conducted by Francine Coutinho et al. In 2016. In this, the intervention, 40 iPad apps were used to train the VMI for the children, and this resulted in significant improvements in VMI outcome measured by Berry VMI 5th edition. And the study conducted by Waldemar et al. In 2022, this included cognitive motor training, and this study also resulted in significant improvements in visual motor integration as well as gross motor and fine motor skills, which is measured by BOT2 as well as by Berry VMI. And the study conducted by On et al. In 2021, which incorporated VR games and CoTRAS. It is a computer game based cognitive therapy over 12 sessions for 40 minutes once a week, and this study also resulted observed scores of both Berry VMI and DTVP2 were increased after the intervention. And the study conducted by Xu et al. In 2024, it is a tablet computer based cognitive training program which is given for about 12 weeks, and each session duration about 30 minutes, and the outcome measured is measured by Berry VMI, Quest as well as VFIM. So the statistical significant improvements is seen in all 3, Berry VMI as well as Quest and VFIM scores. The study conducted by Sevda et al. In 2023, in this the intervention provided here is a physical activity and attention training program, which is almost about 100 minutes per session. So in this they categorized into 40 minutes of attention training and 60 minutes of physical training program. So this study also resulted in significant improvements in fine motor integration, which is measured by BOT2. And the study conducted by Cho et al. In 2015, the intervention used here is visual perceptual training program, which was given for about 24 sessions and thrice a week. And this study also indicated significant improvements in VMI and VFIM scores for all the 56 participants they included. And the study conducted by Kos et al. In 2024, the intervention used here is visual praxis based occupational therapy program, and it was given for about 8 weeks, total of 8 weeks, and the significant improvements were seen in BOT2. So the overall findings of this systematic review highlights the impact of various interventions on visual motor integration in children, as well as this review shed light for the advantages of using a technology based intervention, as these technology based interventions provides a statistically notable results in their studies. And there was a varying duration of interventions across these studies, and the majority of interventions were shorter duration. So this aspect prompts the further exploration of long-term effect of these interventions in VMI improvements. The only studies that were published in English, and we incorporated only 5 databases due to the vast use of terminologies in different categories like technology, intervention, and VMI. So these were the limitations of our study. And in clinical implications, the systematic review provides a valuable insights to the occupational therapist to optimize their practice in using these various VMI interventions in their practice, as well as the importance of using their technology-based intervention incorporating in their practice. In conclusion, the systematic review underscores the effectiveness of various visual motor integration interventions in children with VMI difficulties, and future research should prioritize the exploration of long-term effect of these interventions, integrating along with the advanced technologies. So these are all my references, and thanks for providing an opportunity to present here. Thank you.
I will request all the presenters to come on the stage for discussion. All the presenters, please come. So session is open for question answer or discussion, and only 2 questions are allowed from each delegate. So maximum 2 questions please ask. We are running behind the schedule by more than 1 hour. First, Dr. Shalini Quadros.
Any question for audience? Our audience? Can I ask questions? Can I ask? So my question is, what is the implication of your research in occupational therapy? Can you explain?
Actually, ma'am, based on my literature search, as I mentioned, my actual study is to find out whether there is any relationship between sensory modulation and occupation participation in schizophrenia. But in doing that, what I found was the adult adolescent sensory profile is one of the gold standard which is used to assess sensory modulation. But based on the existing studies, it has been found that the scores that are there on the sensory profile, the normative ranges, is not similar to in different countries. The ranges are different. Because could be because of the cultural differences, the sensory experiences of people that have in different regions. So it becomes necessary to understand what is it different in India. So that was the reason why we wanted to find out how is it in Indian population, and that's the reason this first part of this study was on normal population. So with this information, maybe we may come up with the ranges for Indian population to compare with how is it different, how is the score different in clients with mental illnesses.
You have conducted study on mainly on the typically developed, means normal population.
This first part of the study was on normal population, healthy population.
Okay, thank you.
Now Dr. Fabin Maria Matthew.
As Fabin, I wanted to know what is the diagnosis, like what type of anxiety disorder?
Mostly generalized anxiety disorder, ma'am.
Oh, okay. Generalized anxiety,
Yes.
because that didn't come through in your presentation. You just put
Yes.
based on ICD-10.
Yes.
So, and that was one thing.
Most
So, am I
of-
allowed to ask one more question, or?
There is
He
one-
wants to ask
one more,
after
yeah.
that.
Hi, I'm Dr. Yash from TNMC Mumbai. Really well presented your presentation. So basically, given the diagnosis of a population that is anxiety disorder, and plus you excluded those individuals with cognitive capacities, right? Cognitive impairments, right? So did you, while going through your review of literature, did you find any novel techniques or novel interventions that can be used instead of sensory-based interventions?
Uh, Thank you, sir. But I actually did not explore that area.
Okay.
Thank you, Pavin. Now, Dr. Kiran V. Talkhande from Goa. Her paper was on association between adult sensory processing and behavior characteristics in alcohol use disorder, a quantitative study.
It was well presented. I wanted to know the why such a huge age difference you're taken from 18 to 59 years. Is there any particular reason for that?
Okay. Good afternoon, ma'am. Thank you so much for the question. Ma'am, basically, there are three reasons I took the age group from 18 to 59 years. So, first was that a prevalence study was conducted in Goa to find out the prevalence of alcohol use in 2006, which stated the age group from 18 years to 60 years of age. Second is the outcome measures I have used. First is the adult sensory profile, which is from 11 years to 65 years and above. Also, there is some conflicting thing that it is 69 years and 4 months something, and from 18 to 69 years 4 months. And for adult behavior checklist, it is again from 18 years to 59 years. So considering these all three criteria, and also and observational things which we have observed in the tertiary psychiatric healthcare hospital where I'm currently. So there also the age group, most of the age group was lying between like 35 years to 55 years. So these three things I've considered and selected the age group.
Okay.
Thank you, ma'am.
Hello, really well presented paper. So, as the theme of our conference is translating research into practice and policy, given your evidence, you have got the evidence, how will you translate this evidence into your clinical practice, specifically in individuals with substance use disorder?
Okay, good evening again. Sorry, afternoon. Thank you for the question. So I would like to just state 2 points. First is the assessment thing. I would like the assessment part. I would like that the assessment should be used in the clinical setups, because it is very important. Currently, these all studies were carried out for substance use disorder. I want it specifically for alcohol use disorder also. And second, for developing a sensory based tailored intervention. So these two things I have kept in mind, and always the behavioral aspect is targeted. So rather than going for that, this is how I would like to get it into a policy. Thank you.
Thank you, Dr. Kiran.
Thank you, sir.
Dr. Priyanka Kinalkar from Goa. Her paper was on effectiveness of supporting and enhancing NICU sensory experiences program to enhancing neurodevelopmental outcomes in neonates in NICU in Goa. Any question from audience?
My question is, as per your title, you are saying that your aim is effectiveness of sense program to enhance the neurodevelopmental outcome. I want to say that you have administered a neurobehavioral scale. So it is not related to neurodevelopmental outcome. So if you could have changed your title as on the neurobehavioral status, the effect of sense program, because I understand that you have taken the patients from NICU, so it is difficult to check the neurodevelopmental status at that level. So you could have it is just a suggestion. You could have said that neurobehavioral effect of sense program on the neurobehavioral status of infants admitted in NICU. Thank you. Only that much was the suggestion.
Yeah.
Thank you.
Ma'am, just one. So after discussion with the consultants in my medical college, so they suggested like we can have same patient assessed again at 1 year. So because of that, actually we kept the title. So actually the 1 year is not yet completed. So in few months we'll be completing the 1 year, and if the patients are consistent with the follow-up, we will definitely do the reassessments of these patients.
Yeah, it's a good this project. But initially, now when you are presenting, you should have mentioned that now I am presenting about the neurobehavioral status. My
Okay.
next phase of my study will be assessing
Yeah,
the
ma'am.
neurodevelopmental status.
Definitely, I will do this
Under
correction.
under limitation, you could place
Yeah.
that.
Okay, sir.
Thank you. Dr. Rucha Thorat from Pune. The paper was to study the use of goal attainment scale to measure functional outcomes from sensory-based motor intervention in a classroom setting.
If there is no question from others, Rucha, I will like to appreciate your paper. It was really very well presented, and research design was also to be appreciated. Even Dr. Bajpayee sir is also appreciating that. And one more thing which was mentioned in the previous session also, when you are presenting about the interventions given in your study, it's always good to show some photographs or some videos. If videos are not possible, at least the photographs to show what exactly you have done. Because all the participants, all the delegates are not aware about the terms which you are using. When you show it in the photograph, it is well accepted, and maybe somebody else will try that type of intervention further, which is a aim of these presentations in the scientific session to progress our profession. Thank you.
Thank you, madam, for your feedback and comment.
Using ICF was very good, and actually this giving a presentation on a qualitative study is also very rare, although it is very common in other countries, but in India it is still rare. We always run behind the quantitative and datas and all figures.
Yeah, the reason I selected ICF was we don't have much of a quantitative tools available from the Indian point of view. And we always, as a students and as a clinician, document in the clinical setup. And how do we document? It's based on the clinical observation. So ICF is something developed by WHO and gives us the core set of analysis. And it is easier to translate this language to the parents and across multidisciplinary team. So that becomes easier to put forward how occupational therapists should present ourselves into the medical fraternity, to put our point.
Thank you, Dr. Rucha.
Thank you, sir.
So next is Dr. Deepak Vignesh. The paper was on the impact of sensory processing on executive functioning in children aged 3 to 18 years, a systematic review.
Hi, it was a really good topic, really interesting. So my question is that you included the age group of 3 to 18 years, right? So why did you consider such a large age group? Because in this age group, 3 to 5 are preschoolers, 6 to 10 to 12 are school-going children, and 16 to 18 are basically in the transition from adolescence to adulthood. Basically, all of them, their problems will be very different, right? So even in your articles that you included in the review, those had small age range, like from 3 to 5 or 6 to 12. So what was the reason behind including 3 to 18 years of age?
So I have selected the age group because generally in the pediatric setups we work up to 18, right? So that's why I have selected 3 to 18, and actually I have did a literature review before the systematic reviews. So I have found the articles. It's up to 16, 18. So if I put 2 to 12, then many studies are there in between 10 to 16, 10 to, so I have preferred the pediatric populations. So I have selected 3 to 18.
I'm allowed to ask one more question?
If nobody else is there, you can ask. Please.
Yeah. So since you included a statement in your conclusion that in future we should consider a study for effectiveness of sensory-based interventions, are there any other intervention like cognitive-based interventions that can be effective in such cases? Basically, adolescent or adult age group?
So since this is a study on the impact of sensory processing on executive functions, I have put the statement that sensory based interventions should be the intervention. So you can also use other cognitive interventions also for improving the executive functions. Yes.
Thank you, Dr. Deepak. Dr. Purushothaman P. Presented on effectiveness of occupational therapy intervention on visual motor integration in children with developmental disabilities, a systematic review. Any question from delegates? Yeah, please.
Hello. So I wanted to know, you said use of iPad and virtual reality as a training tool to improve EMI. So do these modalities have something like grip or grasp patterns? Because generally they are button based. So how do you improve dexterity and fine motor skills when you're using iPad?
Actually, the iPad apps, there are several apps. In that study, they included around 40 apps. So those 40 apps majorly focused on visual motor integration in the sense. So the game is like, for example, the buttons will fall and the child has to strike out the button in the exact half of the button. Like those kind of activities will be there in that training.
Okay, so it's
tool.
mostly striking based, right? But even if you are doing Berry VMI, you would be using typically a pencil to actually be
Yes,
drawing,
ma'am.
right? So that
But
is what.
actually, in that study, they didn't mention anything related to fine motor integration or something related to dexterity and all. But they directly focused on visual motor integration, and the outcome measure is also similarly given by Berry VM.
Okay, thank you.
Thank you.
Thank you very much, Dr. Purushothaman.
Thank you, sir. Thank you.
So this concludes the session 7. And all the presenters, congratulations from our side and best wishes if you are in competitive category. The best wishes from our side. Thank you.
So, I mean, allowed, I don't take much time, sir. Now, I just want to appreciate the quality of the presentation. Scientific papers was really very good. I think amazing work. This, especially this scientific session 7, the quality of papers were amazing, excellent. I could see a lot of youngsters doing systematic review and qualitative research is really commendable. Kudos to all of you have done. But just few suggestions I have. One thing is, I think when you apply to the ethical committee itself, I think you apply with the sample size estimation, and ethical committee would have approved that sample size. So you are going ahead with that sample size only. If that is the case, please do not mention in the limitations as sample size was small. Unless if you're not met with what the ethical committee has told, and then you've not been able to, only then you should you mention that sample size is small. That's one thing. And one more I had, I think I just forgot pre-lunch.
Now leave it.
Yes,
Thank
sir.
you.
I probably, when if my memory works, then probably I should be able
You
to.
may talk to them over a cup of coffee when
Coffee.
you
Now
want
it's
to.
lunchtime, ma'am. So,
Yeah.
yeah, sure.
Even
definitely.
I would like to add that whenever you are present, you are designing a scientific study. It is always, the study always has a value if you really do a sample size calculation prior to starting a study. It's just not that your guide or somebody else says that 15 is a proper sample size. No, for every study you have to calculate the effect size and sample size, then only that study is an authentic study. Please take this note.
Actually, remember, please do not use the word subjects. They're not merely subjects. It's always advisable to use the word participants. I think it's a humble request, and in the previous conference itself, I had made this request. Please refrain from using the term subjects. They're not merely subjects for a scientific thing. They are participants.
Thank you, delegates. I would like to extend our heartfelt gratitude to our respected dignitaries for chairing this seventh scientific oral paper presentation of VOTICON 2025. I would like to invite respected Dr. Jyotika Bijlani ma'am, Dean Accord, to felicitate our Honorable President of IOTA, Dr. Pankaj Bajpai sir, with a memento and a certificate. Thank you, ma'am. Thank you, sir. I would like to invite Dr. Patiba Vaidya ma'am, respected President of IOTA, to felicitate our respected Dr. Sailaja ma'am, Assistant Professor Lokmaya Tilak, Municipality General Hospital and Medical College, Mumbai, with a memento and certificate. Thank you, ma'am.
Check. We would like to take a moment to thank and appreciate our sponsors, our platinum sponsors, Speech Care Therapeutics for Ultra Kids and RCM Healthcare Services Foreign Recruitment Specialist. Our partners, India Medico Instruments, Isaac Group LLC Healthcare Staffing and Recruitment, Godrej Interiors, Matrix Rhythm Therapy, Akara Foundations, Treasure Iron Therapy, Digital Interactive Rehabilitation System, KAN Innovations, Embright Infotech, Prasad Psycho, Electromedical Control and HMS Medical Systems, Riskcare Medicines Private Limited, and Health and Fitness. Thank you.
We have come to the last part of our scientific program, OTCon 2025, a faculty talk. I would like to welcome Dr. Lakshmanan sir. Sir is a distinguished senior occupation therapist at the Center of Addiction Medicine, National Institute of Mental Health and Neurosciences, Bengaluru. Sir's academic background includes a master's degree in occupation therapy and PhD with research interest spanning harm reduction, addiction psychology, and occupation therapy. Serves as an executive editor of Indian Journal of Occupation Therapy. Sir has an extensive publication record with over 30 research articles in national and international journals. His work has significant contribution to the field of occupation therapy and mental health, particularly in the area related to addiction and rehabilitation. Sir has been awarded as IOTA's Young OT Achiever Award in 2018. Sir's unwavering commitment to the innovation and excellence continue to inspire and elevate the standards of occupation therapy practices. Now I like to hand over the stage to Sir to deliver his faculty talk on the topic Overview of IJOT and Submission Guidelines. Welcome, sir.
Good afternoon. I won't take more than 5 to 6 minutes. That is the reason I asked them to don't call it as a faculty talk as such. It is basically a request for you to submit to IJAT. That is the thing. It is basically an awareness, kind of, you can say that it is a marketing information. That's it. So coming back to IJOT, the Indian Journal of Occupational Therapy is an official publication of All India Occupational Therapy Association. The journal has been first registered by Dr. Kamala V. Nemkar, basically to promote research among the occupational therapists by then in 1956. So from 1956, it has been regularly published. Over a period, it has become a quarterly journal. And we publish the content with the scope of occupational therapy practice in India, which focuses on occupational therapy education, research, and practice. So these are our abstracting partners. We published study protocols, reviews, original article, case reports, case series, evidence-based summaries, commentaries, and letter to editor, kind of a thing. So based on the time, I have just cut down on my slides on different guidelines per se, basically because it is not going to go well with you right now also at this hour, and I will make you sleepy. That is one of the reasons I have cut down on it. So the guidelines are available at both IJOT on web.org website as well as on IOTA website per se. So basically the question is all about, see, why IOTA has to have a journal. IOTA has, as I said, it has been, the founder of the profession has started it to promote research and research dissemination among the professionals per se by then. So over a period, when almost last 5-6 years, we are struggling to publish in a regular interval with good amount of articles per se. So why is it has happened? Basically because the universities have different requirements right now for their promotions. They are pushing for, as Dr. Arias said, it is more of Scopus index journals have been preferred than any other journal right now. So that is one of the reasons the better research papers are going in. If you ask Dr. Arya to submit to IJAT, definitely he won't submit it. You ask Dr. Sebastina to submit in IJAT, she will not submit. Anyway, she has shown, 2008, she has shown that she has published with IJAT, but today she will not do it because Manipal University never allows her to do that way because the university requirements are that strict right now. The same way with other universities also. So how, then why are we not indexing? For indexing, there are a lot of other requirements. To get it indexed under Scopus, at least a minimum of 30 to 40 original articles have to be published in a year. Publish it. What is the problem? The problem is I am not getting 40 research articles per se. Think about all the rejections and other things, then I may not get anything out of it. So 40 original articles submission itself is not there to IJAT. So earlier, the journal survived by having this agreement. At the time of IOTA conferences, you have to submit an copyright form which says that I submit the publishing rights of so-and-so paper to IOTA so that it will publish it in its official publication. Over a period, because of this university and other guidelines, requirements for the people on their promotions and other revenues, we have relaxed it right now. Like you can present it at IOTA conference, and if you don't want to publish it at IJOT, it's fine. You can go ahead with the other journal, I say. So how does this presentation is going to make a difference? Definitely, I'm not targeting Dr. Arya, I'm not targeting Dr. Sebastina, but I'm targeting the PG students or the PG students who are entering into their post-graduation. I'm here to say that we are there, the first paper of yours, be with us. And we are here to guide you and get into the process of it. So that first paper you do with us, and then by the end of the first paper publication, you will be at least the basic guidelines, you are well versed with it, what has to do and what not to do with the things. So it will be easy for you in a further publication process. Two ways. Okay, this is for your survival. What you are doing it for me. It is like, it is not only my survival or IJOT's survival. It is, you are learning one thing and then you are progressing to that level. But whenever you are doing that, if I get 40 original articles and I have to publish it on time, within 2 or 3 years, I will get its corpus indexed and you don't need to go out anywhere else. Then your journal will be with all the requirements per se. So it will be easy for you in your future also. So that is one of the main reasons I said that it is going to be a marketing talk. Its only difference is the other sponsored talks or they paid money to the organizers and I have the privilege of not giving a paisa, not giving even a single paisa and having a talk with you. That's it. The other information is, so once I submit to IJOT, what happens there? Why it is like, I can get it. As Dr. Arya said, if I submit it by after lunch, when I'm feeling sleepy, I submit it to a journal. And when I woke up for my tea, I'm getting an acceptance letter. There are journals doing that. I have to pay some, the two, as he said, the Indian journals charge you somewhere between 1,500, even 1,500 rupees you can publish a paper. And even your is was will not be corrected and you will within 2 hours period you will get it the acceptance letter. If that is easily possible, then why should I log with you for such a long period? You said 14 weeks your average period, and then maybe some of my colleagues here may say that not for 14 weeks also, I have taken much longer time with you, so I don't want to publish with you kind of thing. So what is happening with the journal when I submitted thing? The first thing is, we'll look for the suitability of the journal, the basic screening which says that whether it falls under the scope of occupational therapy practice. So with all this difficulty in surviving this journal, what we thought is 5 years back, by then to the editor-in-chief and the president of All India Occupational Therapy Association, I went and said, sir, why can't we open up? Because IJOT have a restriction that the author has to be a member of AIOTA. That is still prevail. This information I'm saying it again as because one of the faculty, Dr. Manjusha, who was sitting there, she was saying that you have too many articles, that is why we are not publishing. That is not this scenario. Scenario is, right, we are here. When I went and said that we'll open it up for others, but we'll maintain the scope of the journal as it is, but we'll open it for others. So that we'll get more articles, we'll get it indexed, then we'll be in a better place to attract more articles per se. But by then, the editor-in-chief's version is like, yes, you are right. If you open it, you will get more articles. You will publish that only, and at the end, whoever the novice researcher in the IOTA member, novice researcher who is trying to publish may not be able to publish. So this organization has started this journal to help the novice researcher to get into the practice of writing. So he doesn't want to get back to it. It is very easy for him to say that, yes, go ahead. But he said, no, I want to maintain that the novice researchers will get and help. Right now, you are sending it 10th time. One of my friend who is, just before coming here, I accepted a paper and came here. When I saw him on the first day of the conference, when I told him, I accepted last night, he said, yes, I got the mail. But you have sent it back to me almost for 11 times. That is what he said. It may be much more for others also. That many to and fro communications happen. Why it is so? It is basically, first we'll look for a suitability of the journal. That is what? The major criteria is one of, at least right now, with that discussion, whatever I had with then president, at least right now they relaxed to an extent, at least one member of the author list has to be an IOTA member. That is what still the query is. Still, it is not open for others. So we'll look for whether it falls under the criteria of scope of occupational therapy practice in India. Then the next stage will be, there it won't come back. If it fails there, then you will get a rejection letter within a week or maximum 10 days. Within a week or 10 days, you will get a rejection letter. The second step will be screening the manuscript for the guidelines. When there are failures in that, you will get a manuscript back to you saying that it has been sent to you for a technical modification, kindly do the needful and send us back. I will just, this process alone I am going to explain to you in 2 or 3 minutes in the next couple of slides. Once you submit the technical modification, the next process is peer review process. It is sent to the blinded manuscript will be sent to 2 peer reviewers. And then based on their comments, their comments will be sent to you. Based on that, you can revise and submit the manuscript back to us. And then there will be an editorial review for final, if everything is said, kind of a thing. And then once for editorial review, after editorial review, if you are sending it back, there will be minor here and there fine tweaks kind of a thing. If you send us back, immediately it will be, once all has been addressed, it will be immediately accepted. And then the production editing may take, depends on the publication timing of the journal, it may take somewhere between 4 days to 1 week period. Things will be online, your thing will be online. And I assure the novice researchers that by the time you send the first copy, you have the first copy retained with you, and you see the final proof, you will find what is the difference this entire 14 weeks or 16 weeks has made it to that particular draft. As I said, the technical modifications alone, I brief it in very simple terms, like what are the basic things which we are sending to and fro in technical modification phase itself. The first thing is title. Title doesn't follow the PICOS thing. I don't want to say what is PICOS right now to you. And then there won't be any short title. Basically, people don't understand what is short title is. Short title is a running title within 50 words, 50 letters kind of a thing, where it is along with the author letter, and the subsequent pages as the header, it will be there kind of a thing. And then we follow American English, and the entire manuscript has to be written in American English. And then the word count for the particular article, it depends on different articles, it's kind of a thing. Where usually we follow for an original article 3000 to 3500, and then for a review it can go up to 4000, 4500 words. Kind of, if it is a case report or case series, you can limit to 1000 words only kind of thing. Such way that there are different word counts for the thing, you will find it in the author's instruction per se. Coming to keywords, keywords is the other thing which is there. Maybe as we are discussing post Dr. Arya's session, that we will be, with the permission of IOTA and ACCORD executives, we may be planning full-time workshop on research methodology and writing process soon. So we will be able to tell you how come the mesh words are necessary for the keywords, and just the main keywords in your title will not form the keywords, because somebody when searches in the databases, it looks for title then the keywords. So repeating the words which are there in the title in keywords also doesn't make any sense. You have to add more words to get your research searchers to push your article before. So you can use the other words in the mesh words kind of. And then usually the headers of the abstract. People will write introduction, kind of any other words, methodology, materials, kind of a thing. You can see it in the guidelines that it has been fixed that five headers for the abstract has to be maintained as it is, kind of a thing. Then most of the time what we get is from the novice researchers, they would have been done their thesis, they will copy paste and send it to us, and it is very difficult to put a comment and send it back to us. See, we are looking for a 3000 word article, and you will be sending some 75 page to 80 page thesis into it and sending it to us, kind of thing. That is very difficult to send it, and we don't want to reject it also. That is one of the reasons the to and fro communication is more, and the processing time is also getting lengthier. And then there are the next couple of things is very simple thing. We have repeatedly said in different Azure things and different presentation things, different conferences, kind of thing. Different judges have raised this as a concern. Different judges have raised this as a concern in the conference hall itself. The inclusion and exclusion criteria are not just opposites. The same way, limitation and recommendations are not just opposites. So please avoid writing a limitation as say a small sample size and recommendation as it can be done in a larger sample. Please don't do that. The same way for inclusion criteria. Inclusion criteria is male and exclusion criteria is female. Please do not do that again. Then other one of the guidelines which usually tend to mixed with this is like, as we write, where we'll put an illustration below that we'll write it. But when you are submitting for a journal, you have to look at the journal instruction. At least with iJot, it is going to be, you finish with your references and then you send it as a text table or the images, which will be placed near to the text. When you cite it, it will be placed near during the production editing phase. Repetition. A repetition is one of the other important component. Kind of, I will write it as, I will put a table which says mean value SD, the appropriate statistics values. Then I will put a graph which says the same mean value and SD value. And then below that I will write it with group A had this mean with this SD. So it is complete, it's not even duplicate of information, it is triplicate of information which is not necessary. No journal will have the time or space to publish that information. So avoid repetitions. And then references. We follow a modified Vancouver version of the references. And we usually suggest you use Mendeley or any other software to get the references in place. Kind of. Okay. So this is about iJot overview per se, and as I said, it is going to be a kind of, it's basically, it is not a faculty talk, it is basically a request from the editorial board to all the novice researchers to submit back to iJot to get the iJot in a better shape to help you better in the next few years. Thank you. If there are any questions on the overview or during about the submission process, I will be able to explain you. In the meantime, the delegates whoever has registered for Best OT Delegate Award can scan this, or you can go to, okay, slido.com, slido.com, and then use this OT icon 25 member as the code to enter into the quiz. Only for the delegates, not for the students. Students who are interested to participate in the Best Student Delegate Award, I'll check whether the black box is free. If the black box is free, you can move on to there.
Thank you, sir.
So, members able to get into it? Slido.com with the code OTCON25 member. The students who are interested to participate in Best Student Delegate Award can move to the black box. I will be coming there once they finish it. Maximum it will take 20 into 20. 3 per thing, 18, 4. 8 minutes, 8 minutes for them. At the end of the 8 minutes, I will be there. Best students who are interested to participate in Best Student Delegate Award can move into black box. If I leave it, you will finish it, right? I will come. So, is everybody joined? So, are still somebody trying on it? We'll go ahead. It's not coming in. So we'll start. It's not showing. Oh, sorry, sir. I started the wrong one. No, sir, I started the wrong one. Instead of member, I started the student ones. Sorry. So I'm seeing who are the people who are joined. Fine. We'll start. Thirty, 33. We'll start. Please, boss. Students are waiting there. They have to come start the start play. Street play. This is a problem. Okay. $58. Okay. It's delegate award.
But here you are.
Delegate award.
But here you said black box.
That is for student. I'll finish it. Sir, moving, sir. It's stuck there. Okay. Then I'll stop here. I'll leave this auditorium for the street play. I'll finish the students and then I'll come back and then we'll do it before the valediction. We'll do the best delegate. Yeah. Of course, new questions. Yes, sir. Yes, sir. Leave it. Because we are waiting for the street play to be started.
Thank you, sir. I would like to extend our gratitude to Dr. Lakshmanan, sir, for his faculty talk on the topic, Overview of IJOT and Submission Guidelines. Your clear explanation and valuable insight have greatly enhanced our understanding of publication processes and significance of contributing IJOT. Thank you, sir. I would now like to invite Honorable President of WFOT, Dr. Samantha Shan, ma'am, onto the dais to felicitate our faculty talk person, Dr. Lakshmanan, sir, with a memento and certificate. Thank you, ma'am. Thank you, sir. It is with a great enthusiasm that we welcome you all to our next event, that is the street play. Today we are gathered here to showcase and witness the power of performance and the strength of storytelling and the impact of meaningful message delivered through art. A heartfelt welcome to our esteemed chairpersons for the event, respected Professor Dr. R.K. Sharma sir, Dean, Santosh University, Ghaziabad, and respected Dr. Sophia Azad ma'am, Professor HOD of Occupation Therapy Schools and Center, GMCH, Nagpur. Welcome, sir.
Sophia Sadan
பெண்ணு தேவையில்லை அவங்களோட சார் thank you. Sharing the session street play, totally 9 participants. Just you observe. These are the guidelines. One file, sir. One file for you.
What one is this for?
This is the guidelines, ma'am. First, anyone can read the guidelines, then call one by one. Number one, number two, number three. Totally 9. There is no scoring at all. I know. We have to just go. Guidelines.
Right.
So at the end of the session, both give the overall number.
We have at the end of the full session.
I would like to invite the chairperson for the street play, Honorable President of WF40, Dr. Samantha Shan ma'am, to chair the street play event. And I'm like to hand over the stage to our chairpersons. Thank you.
First you have to tell the. First you have to tell. Okay. Okay. Yes.
Good afternoon. We are going to start street play, and we are sure that all the students, majority of the students, are waiting for this event. The guidelines are as follows. Street play should be composed based on theme of empowering lives of persons with disability through occupational therapy. The street play should be in English. The use of local slang and common expressions are allowed. The use of play cards is allowed. No props allowed. In case of any violation of rules, the team shall be disqualified from the competition. The decision of the chairperson, scientific program committee will be final. So very soon we are going to call upon the first team. I hope the first team is ready.
Check करना. तू वाच लेते हैं. हमको स्टे ओपन करो sana. तू volunteer है. पूरा. So on this team, they will be last some street. Okay. And then we decide. Yeah, how they are doing. We decide. We have 6 minutes. Wait for 2 minutes. We have to do it now. We are going to start. So can just start. Yeah, we can have a discussion. Is there just one prize or there's second thing? No. तो गेलो आता गेलो मरतो. Okay. I think I was sat in the wrong chair. I didn't think I was doing this.
Hello, check, test. Hello, check, check, test. Hello, check, check, test.
Hello, check. Amar.
Can I start?
You need it for the street play, no? For the street play. You don't need it.
I had to announce.
Okay, oh, sorry.
चालू करायला सांग चालू चालू करू सांग चालू हा स्क्रीन बंद करू म्युझिक किती साऊंड म्युझिक
Full lights.
So, number one, please, your time starts now.
According to Ministry of Social Justice and Empowerment 2023, in India, 20% of children between 10 and 17 years old are already addicted to drugs. 40% of adults between 18 and 25 years have alcohol dependence and abuse problems. What is happening to our future? Who is responsible for this? Don't we need to save them before it's too late? You can't fight this battle alone! You can't fight this battle alone! You can't fight this battle alone! The first step to healing is ask for help! Ask for help! Ask for help! We see the struggles, we hear the cries, but do we listen or just pass by? We see the struggles, we hear the cries, but do you listen or just pass by? Ooh, oh my goodness, look at this great mark. Even after all my effort, this for real? Seriously? I should come here? I said come here now. Are you proud of this horrible marks? Why is this so hard for you? I can help it, okay? You don't understand. I don't want to do this anymore. Get back here. Let's see what you can. Right, see now. See, hit the C. Why is the C so messy? What have you done? I'm tired of this. Because I don't care. You're always yelling at me and blaming me. That's it enough. Why did you keep hurting me? How dare you? What's wrong with you? You're out of my control. No more. Please. No. Hey, can you hear me? Let me out, please. My brain gets too loud. My body won't stay still. Do you think locking me up will fix me? Why is my life like this? Is this how we treat our children? Is this how we shall love? With anger, frustration, and punishment. ADHD is not a behavior problem. It is a condition that many parents and children do not understand. It is a cry for help that's often ignored. In India, 8 to 10% of children are diagnosed with ADHD. How many more children are suffering in silence because we don't see their pain? We should be aware. We should care. We should be aware. We should care. Hush up, we all fall down. problems, including isolation, bullying, and discrimination. Why are the peers excluding them? Why are they failing to understand their struggles? Isn't it our responsibility to include and treat them as equal? With every challenge, we go strong. With every challenge, we go strong. Together we rise. We all belong. Together we rise. We all belong. Hey, look! An ant. No, it's an army of ants. They're marching on my arm. Wait, something is not right. You're here to watch me? No. You're here to kill me. Who sent you? Go ahead. You are a monster. You are a ghost. Your existence drains our soul. This is because of bad karma. She should try the holy medicine. No. She should go to mental hospital before she harms someone. No! Only Guruji can save her. No! Let's take her to him. No! Leave! I want to go home! Jessie! Please! Leave! I want to go home! Leave! Alakaza! Alakazi! Be gone, evil spirits, be gone! You should leave the store right now! No! Leave this body! Evil spirit, leave! Was this a curse? A punishment? Or a misunderstood illness? Schizophrenia is not caused by evil spirits. It's a mental illness. Beating and punishing won't help. We have witnessed your battles and resilience, but are we doing enough? Professional help is the catalyst for transformation, empowering individuals to reclaim their independence and live life to its fullest. Occupational therapy is not just a rehabilitation, it's a liberation. With the right effort, every challenge becomes a stepping stone, and every limitation a doorway to possibility. We just don't help them to survive, but we empower them to soar high. Occupational therapy interventions include activities of daily living and instrumental activities of daily living training, play and leisure intervention, vocational rehabilitation, school-based occupational therapy, family-centered practice, sensory integration, social skills training, hand function training, environment and home modifications, ergonomic, community-based interventions, printing and prosthetic training, assistive devices and adaptive aids, and universal design. There is no can't, only can and will.
Thank you. Now we call upon team second number team. Your time starts now.
Come on, gather here a story of it's full of mystery. Life is a puzzle, piece by piece, a tale of cat that will never cease. Watch the tale, don't walk away. Join us now and watch the play.
A warm welcome to all. Get ready for a vibrant street play where talent meets the streets, bringing you all to the world of dementia. A son is here to visit his age-old family. A home filled with love, memory, and beautiful bones. Let's see what's happening in this beautiful family.
Ding dong!
So good to see you. It's been years.
Hi, Grandpa. Come, let's go to the park.
Of course, dear. Wait, let me take my glasses. Vasha, where were my glasses at?
Alex, I haven't kept your glasses anywhere. Look, it's there on the table. You have been forgetting small things lately.
The grandfather and the grandchild has left for the park. It's been a long time. There is no sign of them returning back. The family is panicking and starts searching for them.
I don't know. Which way? Someone help me.
It's been very long time since they went. Where is my child?
Yeah, let's go. Appa, what are you doing here, Appa? So dangerous. I don't know, son. I'm very confused. Yeah, let's go.
Confusion brews in the family. Everybody is worried about what's wrong with Grandpa. Let's see what's wrong.
Amma, something is wrong with Appa. He needs help.
There is nothing wrong with him. He is getting old, that's it.
Open your eyes, Amma. He got lost today. We need to take him to doctor.
Okay.
Yeah.
The son decides to take the father to the doctor. Let's see what the doctor has to say about the grandfather.
Doctor, he's my father. He's not able to recollect the things lately. Yesterday he got lost in the middle of the road, doctor.
He is facing memory issue. What should we do now, doctor? Okay, let's run some medical examinations and I'll let you know.
Doctor, did you review the report? Is he alright?
From all the reports, it seems like a clear case of dementia. Dementia! 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 Oh my god! Dementia? Is it curable, doctor? There is no cure for dementia. There is no cure for dementia. There is no cure for dementia. But we can help them manage to rehabilitation services like occupational therapy. We are the symptoms of dementia. We are the symptoms of dementia. I am depressed. I will not let you live peacefully. We shatter your peace, piece by piece.
We plant the seeds of fear and need in you. Will not let you live peacefully.
We steal your past, your present, your future. It's our nature.
I'm an occupational therapist. I'm going to rescue him from all these problems. Come, take my hand. With the help of OT, you have to face all these challenges. We are occupational therapists.
Who?
Occupational therapists.
What do you do?
Occupational therapists are here to guide and support at every stage of dementia.
Dementia does not affect the person diagnosed, but the entire family.
Let's begin this journey together.
Dementia is a journey, not just for one. It's a family challenge, a battle to be won. Dementia is a journey, not just for one. It's a family challenge, a battle to be won.
Stage 1. Mild cognitive decline. The father is seated in a chair reading a newspaper. OT stands nearby. The doctor enters briefly to address the family.
At this stage, we focus on prevention, healthy routine, and stimulating activities can make a difference. This can be done by an occupational therapist.
Absolutely. Stimulating the mind in early stage can delay the progression of cognitive decline. Let's add memory retraining activities in his routine.
Grandpa, come. Let's play the puzzles together.
Completing the puzzles helps in the memory recall of patterns and shapes.
Brain health is wealth. We all must agree. Start now, stay sharp. Keep your mind debris free.
Stage 2. Moderate cognitive decline. The father now faces difficulty remembering about his meal times. He starts fighting with his family members about the meals.
Where is my lunch at?
Appa, already you have done with your meals.
No, you're lying. You guys never gave me food.
This is common in the second stage of dementia. We can use memory aids like wristwatches or alarms to remind them of their daily meals. Or we can use simple visual schedules to structure their routines. Consistency is key. Keep things the same. Routines and alarms will ease the game.
Stage 2. Stage 3. Severe cognitive decline. Here, now the father faces difficulty remembering where he is going, remembering places, and the son steps in.
Appa, where are you going, Appa? I don't know. Why am I here?
We can intervene this stage through environmental modifications like camouflaging the door by painting the same color of that of the walls to eliminate the queue of exit.
Or there are other techniques like using emergency medical system or motor sensor that enables the person's safety and independence in each transition.
Safety first at every place, reduce the risk at every place. Years passed by. The grandpa kept on fighting dementia with the help of occupational therapists and other medical professionals. In the last stages, he found it difficult for speech and his mobility. One day, his grandchild came across a diary of his. Let's see what's in the diary.
This is Grandpa's diary. Let's see what's in it. Broken like a puzzle with missing pieces. My thoughts scattered and the memories slipped away. Then they came, OTs, kind hearts and patient hands. They saw me as someone worth living and they rebuilt my hope. For that, I'm always grateful.
Let's stand together for those in this fight. With OTs, we show we can.
Now we invite group 3, please. I hope group 3 is ready.
What does it mean to be trapped? Is it the walls around you or the chains inside your mind? Tonight, we take you to a place not of confinement but of transformation. Welcome to the sanctuary. First of all, I'd like to introduce the characters. Boaz is playing the occupational therapist. Jayshri is playing the doctor. Hubert, Azar, and Ananya will be playing the hallucinations. Niranjani and myself will be the narrators for today, and Kamala will be playing the mentally ill patients. And we also have Vikram and Delvin who will be playing the guards.
Another batch of helpless souls. Welcome to our family. Very people. What's here from
Let me go! I don't belong here! I can live my life on my own!
Keep quiet.
I don't belong here. That's what everyone says. But once you're here, no one gets out. Therapy is an distraction, but nothing more than that. No one gets cured here. Trust me, therapy is just a distraction. Nothing more than that.
But are they truly trapped, or are they stuck in a world that refuses to see their true self? Is the prison around you or inside of you?
Step aside. You are not a prisoner. You are here to rediscover yourself.
Rediscover? My body betrays me. My dreams are shattered. I keep hearing voices. I see things that aren't there. I don't know what's real anymore.
It's okay. We'll figure this out.
Occupational therapy doesn't erase people of their struggles. It gives them the resources to fight them. With the help of occupational therapy, one can go to bed with satisfaction and wake up with determination.
Break the chains.
Embrace the change.
In the mind's maze, is anything real? What are the shadows that lurk in the mind?
You feel it, don't you?
Who's there?
You know who? You've always been weak, always drowning. And guess what? No one will save you.
No, this isn't real.
What if I'm the only one thing that's real and no one else?
No.
Then why are you gasping for air?
Why fight it? Just leave it. You've always been drowning. You see, I was here once. They told me I'll get better. They told me I'll be fine. You see, where am I now? Stop! 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 Please stop! Stop! Please stop!
Stop struggling.
Stop! I can't breathe!
Stay with us.
It's alright. We don't want to hurt you. Stop! 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 You put yourself here. You trust me, don't you?
It's over now, sweetheart. Come on.
Given. Stop it, Dari. It's safe.
Breathe. Breathe. Relax.
It's okay, it's okay, it's okay. You are safe. This isn't real. You are safe now. You are safe.
I felt them strangling me.
It's okay, it's okay.
Even in the darkest of hours, hope still lingers. That is what occupational therapy believes in.
Only you can define your reality.
Face your face.
Find your freedom.
For some people, wound and pain isn't just physical. The real battle is inside.
Today, let's try to do something new. What do you like to do?
I used to paint.
Okay, then let's paint. Let your colors speak for you.
No, I don't want to paint. I want my old life back.
Your whole life isn't gone. It's just evolving. You're still you. Take this paint and start painting. Come on.
What a masterpiece. I think you should frame it. Some paint? That's what was saved them? Bullshit. Bullshit nonsense.
Come on. How can a painting just embrace the women? Nothing can help her. Nothing. Therapies are just fantasies.
I am normal. I'm not trapped in the past. I'm not stuck. I am painting my future. Disability is not inability. The true prison isn't not with them. It is how we see them. The world thinks that they were broken, but they weren't. Only waiting to be seen.
Healing can only begin with acceptance.
Defy expectations. Recognize her strength.
Find liberation. Gain independence.
Empowering people with disabilities is all about possibilities. It's about helping them remember who they are.
With the help of occupational therapy, adaptation, and determination, every single one of the person can gain their independence.
Occupational therapy is not just rehabilitation. It is the mission to bring back people home. It's time now. It's time to walk towards hope and possibility. To walk towards my life.
Now we call upon Group 4.
Hey! 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 Answer in skills.empower. Answer in skills.empower. Oh, hey! 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 Empower life. Restore the spark. What lights the dark.
Friends, Romans, countrymen, lend us your ears.
Here we are going to tell you the stories of hope, strength, and
empowerment.
empowerment.
you know disability is not just a deformity or absent? It is an umbrella term for impairment and anything that obstructs one's participation in daily task and community.
Disability, it's not a barrier, it is a challenge. A challenge to adapt, to thrive, and to live life to its fullest. However, many persons with disability face personal and environmental barriers that limit their participation in daily activities.
This is where the transformative power of occupational therapy comes in. OT empowers persons with disabilities.
Hey, wait! You just want to just play with children and give you humans for the stroke patient. How is this empowering?
No! PI's OT deals with motor, sensory, cognitive, perceptual, social and emotional deficits caused due to various conditions. We use activities that are meaningful and purposeful to them to give them wings to soar high.
Initially, we as OTs assess their existing abilities and capacities, identify their defects, and improve their functioning.
Enabling everyone to perform their roles and routines is what we strive to achieve.
As an OT, we will bond with the client, and as together we work to achieve that goal through the intervention plan.
We tailor a treatment plan that is client-centered and evidence-based, help them to achieve their goals. But how? Hey, we will show you. I have lost my hand. I have lost my means of survival. How will I eat? How will I drive? How will I do anything on my own? If you're happy and you know, clap your hands. If you're happy and you know, clap your hands. How dare you mock me?
No worries, no worries. Here is OT to help you with your queries.
Hey, we can actually give you a hand. Not an actual one, but a prosthetic. We can make it your fittings and help with its usage. We can adapt it to help your functions and needs.
Can you make it so I can eat and drive on my own?
Yes, yes. With OT, your needs and dreams are not so far.
Technology and OT goes hand in hand. Together, we will improve the quality of your life and let you live the life that you have always wanted.
Your partner in progress?
OT!
Learn to live independently with?
OT!
Oh, so you OT help those people who lack something?
We also help people who have illness like Parkinson's disease, which can worsen over time, and cancer to strengthen them.
How will you help those patients?
Let's meet Mohan the farmer.
What will I do, sir? What will I do? I must be working in my farm throughout the day, but I'm so tired after the chemotherapy. What should I do?
Arey, how sad. What will he do now?
How will he take care of his family?
How will he take care of his family?
Are you not able to do your work properly?
OT is here to help you live satisfactorily.
OT help individuals to work efficiently, even with their illness, thus financial income and empowering them. With OT, work becomes
Easy, peasy, lemon squeezy.
My daughter, the apple of my eye. She can't even stand for long without getting tired. She can't go to school or play due to her heart condition. I don't know what to do.
Why don't you visit an OT?
OT? Operation theatre?
No. Occupational therapy.
Occupational therapy.
Somebody called me.
Yes, sir. Sir, my child has congenital heart condition due to which she can't able to play or go to school. I don't know what to do.
With OT here, you don't have to keep on worrying about your child. Every child is special and unique. They need some extra care. As an OT, we will provide that care and help them thrive. Stronger hearts, brighter future, OT empowers every beat.
OTs don't just work in hospitals and rehabilitative settings, but also in community programs where we help the specially able people to integrate into the society by modifying their environment and advocating for their equality and accessibility.
In schools, we modify their environment for specially able to play, to learn, and enjoy their childhood.
We promote vocational independence by using ergonomics.
Among the elderly, we are OT, help them to stay engaged, active, and independently. In psychiatry, OT assists in rediscovering their problem and improve ability to cope and get back to their routine. OT bridges the gap between disability and ability. OT, we are OT, we are OT, we are OT. Occupational therapy is not just a profession. It is a mission to restore their dignity, independence, and meaning to life. We not only treat people, we not only treat conditions, we treat people, their dreams, their struggles, and their dreams.
As occupational therapists, our role extends beyond treatment. Let us strive to create a world where everyone, irrespective of their abilities, has the opportunities to lead a meaningful and fulfilling life.
Our ultimate goal is to empower, not by doing things for them, but enabling them to do things for themselves. Because true empowerment isn't just about therapy, it's about breaking barriers and unleashing their potential.
Empowerment, it's not safe for everyone. It's a child with cerebral palsy taking their first step, or a stroke survivor learning to write again. We, as an OT, we empower them the way they want to be empowered.
Let's not forget that empowerment is not involved in everything. Shaping inclusive policies, fostering a society that celebrates diversity.
Occupational therapy is not about recovery, it's about rediscovery.
We are not just therapists, we are hope builders, change makers, and advocates for a world where everyone has the right to live with dignity and purpose.
Let us build a society which is not just accessible but inclusive and empowering.
No person with disability will be left behind. With OT, your dreams won't be confined. Because disability is not an inability, and OT will help you unlock the possibilities.
We are OT. We are OT.
Thank you very much. Now we call upon number 5 group. Group number 5.
Rhythm of life, it moves us all. Lost it once, but hear the call. OT shows the ways to restore the days. Rhythm of life, it moves us all. Lost it once, but hear the call. OT shows the ways to restore the days.
Welcoming the Sarpanch of Village Kalwan.
Hello everyone, welcome to my village. Every life has a rhythm, a unique beat that guides its journey. Sometimes fast, sometimes slow. Now first, let's witness the rhythm of love. Listen closely. Can you hear the rhythm of love? find the open fields for the crowded cities.
Look at her, so lost, like a fish out of the water.
Exactly. This is a race, and you have just walked in without a gear.
You're boring for us.
Aren't you tired of your drama? Can't you just act normal?
You're a weight for the community. You're a liability.
Your family doesn't need you. Your friends have left you. The society has abandoned you. Your family doesn't need you. Your friends have left you. The society has abandoned you. Your family doesn't need you. Your friends have left you. The society has abandoned you.
Hey friend, what's going on?
I don't feel like myself anymore. I lost my rhythm.
It's alright, I'm here. And I think I can help you find someone who can get you through this.
But who?
An occupational therapist.
Hey, how are you feeling today? Not great. I feel lost. Everything has changed. My psychiatrist has diagnosed me with generalized anxiety disorder. I hear you. Can you tell me a bit more about it? It's everything. The noise, the crowd, the pace of life. Back home, everything was quiet and peaceful. But now, I feel like I can't keep up. It seems like the new environment is making you feel anxious and out of place. Do you feel this way all the time, or are there any certain situations that make it worse? Mostly when I go outside, especially alone. I feel like I'll make some mistake and everyone will make fun of me. These feelings are completely valid, and you are not alone in this. Through occupational therapy, we will make you come back to the society in the most comfortable and confident way. Come with me. Thank you so much for helping me find my rhythm again. Through occupational therapy, I discovered new ways to cope, new passions to pursue, and a new sense of purpose. You empowered me to take control of my mental health, and for that, I'm forever grateful to you. You're most welcome.
Rhythm of life, it moves us on. Lost it once, but hear the chord. Only shows the ways to restore the days.
Group number 6, please get ready. Group number 6. Group number 6, please.
Hey bro, what's happening?
We are here to perform street plays.
Shall I join?
Yeah.
Story 1.
Abdul, raise your hands in 80 degrees.
Yes, sir.
So halt.
Good morning, sir.
Morning, guys. Today we are going to demonstrate how to use and defuse the bomb. So gather here.
Okay, sir.
So guys, this is the bomb. Today we are going to demonstrate. This is very dangerous and explosive. This can explode anyway. So this is the pin. If we take this, it will burst. Boom! Oh!
Military hospital. Excuse me, sir.
Yes, ma'am.
What happened, sir?
He was severely injured. He had no other option than to amputate her hand. Sorry.
It's okay, sir. Sir, get well soon, sir. After a few days.
Ring, 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 ring.
Hello, sir.
Hi, sir. Do you feel better now?
Yes, sir. I hope I'm getting better now. But my mind is mentally disturbed. I don't know how to live with this condition without a hand. I don't know, sir.
Okay, sir. I understand your feelings. I suggest an OTS who will take care of you and guide you.
Yeah, thank you for your suggestion.
Okay, sir.
OT meeting.
Excuse me, sir.
Yes, sir. Get in. Please take your seat, sir. Sir, you are?
Myself, Mr. Karthik, military doctor, referred me to meet you, sir.
Okay, okay. Doctor told me everything. Let's start the section. Okay? Sir, do you feel any pain?
No pain, sir.
Okay. Sir, for how many years you are working in the service, sir?
It's almost 15 years, sir. It's my childhood dream to join in Indian military. I'm the only person in my family who is senior. Without me, there is no one to support my family financially, sir.
I can understand your situation, sir. We will work on it.
Yeah.
Sir, I will call you after the process is ready. Alright? Sir, I have a little suggestion for you.
Tell me.
Sir, why can't you just start a military coaching center? I think it may fulfill your dream.
Oh, it sounds nice. We shall try, sir.
Okay, sir. Bye.
After process is fixed.
Hello, ring, ring. Ring, ring.
Hello,
Hello.
sir.
Hello, sir. Do you feel comfortable now?
Yes, sir. I'm completely better now, sir. Because of your idea, I changed the way of thinking and way of seeing the world. I need to thank you, sir. I'm completely satisfied with my service.
Okay, sir.
Very little, guys.
Military coaching center running successfully. Story 2.
Oh dear God, today is interview day for my child. So please help her and be with her throughout the interview.
Appa, Amma, give me your blessings.
Okay, ma, go safe. Bye.
Sure, Pa. Bye, Ma. Bye, Pa.
Hey, dude. Look at Alexa just walking like a cat.
Hey, Daddy, I kept your eyes on. Do you know how busy a businessman I am? Will my meeting will be successful? If I had a sight on you?
Sorry, sir.
Such a bullshit fellow.
Excuse me, ma'am. May I get in? Yes, get in. Good morning, sir. Good morning, ma'am. Good morning. Take your seat. Thank you, ma'am. My resume.
I think you may search for some other job.
Sir, please have a look on my resume, sir.
People like you are not fit for this job.
Sir, please. You may leave now, ma'am. Please. Security. Sir. Whom do you think will give a job? You can't stay in room. Excuse me, ma'am. Yes, get in.
At home.
Hey, what are you doing?
What happened? Why are you crying? I think I don't fit to survive in this society. I'm getting rejected from all my interviews. I'm a loser, pa.
It's just a job, right? Let me get it for you.
The next
day.
Hey, buddy, how are you? Hey, bro. Yeah. I'm in a bad situation. I need your help. She's my daughter. Hey, wait, I have seen you somewhere, right? The day I charged you in the office, ma. Sorry, I was in some tension.
It's okay, uncle.
Due to her disability, she faces a lot of bad situations in her life, which makes her so depressed. Okay, don't worry about it. I suggest an OTS Chinta. Who will OT, she will take care of you and guide you. Okay, bro. Bye.
Okay, bye.
Excuse me, ma'am.
Yeah, get in. Please take your seat, sir.
Good morning, ma'am. My friend Karthik suggested to meet you. She's my daughter.
Okay, sir. I'll take care of her. You please wait outside for a few minutes.
Ma'am, now you are my last stop, so please take care of her.
Okay, sir. Okay, ma. Now tell me about you and what is the reason for your suicide letter?
I'm Saleh Adisha, MSc Gold Medalist, ma'am.
Wow, super, ma.
Thank you, ma'am. But the society gives opportunity based on the appearance, not for knowledge, ma'am.
No, ma. It's not like that. There are lots of schemes provided by the government that will definitely help you to find a good position and thereby you can achieve your dreams. Don't lose your hope, ma. Keep trying for your success.
Thank you, ma'am. Thank you for your guidance. Your words made me very stronger. Thank you.
Best of luck, ma.
Thank you, ma'am.
Hey, dear. You're not disabled. You are differently able.
After a few days. Ring, 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 ring.
Hello.
Good morning, ma'am. You are calling from AK Event Organizing Company. You are appointed as the managing director for our organizing team. Congrats, ma'am.
Oh, really? Thank you, sir. Thank you so much. Ma, Pa, I have a good news. I got a job.
Congrats, dear. Thank God.
Thank you, Ma. Thank you, Pa.
Story 3.
Hey, bro. I really want to ask you about something.
Yeah, sure, dude.
How is it possible, bro? You are topper of the college, and you are also good at extracurricular activities, and you also just chill with us. How do you manage all of this, bro?
That's simple, bro. How will feel when we are using these drugs? It gets same feel while watching all these things and these lines too. I am Donis, topper of college, topper of university, and very well known senior.
That's awesome, bro. But we are not like that.
It's already getting late, bro. I need to leave.
Okay, I will drop you. Boom! Hey, bro. What happened? Please get up. Oh, shit, his hand is bleeding.
Please, someone call the ambulance.
At hospital.
Nurse, what happened to him?
Wait a minute, sir. Doctor is in emergency ward. He will come and tell you.
Doctor, what happened to him? Is he alright?
I'm sorry to say this. He got severe head injury, but he has saved his life. Unfortunately, he had one-side paralysis.
After a few days.
Yes, Pa, get him. Do you feel better now? Can you manage the day-to-day activities?
Much better, sir. It's difficult to manage day-to-day life. I need support from others to do all activities.
Okay, don't worry about it. I suggest you and OTS. He will take care of you and guide you, okay?
Okay, sir. Excuse me, ma'am.
Yes, come in. Please take your seat. What happened, sir?
I am Todis. Dr. Thirumurugan, sir, referred to me.
Yeah, okay, let's start the session. Can you stretch your arm a little bit, sir?
No,
Are you able to manage your life?
I can manage it, ma'am, but I feel empty. I want to achieve something.
Okay, we have some activities that may help you make independent. So today's activity is painting. Here, take the brush. Do some random activity over there.
Okay, ma'am.
Shall I get in, ma'am? Yes, come in. Ma'am, as we had decided, we are going to conduct a huge artistic competition on Say No to Drug. Here is the pamphlet. Wow, that's nice. Finally, we are done. Do you like to participate in this competition?
Of course, ma'am. I definitely participate. I am here because of drugs. So my arts will make huge impact against the drugs.
Good. All the very best. I will add your name.
Thank you, ma'am.
Competition. Result announcement. It's time to announce the winner of the OT Artistic Competition on Say No to Drugs. Before announcing the winner, now I call upon the great hero of the show, who is the lamplighter for many students' life, ex-military officer Mr. Madhubalan sir, to the stage. Secondly, now I call upon the great event manager, Ms. Adisha. You're also being an inspiration for many women in the community. Kindly join with sir to announce the winner, ma'am.
The winner of the OT Artistic Competition on Say No to Drugs is Mr. Donis.
Group 7, please. Group 7, get ready.
Ladies and gentlemen, this is your captain speaking. आज मैं आपके इवेंट में आपका स्वागत करता हूँ। कृपया अपनी चोली टाइट कर लीजिए ताकि आपका दिल बाहर ना आ जाए।
Before we begin, a quick disclaimer. This street play is an artistic expression intended for awareness, education, and empowerment. We do not intend to objectify anyone. Thank you.
By birth, we are all human, but society labels us differently. Remember, those who have never fallen will never know how to rise. Today, we bring you stories of people who have risen despite all odds.
Oh no! Oh dear! Life's a mess. Buttoning a shirt, total stress. I can't even sit still. Is this a curse? If life was bad, it just got worse. I struggle to write.
I can't hold a cup.
I feel so stuck. I feel fed up.
Fear not, my friend. Don't you cry. OT is here. Let us all try.
Independence is our goal for every heart and every soul.
OT?
What is that?
A magic?
A spell?
Do tell.
Do tell. No magic, no tricks, no spells too.
Just skills that helps.
You do you.
Congratulations, it's a baby boy.
मेरा बेटा तो बड़ा होकर आर्मी में जाएगा, देश का नाम रोशन करेगा।
बापूजी, help me, मैं बहुत बड़ी प्रॉब्लम में हूँ।
ये चीटिया, उठ जा मेरे शेर।
शेर तो सो गया।
ये आलसी।
लगता है आपका और ग्रेविटी के बीच में रिलेशनशिप काफी स्ट्रांग है।
ओहो जेठा जी, what a style!
मेरे उठने का स्टाइल है।
Champak takes Jeta to the doctor who diagnoses him with Duchenne muscular dystrophy and is further going for occupational therapy treatment.
Why are you so tense today? मेरे लाइफ के प्रॉब्लम का सॉल्यूशन सिर्फ आप ही हो. Tell me, what are you worried about? I am just sad. Lately, I have been watching this documentary on army men, and I just love the way they shoot and aim at things. I wish I would be able to do it so. Okay, we will try everything we can. Really?
After 7 years of aggressive therapy, Jeta is now participating in national and regional competition. This is his first time in Paralympics event 2025 and the winning shot.
Victory!
Ring ring! Hello, Shan.
Well, hello. You have been shortlisted for a shoot tomorrow and the director wants to meet you at 5 in the morning.
First of all, stop. You know I have a very specific schedule to follow. I cannot break that.
Oh, come on. For once break your schedule. You want to become a renowned model, right?
Okay.
Rohan goes for the shoot. Shan is already present. He is trying to calm an anxious Rohan down. Lights, camera, flashlight, everything is already set.
Stop! Stop! Stop!
See.
Rohan goes to his occupational therapist, his superhero.
I went for a shoot today. Everything was alright, but flashlights ruined it for me.
Let's start with the goal that you have in your mind.
I want to be comfortable around flashlights, people, and different textures.
His occupational therapist plan worked very well, using techniques like simulated environment, desensitization program, sensory binge, and reinforcement. He's all set to get back to his work.
I see how you're one step closer to your big step.
During the entire time that Rohan was engaged in his OT session, a producer saw his shots in newspaper and called Shan.
Guess what?
What?
You have been enlisted for a really big brand model and you are becoming their well-renowned brand ambassador.
Oh my god, I will try my best.
All the best. Rohan goes for a show. And he aces it. An interviewer asks a few questions to the room.
I came to know from my sources that you are autistic and found it truly inspiring. Who would you like to thank you for your journey?
I would want to thank my superhero, my occupational therapist, my manager Shan, the producer, and the whole crew.
Hello, my cute little green flags. Welcome to the Day in My Life vlog. Today, I traveled in the lifeline of Mumbai and came to Mumbai Central Station. My DMs were flooded with recommendations from this place. Sardar Pav Bhaji. To be honest, guys, it was below average. And I thought it was just...
Suddenly, a masked man comes and throws acid on Zaisha. And
हाँ 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 बहुत रिजेक्ट कर रही थी ना मुझे, अब दुनिया रिजेक्ट करेगी तुझे.
Zaisha is in hospital, struggling to scroll with her one good eye.
Hello, I'm an occupational therapist. How's my favorite superstar doing?
My life is deader than my phone battery after 12 hours of doom scrolling. I can't even get out of the bed without a dramatic exit. Please help me.
Don't worry, we'll turn that dramatic exit into a standing ovation. You're still an influencer, just with a stronger story.
Zaisha struggling to move, to hold a makeup brush, to apply a perfect stroke of eyeliner, and setting up a tripod stand.
Mission accomplished. You can now take over the internet.
Zaisha is now doing a live stream.
Hello, my cute little green flags. I wanted to tell you all about my past experience. Someone tried to destroy me. But guess what? Joke's on them. Not only I'm alive, but also I'm surviving and thriving. Big shout out to my OT because she gave me back my skills and not only my joints. 12 on 10 would recommend.
Because Queen Fleet function.
Also, guys, hashtag Ben Code.
Radha teaches dance to her students.
Again, go 1, 2. Why does my Kataka Mukha looks like a Kataka mess?
Radha was an unstoppable dancer, but suddenly her body has its own mind. What is happening? Radha goes to her doctor and she is diagnosed with Parkinson's. She is further referred to OT.
How may I help you?
Doctor, this Parkinson's make me feel like I won't be able to dance again. Why? Radha without dance is just like Krishna without Radha.
Don't worry, let's get to a new rhythm. See, we have this like a choreography. Every small step leads to a grand performance.
New rhythm? But how?
I'll show you how.
Pop. OT gives voice breathing exercises, improvisation techniques, and rhythmic exercises. After 5 years, when dementia starts, Radha's students complain that she's forgetting her steps. She goes back to her OT.
Doctor, I keep forgetting steps. It feels like I am not able to dance. I teach them the same thing again and again.
Okay, new sentence, new game.
Lock it, pop it, dance and rock it. Step inside and don't you stop it. Arms out wide, swing side to side, jump to the left and let it glide.
I am grateful your words. OT isn't just therapy. It's motion, it's magic in motion. Doctor, thank you for being the choreographer of my comeback story.
After 7 years, when Parkinson's has slowed her body and dementia clouds her mind, her heart still dances. In the quiet of hospice, where time stands still, her soul still has rhythm.
Radhabai, you have shown great strength and courage. Now it's time you remember that your voice matters, your choice matters, because you matter.
Doctor, I have lived a very beautiful life. Now that I want to be remembered is through dance.
Okay, let's try it.
Radha does some slow dance mudras. Gradually, her movements become slow, and she finally rests. ability, from dependence to independence. Thank you.
Thank you very much. All the 7 groups have shown their talent, full of energy and enthusiasm. I'll hand over for comments to Samantha, madam.
Is that still under the group?
2 more.
Oh, we were told.
2 more. Okay, sorry, we had an impression about that there are 7 groups, but 2 more. So I welcome number 8. Yes, please. Group number 8. Start, please. Your time starts.
Welcome, welcome, welcome. Ladies and gentlemen, welcoming you on board. This is Flight 101, OT Skyway, departing to OTCon Panji. As we prepare for takeoff, I kindly request you all to fasten your seatbelts and get ready to enjoy this fun ride. There are 4 exits on this plane, 2 towards the back and... But all of them will be closed because you don't need them.
What is disability? A person with disability is someone with a mental or physical impairment, and it substantially limits their daily life. We tend to sympathize with them, but what they really need is empathy, love, and care. Hey, Hey, Ajji, what happened? You pretend to care for them, but do you really treat them like a normal human? Let me tell you a story. We want a girl, and you all will find your answers.
This tale is of a young girl, no sorrows in her life. Off she went with her friends to enjoy cycle ride. There came a big bike, uncontrolled and fierce. It hit her cycle hard and a voice.
Ari was a fool. When this should have happened to my child only. She's such a nice girl. Doesn't interfere in anybody's life. But where is humanity left in this world? Deva, Pavane.
Hey, what happened to that lady's daughter? It seems like she met with an accident while coming back home. She's only 19 years old, and the worst part is her legs are seriously injured. Oh, I feel so sorry for her.
My dear daughter. She was muscular, she was popular, and one day she met with an accident.
With an accident, with an accident.
She's gone down with surgery, she has no more grave injury. With some help she'll walk again, this shall ease all her pain.
All her pain.
Arey Bittu, you're walking again. My happiness resembles to the day when I saw you walking for the first time. Very good, Bittu. Very good.
Very good, Bittu. Very good.
Everything seems to be fine. There's a smile on everyone's face. But, however,
Why are you so sad, Baba?
Hey, 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 hey.
What is wrong with you, Baba?
Hey, 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 hey. Arey, why are you so sad, Baba?
After all the struggle struggles we have endured just for you. You don't even show us any gratitude. This accident could have been fatal, but by God's grace, we are now all right. Even then, why are you so sad?
You are such a selfish person. Can't you even appreciate your family's efforts?
You were just sitting on a wheelchair. We made you to walk on your feet. Aren't you content?
We managed all your finances for your surgery so that you can walk on your feet again. But all of this in vain.
I had always dreamed of becoming a dancer, practicing through hours so that I can make my family proud one day. You all tell me to be grateful that I can still stand and walk, but have you ever asked me what I want? Oh, Bittu, Ranaka, we understand your difficulty, but what is the solution to this now? Maybe you have to make peace with this new lifestyle, or else who is it that can help you out? Who can help you out? Who is that? Who?
Me. I shall help her out. I will get her life back on track. I will give her adaptive techniques to overcome physical barriers. I will improve her strength and flexibility. I will provide her the rehabilitation necessary for her to achieve her dreams. I will boost her self-confidence and empower her to achieve her recovery goals.
That's fine, but who are you?
I am an occupational therapist who supports people with injuries, illnesses, disabilities, or pains to adapt their environments according to their own needs. We work with them to help them develop new skills or find new and easier way of doing things. We help them function better without any discomfort or pain.
Hey, Bittu, don't listen to her. The waste of Santa. No, Bittu, I think he's a genuine person.
Nare, these therapists just want to loot middle-class people like us.
Oh, nonsense. I think you must give it a try. No, this won't help you in any way, but will worsen your health. No, Bittu, she'll pull you out of your misery and treat you well to become a dancer.
No, Bittu,
stop it.
You won't believe me until I show you the results, will you?
Yes.
Bittu, I don't care about them, but do you trust me?
Yes.
If you fall down, we will there to push you on your feet. If you're tired, we shall raise your stamina back up. Whatever may come, you and me, we always need to be strong. We help you achieve your big dreams and prove all your haters wrong. Dha din din da, dha din din da, dha din din da, dha din din da, dha.
Oh, Neha, you're dancing so well. Thank you so much for becoming my first student. I thought with my injury, I wouldn't be able to dance again. But now, through teaching you, I feel that I can achieve the same. This is all because my occupational therapist gave me a new perspective.
Is it too late now to say sorry? 'Cause we misjudged you and your motive. Is it too late now to say sorry? 'Cause we know you deserve more respect and all we need to be more aware.
Disability isn't a limitation, but lack of opportunity is. We are occupational therapists. We can transition your disability into your new ability.
Independence is not a privilege, but it's a right, and we make sure everyone gets it.
Wheelchair does not define a person. but the courage to move forward does. Let's build a world where barriers are broken and not people's dreams. Empower, enable, and elevate. That's what occupational therapy stands for. Ladies and gentlemen, thank you for choosing OT Skyway 101. I hope you all had a great flight.
Group number 9, please get ready. Group number 9, please kindly come on the stage.
People on the right. People on the left. People in the front. All listen. Listen, listen, listen. Listen, 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 listen. These voices inside my ears are killing me. How will I forget the incident that changed my life? I'm a kid who fought in a war in which I was injured and my legs got paralyzed. People are looking at me as if broken. I did this for my country, but people do not understand me. It would have been better if I lost my life with the war. Stop, 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 stop. Please stop your melancholic thoughts and kindly listen to me. Listen, listen, listen. Listen, listen, listen. Why fear when OT is near? Why fear when OT is near? Why fear when OT is near? I hate my life. What can I do? Can I give my legs back? No, we can't give your legs back, but we can make your steps possible in your path. We make steps possible. We make steps possible.
We focus on rehabilitation towards physical, psychological, and social aspects, including the improvements in performing daily living activities.
Wait. What? Daily activities? Performing daily activities is not my permanent job. I need to live my life to the fullest. Hey, my brave lady, let me show a path to your destiny where vocational rehabilitation will be your guide.
Analyzing your barriers and your abilities is the first consent.
Accessing your abilities and enhancing the level of skills, we determine job retention and job modification possibilities.
Job retention, job modification. Job retention, job modification.
It is possible.
Yes, it is possible. We modify or adapt the tasks and methodologies for better performance in your roles and routines. Adaptive equipment is your right and nature is your pride.
Support to self-management. Workplace modification and energy conservation
finds a home for it to return to work.
We rehabilitate you to return and remain in your own profession. Your life is purposeful and meaningful with your high intelligence.
Soldiers expedite a crucial role in the welfare of our nation. Not only our nation, the whole world. Soldiers are highly metacognitive learners in the field of defense. They are tactic, aware, strategic, and reflective in defense.
Tactic, aware, strategic, reflective. Tactic, aware, strategic, reflective. For instance, our wounded warriors in war now work in Intelligence Bureau and other analyzing committees where they analyze and gather information about the possible threats and protect our country from terrorism and other threats. In this way, their war tactics are still in action.
Your metacognition needs AI.
Your metacognition needs AI. Your metacognition needs AI.
Now, let me share a story where you paved a path to our OT profession.
Is that so? When? Where? And how?
When, where, and how? When, where, and how? It all started when the United Nations joined the World War I, where 1 million soldiers were sent to the war each year, out of which a minimum of 10,000 returned home disabled.
Up until then, we were just concerned only with the treatment of people with mental illness.
Due to the escalating number of injured and disabled soldiers, it was a daunting challenge for those who were in command. As OTs, we were not only healing their bodies, rather reviving their souls and spirits.
Not only that, nowadays we collaborate with the social workers, vocational counselors, and NGOs to make them aware of the available programs such as
Resettlement training,
reservation for ex-servicemen in central government posts,
Financial assistance procuring mobility aids.
we, the occupational therapists, shall pledge to express our endless gratitude to the ones who serve for our country and to give exceptional occupational therapy services with care and compassion. We utilize our skills and knowledge to improve independence, confidence, and purpose, and to promote physical and mental well-being.
Thus, the honor plays in us, maintaining confidentiality, upholding ethics, striving excellence in education, research, and practice. We recognize the service of military personnel and their families by creating positive impact in their lives. We pledge that we serve with respect, humanity, and selflessness.
Thank you.
Do you? You want me to speak? I'm really not sure because she keeps looking at me. Do you want me to say something? Okay, right, okay. Okay, thank you to all of the groups. That was my first observation and first experience of street play. So thank you to everybody, not just for the entertainment, but also for the very clear messages there was some very difficult storylines there, but they were all approached with real empathy, clarity, and a little bit of humour. I really loved the use of song and the clapping. So thank you very much for all of the efforts of all of the groups. Thank you.
Thank you very much.
Thank you, participants. That was a power packed performance, and thank you, Chairperson. I would like to invite Dr. Joseph Sunny, Sir, Honorable Secretary, IOTA, to felicitate our Chairperson, Dr. Samantha Shan, Ma'am, WFOT President, with a memento. Thank you, sir. Thank you, ma'am. I would like to call upon Honorable President of IOTA, Dr. Pankaj Bajpai, sir, to felicitate our chairperson, Dr. R.K. Sharma, sir, Dean, Santosh University, with a memento and a certificate. Thank you, sir. As we come to the end of the scientific sessions of OTCon 2025, I want to thank everyone for their active participation and insightful contribution under the theme Translating Research into Policies and Clinical Practices, Occupational Therapy. To our esteemed audience, and your active participation, curiosity, and engagement have truly enriched this session. Your presence gave an importance of continuing collaboration in advancing occupation therapy, ensuring its evolving impact on individual and communities. The knowledge shared today and all the 3 days of the conference enriches the significance of researches driven practices, innovation, and interdisciplinary collaboration. Let us continue to push boundaries, explore new perspectives, and work towards a future where occupation therapy continues to transform lives. With that, we extend our sincere thanks to each one of you for making this event a grand success. Wishing you all a continuing success in your endeavor. Thank you. There is an announcement to be given. Members kindly join the Slido for Best Member Delegate Award. Details have been given in your WhatsApp group, OT Icon Delegate group. Thank you.
Good evening, respected dignitaries, esteemed guests, colleagues, delegates, and dear friends. I welcome all of you on this special evening as we gather for the valedictory function of OTCon 2025. All of you will agree with me that the past 3 days have been an enriching and inspiring journey as we together explored our theme for this year, translating research into policies and clinical practices in occupational therapy. In these 3 days, we have heard from brilliant speakers, engaged in stimulating discussions, and gained valuable insights from thought provoking panel discussions and paper presentations into how research can guide our policies and impact clinical practices across the nation. Each session of this conference has been a stepping stone toward advancing our collective knowledge while strengthening the ties within our professional community. It has been inspiring to witness the enthusiasm and commitment of everyone who attended, the presenters who shared their insights, and the volunteers who worked tirelessly behind the scenes. Thank you to each one of you for being part of this incredible conference. I now request our Honorable President of IOTA, Dr. Pankaj Bajpai, to invite the chief guest of this evening, Shri Devidas Pangam, Honorable Advocate General of Government of Goa, on the dais. I also invite all other dignitaries, Dr. S.M. Bandekar, Dr. Sandeep Sardesai, Dr. J.P. Tiwari, Samantha Shawn, our AIOTA committee members, Dr. Pratibha Vaidya, Dr. Jyotika Bijlani, Dr. Joseph Sani, Dr. Satish Maslekar, Dr. Ganapati Shankar, Dr. Raghuram, Dr. Anbarasu, Dr. Anurupa Senapati, and Dr. Bhavya Chandrakar to the dais. We are honored today to have on the dais the presence of such distinguished guests, and we would like to show our gratitude to you for gracing this function with your presence. I request our Honorable President of IOTA to felicitate our chief guest, Shri Devidas Pangam, with a small memento. Next, I request Dr. Pratibha Vaidya ma'am, Vice President of IOTA, to felicitate Samantha Shawn, President of the World Federation of Occupational Therapy. I now request Dr. Jyotika Bijlani, Dean Accord, to felicitate Dr. S.M. Bandekar, Dean of Goa Medical College and Hospital. I now request Dr. Joseph Sunny, Honorary Secretary of IOTA, to felicitate Dr. J.P. Tiwari, Dean, Faculty of Medicine, Professor and Head of Department of Nephrology at Goa Medical College. I now request Dr. Sandeep Maslikar, Honorary Treasurer of IOTA, to felicitate Dr. Sandeep Sardesai, Director Academic of Goa Medical College and Hospital. I once again thank you for gracing this function with your presence. The organizing committee would like to thank our Honorable President of IOTA, Dr. Pankaj Bajpai, for being our strongest support throughout the journey of this conference. I therefore would like to request our chief guest, Shri Devidas Pangam, to felicitate Dr. Pankaj Bajpai for being such an inspiring leader and providing his guidance throughout this conference. Dr. Pankaj Bajpai, sir, I now invite you to deliver the valedictory address and formally begin this function.
Honorable Advocate General Sir, State of Goa, respected Dean Sir, Goa Medical College, respected Professor Tiwari, respected Director Academics, respected President WFOT, Ms. Samantha, all my executive committee members, organizing secretary of this conference, Dr. Vivek, scientific chairperson of this conference, Dr. Ganpati, respected ex-president present here, Dr. R.K. Sharma, my colleagues, delegates, and dear students. A very good evening to everyone. It is my great pleasure and proud moment that in this conference, the Advocate General of State of Goa is gracing this occasion. Thank you, sir, to be with us. I am thankful to Dean, Goa Medical College, Goa, to grace the occasion, sir. Three days have passed very quickly. From morning to evening, from morning 9 to not evening, rather late night, 10, 11, 12. So many presentations which were really enriching. We have started basically from pre-conference workshop, which was held one day before to this conference conducted by Miss Benson from USA on a very important topic of ideation to functional execution in the school setting by children having apraxia, means having some movement disorders. Then we have 2 pre-conference continuing occupational therapy education programs on a very special subjects of onco rehabilitation on head, face, and neck, conducted by Dr. Manjusha from Tata Memorial Hospital and Dr. Hitesh Gupta from BLK Max Hospital, New Delhi. These two presentations were excellent because they have shown the role of occupational therapy and the function of occupational therapy in those cases of cancer where there is a surgical intervention on the face level or a mouth level or a neck level. So how those patients can be made to use or their mouth for talking, for speaking, and for eating and feeding. Excellent lectures were there, and an eye opener for many occupational therapists also who are restricted to a physical disability sector. So those presentations have opened new avenues for the students also and new graduates also to opt for that area. So excellent lectures were presented by them. Various researches have been scientifically which were done at their college level. They have presented by various delegates on various topics which can be utilized to gain or to use for a policy decisions also at the government level, which can be bring down to the ground level for the use of the patient. So such type of presentations were made here, again with the theme of this 62nd Annual National Conference of All India Occupational Therapists Association, that is translating research into policy and clinical practice in occupational therapy. Then there were many guest lectures of various topics of interest and various new dimensions have been presented before the delegates to enrich their knowledge. Students' participation was excellent. So many colleges from all over India are participating in this OTCon 2025 at Goa. Most of the colleges are from Chennai, but other colleges are also have participated, like from Indore, like from Kolkata, like from Mumbai. So various colleges are there from who have participated in different events, and Manipal. They had a very good competition related to innovative technologies, and poster competitions were there. And at last, sir, you have seen this street play competition on a very nice topic of empowering lives of persons with disabilities through occupational therapy. So from this forum, I would like to definitely congratulate Dr. Vivek, who was the organizing secretary of 2025 Goa, and he definitely needs a applause from the audience and from my side too. I also congratulate to conduct the scientific sessions successfully by Dr. Ganpati, one of our EC member, along with Dr. Anbarasu, another EC member. They did a marvelous job in conducting the session smoothly. They were running here and there continuously. You must have observed. But ultimately, they concluded all the sessions successfully, and in a little bit late, though it will be late, but still it happens in such type of big programs. I will definitely thank one more person, Dr. Chetan, who was unable to attend the conference, but who was busy with arranging the conveyance of all the delegates. And most of very tedious job, arranging the conveyance as well as looking after the accommodations of each and everyone. Continuously he was running here and there. I also extend my appreciation to all the sponsors too, who have supported us and partnered with the organizing committee of OTCon 2025 and to promote the occupational therapy activities through conference. From IOTA side, we hope that they will continue their support in the same manner in future conferences also. Thank you very much. I will also appreciate the presence of all the delegates here. Very senior delegates are present. Many students are there. Young delegates are there. And they have participated in different competitions very enthusiastically. And it is also a praiseworthy. I hope that everyone will get award. And the award is only appraisal. Thank you. I will not take much more time from here because I know what for you are waiting here. So thank you very much, sir. Thank you again to all of you. Thank you, sir.
Thank you, sir, for your words of encouragement and sharing your reflections on this year's conference with all of us. It's now time to reflect on the scientific aspect of this conference. The academic sessions have truly been the heart of OTCon 2025, featuring latest research and thought-provoking discussions. Our respected scientific chairperson, Dr. Ganapati Sankar, has been at the helm of organizing the scientific content of this conference, ensuring that the research presented is not only informative but also impactful. I now invite respected Dr. Ganapati Shankar sir to present the report on the scientific sessions of OTCon 2025.
Our respected Advocate General, Government of Goa, our respected Chief Guest, Chief Guest, Advocate General, Government of Goa, our respected Dean Medical, Goa Medical College, our respected Director Academics, Goa Medical College, our respected President, IOTA, Vice President of IOTA, and Secretary and Treasurer, and all AOTA Executive Body member, and all AOTA life member of IOTA, and student delegate. Good evening to everyone. This 62nd annual IOTA conference, we have selected the theme translating research into clinical practice as well as the policy. So why we are choosing this theme? In Indian context, occupational therapists are doing research, but the documentation is lacking. The quality of research also lacking. So during the conference, before the conference, 1 month before, they are writing some papers and submit to the any conference for just name check of paper presentation. So similar way, this time also we have received some of the paper without the quality. So that's why everyone should know about the value of research. So due to this only, we don't have the adequate documentation to create a policy for occupational therapy. So still we are behind other professional. So that's why in the government post and all, it is very difficult to get compared to other professional. So that's why we are choosing this topic. So this time we have received almost 75 oral paper presentation. So out of 75 was scrutinized, we have selected 46 paper presentation. So young occupational therapists presented in various themes in the pediatrics, mental health, orthopedics, neuroscience, hand rehabilitation, and geriatrics and ergonomics. In various themes, they presented their original research work in their platform. Similarly, 23 e-poster presentations from various colleges in India, occupational therapy colleges. We have invited the 7 speaker from occupational therapy fraternity, mainly related to our conference theme. Driver evaluation, it is the one of the main core of occupational therapy, but Indian context, it is very difficult. So that's why we have invited occupational therapists who are all practicing in this field from Dubai. He explained very well. Our chairperson, NCAP, she also appreciated through this conference. She knows very well role of occupational therapy in driver rehabilitation and evaluation aspect. She spoke to me. She appreciated for that particular presentation. Similarly, we invited many speakers for new area. Our Dr. Kamal Arya, the EC member of ACCORD, he also explained very well how to select the journal for publication. So many people they selected the predatory journal. So that's why we invited to enlighten our young occupational therapists. So similarly, many things happen related to our research, how to convert our original research to our clinical practice and policy. We have conducted 1 hour panel discussion. What are the challenges faced in the research to convert the research into the policies? How we are going to overcome that also clearly discussed. So I hope that the outcome of this conference we receive in future our young occupational therapy young occupational therapists will involve good research. Through that we create more evidence-based practice in occupational therapy. We create more policies in the field of occupational therapy. We submit the more paper with appropriate document. In this conference in IOTA history, we have conducted first pre-conference workshop international level. That also 139 participant attended. The good feedback from all the participants. The resource person from USA, she conducted the workshop how to assess the children in the school environment and how to give the occupational therapy intervention, because nowadays there is more demand in the school based occupational therapy. The problem is how to assess, how to give the intervention in the school environment. So she clearly explained. Finally, I would like to thank our respected IOTA president and IOTA executive body for this opportunity, as well as organizing secretary for this OT Icon 2025 for proposed my name for this conference as a scientific committee chairperson. I would like to thank my team member, scientific committee team member, Dr. Anbarasu, Dr. Purani, Dr. Parag Padusul, Dr. Bhuja, Dr. Priyanka, and Dr. Charmini, all 3 from Goa Medical College, 2 from SRM College of Occupational Therapy, and other volunteers also, Dr. Lakshmanan, Dr. Sriharis, and other judges and chairperson. I would like to thankful for all judges, all chairpersons, and all professional delegate and student delegate who are all helping to conduct this conference successfully. Thank you, one and all.
Thank you.
Thank you, sir, for sharing your insights with us. Dr. Professor S.M. Bandekar, our respected Dean of Goa Medical College and Hospital, has been a vital part of the academic landscape of our state and has always been a strong advocate for the integration of occupational therapy into medical curricula and healthcare clinical practice. I now request Dr. Bandekar to reflect on OTCon 2025.
Honorable Advocate General Sri Devidas Pangam, the President of Indian Association of Occupational Therapists, Dr. Pankaj Bajpai, Secretary Sunny, please don't mind my voice. It is my vocal cords are disabled by this viruses. I was in fact not too well. The other dignitaries on the days and off the days and the dearest delegates who came to Goa to attend this 62nd OTCon, partly in Goa Medical College and partly in this venue. It is indeed a great event, and when I first time spoke to Dr. Vivek, I said such events must happen in Goa, state of Goa, so that our students, UGs and PGs get a greater exposure to know what is happening around the world. As I told you that we had only 2 occupational therapists when I was a resident, and now we have a college of occupational therapists. Our aim is to improve the medical education in Goa Medical College and also add on master's degree in occupational therapy. Presently we have 7, and we intend to add on more masters in Goa Medical College. We are also thinking of having PhD because we got approval of the government to start PhD courses. And once, I think by next academic year, we should be starting PhD in occupational therapy. I would like to say that this particular conference had a very, very great academic feast. I had gone through the program and I know the certain topics like artificial intelligence and also the rehab of what is called as head face neck resection, or we call it as wide resections in the oncology. These are the topics which the younger generation should know, basically because this is going to be the need of the hour in the society. As there is increasing incidences of cancer and equally increasing numbers of oncological surgical doctors. As I told you, the surgeons only love their knife, but they don't know what disabilities remain after a radical dissection or the wide resection of the tissues. I heard that lecture was the best, and I really congratulate the faculty who came from Tata and Max Hospital, Delhi. They have hands-on and they have the real experience of wide resection in the patients. We also have taken a policy decision. My Honorable Minister for Health was with me today in a camp, and he told me that every occupational therapist who graduates from Goa Medical College in future will get a government job. And that will be his or her choice. It is not going to be a bond or compulsory. If they feel they should work in government setup and help the people, they will be more than welcome and they will be given this job. And we are thinking of having a unit in every sub center which will care for the elderly people and people who need support from the occupational therapist. I do not want to take much time. I wish all the best to all the participants, the award winners, students who have not won the awards. They can win next year, but that enthusiasm to present a paper and to have a research is bigger than any award. So I wish you all the best and very safe journey back home. Thank you.
Thank you so much, sir, for those encouraging words. We are extremely privileged to have with us today Shri Devidas Pangam, Honorable Advocate General of the Government of Goa, as our chief guest. The role of legal frameworks in shaping public health policies cannot be overstated, and Shri Devidas Pangam has been an important figure in advocating for policy reforms that enhance healthcare delivery. We are grateful to have you here with us, sir, and now I invite you to share your thoughts with us.
Good evening, ladies and gentlemen. On this occasion, on the dais, we have Dr. Shivanand Bandekar, Dean of Goa Medical College, a dear friend of mine. Dr. Sandeep Sardesai, Director Academics. Dr. J.P. Tiwari, Professor and Head of Nephrology Department of GMC. Dr. Samanta Sen, the President of WFOT. Dr. Pankaj Vajpayee, President of IOTA. Dr. Pratibha Vaid, Vice President of IOTA. Dr. Joseph Sunny, Secretary of IOTA. Dr. Jyotika Bijlani, Dean Acton. Dr. Satish Malsekar, Treasurer of IOTA. Dr. Ganpati Shankar, Scientific Committee Chairman. Dr. Abarasu, EC Member of IOTA. Dr. Raghuram, Member. Dr. Anurupa Senapati, EC Member of IOTA. Dr. Bhavya, EC Member. Dr. Vivek, the Organizing Secretary. Welcome to Goa, all of you. It's my privilege to be here, and it's an honor to be part of this function. As a lawyer, my perspective may differ from that of a clinician or a researcher, but I believe that it is crucial to understand how the legal and policy frameworks that govern healthcare system can significantly shape the practice of occupational therapy and, more importantly, the lives of those who depend on your expertise and care. Occupational therapy can play a crucial role in the lives of our clients, particularly in legal matters involving personal injury, disability, and rehabilitation. As attorneys, we are often tasked with seeking justice, securing compensation, and ensuring that our clients receive the resources they need to recover and move forward. Yet, the importance of rehabilitative services like occupational therapy cannot be overstated in this journey. Occupational therapy is not merely a healthcare service, it is a transformative force that empowers individuals to regain their independence and quality of life after an injury, illness, or disability. Whether we are representing a client recovering from a car accident, dealing with aftermath of workplace injury, or advocating for someone with a chronic illness, occupational therapy is an essential component of rehabilitation process. One of the core objectives of occupational therapy is to restore or enhance an individual's ability to perform essential activities of daily living. These occupations include simple yet vital tasks such as eating, dressing, bathing, and working. For many of our clients, a personal injury or disability can severely impair their ability to perform these tasks, leaving them dependent on others and significantly lowering their quality of life. As an attorney, it is our duty to ensure that our clients have access to care and resources they need to regain their independence. Occupational therapy is instrumental in this regard, as it helps individuals learn or relearn the skills necessary for everyday life. Imagine a client who has suffered a stroke or serious injury. They may not be able to tie their shoes, prepare a meal, or even go to work. The therapist's role is to assess their abilities and then create a tailored plan that addresses these specific challenges, gradually helping the person regain control over their lives. From a legal perspective, it is essential that we not only understand the value of occupational therapy but also advocate for it during the course of litigation or settlement negotiation. It is our responsibility to ensure that the clients receive compensation for the cost of these critical services, whether through insurance claims, workers' compensation, or personal injury suits. The cost of occupational therapy should be factored into any settlement or claim, as it often represents a substantial part of rehabilitation process. As you well know, research is the foundation upon which effective healthcare practices are built. In the realm of occupational therapy, research provides us with critical insight into how people function, adapt, and recover. However, research by itself does not create change. For research to have a meaningful impact on the communities we serve, it must be translated into policies that supports its implementation and into clinical practices that ensure its benefits reach people who need them most. As a lawyer, I often see the profound impact that policies and laws can have on healthcare. Law determine the framework within which healthcare professionals operate and can either facilitate or obstruct the integration of new evidence into practice. Our occupational therapy to evolve, it must have a legal and a policy environment that fosters innovation, collaboration, and access to care. In conclusion, the work you do as occupational therapist is transformative. But for that transformation, it to have the widest and most lasting impact, we must ensure that research is translated into policies that guide healthcare and that those policies are reflected in your daily clinical practice. By working together across disciplines, we can ensure that people who depend on occupational therapy services receive the care and support they need. And to end my speech, I thank you all of you for having me here. Uh, and I congratulate you for organizing this function so effectively. We as a Goan are very proud to have you here, and I hope that in near future you will be here with better functions and better conferences. Thank you so much, and thank you everybody for inviting me here. Thanks a lot.
Thank you, sir. I now request all of you to join me in felicitating the IOTA committee members for their efforts and continued support in making this conference a grand success. I request Dr. S.M. Bandekar to please come forward to felicitate Dr. Pratibha Vaidya, Vice President, IOTA, Dr. Jyotika Bijlani, Dean Acott, Dr. Joseph Sunny, Honorary Secretary of IOTA, and Dr. Satish Maslekar, Honorary Treasurer of IOTA. Thank you, sir. I now request Samantha Shawn, President, WFOT, to please come forward to felicitate Dr. Ganapati Sankar, our Scientific Chairperson, Dr. Anbarasu, IOTA Executive Committee. Dr. Raghuram, IOTA Executive Committee. Dr. Anurupa Senapati, IOTA Executive Committee. And Dr. Bhavya Gaur Chandrakar, IOTA Executive Committee. Thank you, ma'am. I now request Dr. Sandeep Sardesai, Director. Sorry. Thank you, ma'am. I now request Dr. Sandeep Sardesai, Director Academic of Goa Medical College, to please come forward to felicitate the ACOT Executive Committee members, Dr. Shailaja Jaiwant, Dr. Vijay Batra, Dr. Kamal Arya, and Dr. Sriharsh Jahagirdar. Dr. Shailaja Jaiwant, ACOT Executive Committee member. Dr. Vijay Batra, they are not present, but Dr. Sriharsh Jahagirdar, ACOT Executive Committee member. Thank you, sir. Lastly, I request Dr. J.P. Tiwari to please come forward to felicitate the IJOT committee members, Dr. Lakshmanan, Dr. Murli Krishnan, and Dr. Kaushik Sau. Thank you, sir. It is now time to recognize the efforts of the organizing committee who have been working tirelessly behind the scenes to ensure the smooth execution of this conference. I request Dr. Bhavya, IOTA Executive Committee member, to please come forward to felicitate the Scientific Program Committee members of OTCon 2025. Dr. Charmaine Almeida, Dr. Purni P., Dr. Anbarasu, and our scientific committee chairperson, Dr. Ganpati Shankar. Thank you, ma'am. I now request Dr. Anurupa Senapati, Executive Committee member of IOTA, to please come forward to felicitate the organizing committee members. Dr. Siddhika Raut, Dr. Akshata Mahale, Dr. Gopal Gaonkar, and Dr. Velanki Raposo. It's okay, you go, Velanki. Thank you, ma'am. I now request Dr. Raghuram to please come forward to felicitate Dr. Chetan Gowde, Dr. Prabhakar Matkaikar, and Dr. Priyanka Raikar, who has been the organizing committee member as well as the scientific committee member. Thank you, sir. I now request Dr. Satish Maslekar, our honorary treasurer of IOTA, to please come forward to felicitate Dr. Pooja Vajratkar, the organizing as well as the scientific committee member. Dr. Mahira Kantawala, that is myself, so I'll just go.
Dr. Mahira.
And Dr. Parag Atsul, who is the organizing as well as the scientific committee member. Thank you, sir. I now request Dr. Joseph Sunny, Honorary Secretary of IOTA, to please come forward and felicitate our organizing secretary, Dr. Vivek Vajratkar. No.
Cultural team felicitate.
Not this, sir. Names are not given to me. We also want to recognize the efforts of our conference coordinator, Dr. Jyotika Bijlani, who is not here with us, but want to definitely recognize her efforts and continued support. We now come to the most awaited and important segment of this function. Any guesses? The awards. It is now time to recognize the outstanding achievers of this conference who have showcased significant impact in the field of occupational therapy through their work. I now call upon our Honorary Secretary of IOTA, Dr. Joseph Sunny, to announce the award recipients of OTCon 2025.
Respected Chief Guest, Advocate General Sri Devidas Pangam, Goa Medical College Dean Dr. S.M. Bandekar Sir, Director Dr. Sandeep Sir Desai, Dean Faculty of Medicine, Dr. J.P. Tiwari, Professor and HOD of Department of Nephrology, President of IOTA, WFOT President, Treasurer, Scientific Committee Chairperson, Organization Secretary, Dean Accord, and all the other Executive Committee members, IOTA members, senior members, HODs, and students. I know you all are waiting for this award announcement. Every year we give during the validity function. Since we are running out of time, I am just going to announce award. First, we will go to the Professional Delegate Category Awards for the Scientific Program. Kamala V. Nimkar Award for the Best Scientific Paper. Simran Sandeep. I request of Chief Guest to give this award. Redkar Simran Sandeep. Congratulations. I request the Chief Guest to give the next award is Dr. Vijay Supplai Award for the Best Scientific Paper in Mental Health goes to Dr. Kiran V. Talkonde. Congratulations, Dr. Kiran. Next award is Ona Desai Award for the Best Scientific Paper in Neuroscience. Goes to Dr. Nidhi Sujindra Agni. Dr. Nidhi Sujindra Agni. Congratulations. Next award is IOTA Best Scientific Paper in Pediatrics. Goes to Dr. Deepak Vignesh Raj. Congratulations, Dr. Deepak. Next award is MM Sangoy Award for the Best Scientific Paper on Ergonomics and Environment Accesses. Goes to Dr. Arfa Menesis. Dr. Arfa. Next award is Bharati Kirti Patel Youth Talent Award for the Best Scientific Paper. Goes to Dr. Purushothaman P. Congratulations, Dr. Purushothaman. Next award is N. Swaroop Award for the Best Innovative Technology goes to Dr. Vinod Kumar T. Dr. Vinod Kumar T. Yeah, on behalf of Dr. Vinod Kumar, his friend is collecting. Next award is Dr. Nirmala Venkateswaran Award for the Best Mini Movie of the Oticon 2025 goes to Dr. Blasen Baggio. Dr. Blasen Baggio. Best Mini Movie of the Oticon. Next award is Best Delegate of Oticon 2024-25 award by Kerala branch of IOTA. We give this award to the best delegate based on the scientific presentations we conduct in exam. Based on this, we are giving this award. This award goes to Dr. Anna Daniel. Congratulations. Next is E-Poster Award. E-Poster Award goes to Dr. Miraculin Devadarshini. The next award is Best Student Delegate Oticon 2025 award by the Karnataka branch of IOTA in memory of Dr. Ebenezer Rajkumar Wilson. I also invite the Karnataka branch convener also to the stage, Dr. Lakshmanan, along with the chief guest. The award goes to Manasa from Manipal College. Thank you, Dr. Lakshmanan. Next, moving on to the Student Scientific Category Awards. All are excited. IOTA Trophy for the Best Poster. Third prize goes to SRM College of Occupational Therapy, Chennai. Students, please come to the stage fast. IOTA Trophy for the Best Poster Award. Third prize goes to SRM College of Occupational Therapy, Chennai. Come quickly, come fast. Only one person. IOTA Trophy for the Best Poster. Second prize goes to JKK College of Occupational Therapy. First prize, any guess? KEM College, Mumbai. Congratulations. The next category is IOTA Trophy for the Best Innovative Technology. Third prize goes to DY Patil College, Mumbai. DY Patil, Mumbai. Congratulations. Second prize goes to KMCH College of Occupational Therapy, Coimbatore. First prize, IOTA Trophy for the Best Innovative Technology goes to Jamia Ahmad Delhi. Next is IOTA Trophy for the Best Street Play. Third prize goes to DY Patil, Mumbai. DY Patil, College of Occupational Therapy. Second prize goes to Manipal College of Occupational Therapy. First prize goes to NIPMR. Next is OMG Provo Award for the humorous posters. First prize goes to KEM Mumbai.
Best.
Yeah.
Best.
Best OMG Provo Award for humorous poster goes to KEM Mumbai. Next, thank you, sir. Next, I request Dean Dr. S.M. Bandekar, Goa Medical College, to give the award. Gold Medal Award for the Best OT Graduate of 2024 by Orissa Branch of IOTA. I request Dr. Anirupa Senapati Madam also to accompany. It goes to Rida Ashkar. Thank you, sir. So with this, I conclude this session. I congratulate all the students and delegates who got the award. Thank you. Thank you, sir. I'll give the mic to Mahira.
Congratulations to all the winners. OTCon 2025 has not only been a hub for scientific exchange, but also a celebration of the rich cultural diversity of our country. The cultural awards will honor those who have brought creativity, energy, and joy to this conference through performances and artistic expressions. I now invite Dr. Pooja Vajratkar, Cultural Committee in charge, to announce the cultural awards.
Good evening, everyone. We are gathered here today to celebrate the incredible talent showcased in the various cultural programs. It is with great pleasure that we announce the winners in each category, recognizing the creativity, effort, and dedication that each participant has put in their performances. So let's start with the award ceremony. May I call upon our beloved Professor Dr. S.M. Bandekar, sir of GMC, to give this award. So let's start with solo dance category.
Just 1 minute. 1 minute. Sorry, because Dean sir wants to go early, so I want to announce one award which is on his name, which is we announce as a from Goa Medical College. This award is for the most enthusiastic faculty award, and it goes to the Dr. Sebastina D'Souza, Manipal. Yeah, on behalf, if anybody come, Manipal can come and collect. Okay, next award also from the Goa Medical College and Organizing Committee, which is the most enthusiastic clinical practitioner award. It goes to Dr. Trishala Upadhyaya, Mumbai Reach Therapy Center for Children, Mumbai. If anybody is there. In name of this award is in the name of Dr. J.P. Tiwari, Professor and Head Department of Nephrology. Now I'll call again the Dean Sir. There is one more award, just one more. And the Director Academics, both. This is the Most Spirited Institute Award, which is based on the maximum number of registration, number of participation in scientific and cultural events, attendance in scientific and cultural inauguration and etc., and overall behavior of the students during the conference. And it goes to the SRM College of Occupational Therapy. Thank you.
So let's start with the cultural awards, and in the solo dance category, the third prize. This was a performance with a beautiful theme of celebration of life. They brought an energy that was truly vibrant. Yes. So may I call upon Dr. J.P. Tiwari sir to give this award, and this award goes to JSS College SD4. Solo dance. Second prize for solo dance, KMCH SD5. And first prize, any guesses? SRM College. So much of enthusiasm. Next is the group dance category. Next in the group dance category, the third prize and the accolade goes to Manipal College. And the second prize goes to SRM. Congratulations. And the first prize, their take on mythological stories was deeply engaging and powerful. Any guesses? NIPMR. Congratulations. Yes. Now I call upon Dr. Sandeep Sir Desai sir to give the next award, and we are moving towards fashion show. And the third prize goes to JSS College. Congratulations. Second prize goes to Manipal College. And first prize, the theme of divine and glamour, was brought to life with elegance and grace. The performance that truly shined is NIPMR. Congratulations. Now I call upon WFOT President Dr. Samantha Shan to give the following awards. Now in the group singing category, the third prize goes to Manipal College. The second prize goes to SRM College. First prize their harmony and collective talent were nothing short of exceptional. The excellence goes to NIPMR. we have found one Visa card named as Vancy D'Souza. Can you come backstage and collect it, please? And next, finally, in the instrumental music category, the third prize goes to JKK MMFRF. Second prize goes to KMCH. And first prize, the musical arrangement was flawless, creating an immersive experience. The moment of glory belongs to SRM. A huge congratulations to all the winners as well as to every participant who made this event so memorable. Each performance demonstrated immense talent and the dedication of all involved in truly commendable. Thank you for making this event a success. Let's continue to encourage the spirit of cultural expression and creativity. Congratulations all. Thank you.
Hearty congratulations to all of you. Now, this is a little emotional moment for me as we bid farewell to OTCon 2025. It's coming to a close, it's coming to an end. But we eagerly anticipate the next chapter. I now invite Dr. Anurupa Senapati to extend her heartfelt invitation and formally invite all of you for OTCon 2026.
Hello, good evening everyone. It's my immense pleasure to invite one and all delegates, student delegates present here to come to Odisha for celebration of OTCon 2026. The date and the venue shortly we are going to announce, and we hope all the students from every corner of our country will participate in this conference and try to make this conference a grand success. Thank you.
In keeping with the tradition of supporting AIOTA's future endeavors, the organizing secretary, Dr. Vivek Vajratkar, will now present the check representing the proceeds from OTCon 2025 to IOTA. This gesture is a testament to the hard work and dedication of the organizing committee and their commitment in advancing the profession. I now invite Dr. Vivek to present the check to our Honorable President of IOTA, Dr. Pankaj Bajpai, and our Honorary Treasurer, Dr. Satish Maslekar. As we near the conclusion of this beautiful evening, it is time to express our deepest gratitude. The success of OTCon 2025 would not have been possible without the tireless efforts of many, many individuals. To formally acknowledge everyone's contribution, I once again invite the organizing secretary of OTCon 2025, Dr. Vivek Vajratkar to deliver the vote of thanks.
Good evening. Today's chief guest, Honorable Advocate General Shri Devidas Pangam sir, esteemed guest, Dr. Samantha Shan, President WFOT, Dean Goa Medical College, Dr. Pankaj Vajpayee sir, President AVOTA, uh, uh, then Honorary Secretary Dr. Joseph Sani, Treasurer Dr. Satish Maslekar, Dr. J.P. Tiwari, Dean Faculty of Medicine, and the Professor Head of the Department of Nephrology, Sardesai sir, and distinguished guests, respected delegates, and esteemed colleagues. It is with the great honor and immense gratitude that I stand before you today as we come to the close of the OTCon 2025. On behalf of organizing committee and all attendees, I express my heartfelt gratitude to our distinguished chief guest, Honorable Advocate General Shri Devidas Pangam sir, for gracing us with your presence today at the OTCon 2025 conference. As we draw the curtain on this remarkable OTCon 2025 conference, it is our honor and privilege to extend our heartfelt vote of thanks to our esteemed guest, Dr. Samantha Shan, President WFOT, for gracing us with your invaluable presence and participation. Also, it is our honor to extend our deepest gratitude to respected Dean Sir, Professor Dr. S.M. Bandekar, for his unwavering support in organizing this conference. Your leadership, vision, and commitment to advancing in the field of education, healthcare have been instrumental in making this event reality. From initial planning stages to the final moment of this conference, your guidance and encouragement have been invaluable. Just the success of OTCon is the testament of your dedication, belief in the importance of bringing professionals together to learn, share, and collaborate. With respect to his dedication and support to this event, I would like to inform you that when you check your certificates, you will find there are all digital signatures except Dean Sir's signature, which he's done manually. So approximately 5,000 certificates he signed manually. So it is that much he's involved in this. I would like to take this moment to extend our heartfelt gratitude to our esteemed President, Dr. Pankaj Vajpayee sir, and other official bearers of the AVOTA and the ACOT EC and the other members. Your invaluable contribution throughout this event has helped shape the course of our discussion, and your leadership in advancing the field of occupational therapy has been truly inspiring. We deeply appreciate time, effort, and expertise you have shared with us. Your dedication to profession and to enhancing the practice of occupational therapy at the national level is evident in everything you do. We are privileged to have had you with us at this conference. I would like to take a moment to express our heartfelt gratitude to our scientific chairperson, Dr. Ganpati Shankar, for your exceptional leadership, guidance throughout this event. Your meticulous planning, dedication have ensured that scientific sessions were of highest quality. Thought-provoking discussion, innovative ideas, cutting-edge research presented have highest quality. The throughout-provoking discussion, innovative ideas, and cutting-edge research presented have not been only enriched our knowledge, but also have inspired us all to push the boundaries of our profession. Your commitment to the excellence have been driving force behind the success of this conference. We are truly grateful for your hard work, vision, and unwavering commitment to advancing the field. Thank you, sir. On behalf of organizing committee and all participants, I extend our sincere thanks to my respected teacher and conference coordinator, Dr. Jyotika Bijlani ma'am, for your invaluable contribution to guiding us in each and every minute aspect of the conference organization. You have played a central role in making OTCon 2025 a reality. We need your guidance in future. Last 1 year, I realized why we use the phrase, once teacher, always a teacher. I would like to extend my gratitude to all speakers, panelists, attendees who have contributed to the success of this conference. Together, we have laid the foundation for a productive discussion, collaboration, and that will undoubtedly shape the future of our profession. I would like to take a moment to extend my special and heartfelt vote of thanks. I will do it in the two phases. I just call my dynamic young team on the stage. I call Chetan, Akshata, Siddhika, Gopal, Shamin, Siddhika, everyone, please. I would like to take a moment to extend my special and heartfelt word of thanks to my dynamic young organizing team, my dear students, now my colleagues. I would like to thank my students, both interns, undergraduate, PG students, as well as all occupational therapists working in Goa Medical College, also the member of Goa branch of Avata. Your energy, enthusiasm, and dedication have been truly exceptional. From very beginning, you have been driving force behind this conference, working tirelessly behind the scenes to ensure that work gets done. You have brought the fresh perspective, innovative ideas, passion for the excellence. Your teamwork, commitment, and professionalism have contributed in the conference. Now it is my privilege to take this opportunity to extend a special word of thanks to the senior, little senior, but not still old, Dr. Parag, Dr. Pooja, Dr. Mahira, and Dr. Priyanka. Please come. To my dear colleagues who have worked so tirelessly behind the scenes to make this event reality. Your dedication, collaboration, unwavering support have been nothing short of remarkable. As a special mention to the, thank you. Please give a round of applause to them. A special mention to the delegates and participants from across country who have joined us for this event. Your presence and participation have truly made this conference dynamic and interacting experience. The exchange of ideas, collaboration, and shared passion for occupational therapy are what makes this gathering so special. I would like to express my gratitude to print and digital partners who have helped publicize and support the OTCon 2025. I would like to take a moment to express our deepest gratitude to our generous sponsor, Platinum Partners, Peachgas Private Limited, and RCM Healthcare Services, government departments, and other partners. While we celebrate the success of this event as an organizing secretary, I wish to extend a sincere apologies for any shortcomings and challenges that you may have arisen during the course of the conference. Despite our best efforts and meticulous planning, I acknowledge that there may have been areas where expectations were not fully met. I take a full responsibility and I want to assure you that I deeply regret any inconvenience this may have caused. I have committed to learning from these experiences and I appreciate your understanding and patience. One thing I assure you that our heart were in the right place, but outcome fell short of our hopes. As we contribute to this conference, let us carry forward knowledge shared, connection made, and inspiration we have gained. Together, let us continue to advance the cause of occupational therapy, advocate for inclusive healthcare, enhance the quality of life for all individuals who need our expertise. Once again, I thank all for being a part of this incredible event. Thank you and have a wonderful days ahead. Thank you. Sorry, I forgot the one name which I really forgot. Prabhakar, please come here. We all of us, rest of people work 50%, and this guy has worked rest of the 50% of the work. So give your, starting from your website, all digital promotion, everything is single-handedly managed by him. All the links, everything. So give a big round of applause to this person. Okay. I'm extremely apologize. Yeah. Thank you. Thank you. Yeah. Now kindly stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you everyone for being a part of this remarkable journey at OTCon 2025. As we move forward, let us continue to collaborate, innovate, and make a lasting impact on the professions and the lives of those who we serve. I look forward to seeing you all at OTCon 2026. Safe travels and good night.